yesterday I was saying there are certain people who work behind the curtain, and Dr. Manivannan is one of them. When talking about the Pilani Birla Balika Vidyapeeth and Dr. Madam Kasturi, she happens to be the principal. And when we were talking about all arrangements and everything, there was a lot of input of Dr. Manivannan. And he has a offer that why not have again in Pilani. Sometimes maybe he has to decide and he has to work out the feasibility and all that.
अभी डॉक्टर साहब मेरे
we'll do sir this year if permitted. If there are no other people, no proposal, then we can have it sir this year.
डॉक्टर साहब सर एक I would like to share जो NDRI है साइंस एंड टेक्नोलॉजी ने एक प्रोग्राम शुरू किया है गति।
हाँ सर।
जेंडर एडवांसमेंट इनटू द स्टेम्स इनटू द वुमेन्स के लिए वो उसमें उन्होंने एक पायलट प्रोजेक्ट जो यूके के साथ उन्होंने डीएसटी ने शुरू किया है।
Okay, sir.
And they have chosen 25 universities all across the India.
Okay, sir.
Including IIT, AIMS, and medical. In every there is no demarcation about the agriculture or something.
Okay, sir.
So out of 25, NDRI is also one of the program, and that's called Gati.
Okay, sir.
So we are actually organizing a women's program to make the actually women's come into the gender. I think.
Okay.
वहां भी एक प्लेटफॉर्म अच्छा हो सकता है ISSRF का पॉपुलैरिटी के लिए क्योंकि यूके के साथ उनका कोलैबोरेशन हमारा सो वी कैन लुक फॉरवर्ड एक्चुअली इफ वी कैन सम वे
वी कैन डू व्हाट आर द एक्टिविटीज सर
एक्टिविटी हमारे साइंस एंड टेक्नोलॉजी को वुमेन्स में इंकरेज करना दैट्स
ओके सर
दैट्स एक्चुअली गवर्नमेंट ऑफ इंडिया प्लान बट इंडिया में इतना डिस्क्रिमिनेशन है नहीं जितना कि यूके एंड अदर कंट्रीज में वहां पे तो डॉक्टर साहब सैलरी आई केम मींस इट वाज सरप्राइज टू मी कि वुमेन के सैलरी भी जो है जेंट्स से अलग होती है यहाँ तो ऐसा कोई डिमार्केशन नहीं है
इंडिया में तो नहीं है सर
ना हमारा तो है ही नहीं वहां पे तो क्योंकि निगोशिएशन बेस्ड होता है ना डॉक्टर साहब तो थोड़ा सा डिफरेंस
तो आप वर्कआउट करिए देव सिंह जी कि वहां ऐसी फिजिबिलिटी है तो इट विल बी ए प्लेजर और कोई जरूरी नहीं कि अपन मिड टर्म एक ही एक्टिविटी करें वी कैन हैव मोर देन वन डिपेंडिंग अपॉन द फिजिबिलिटी एंड ऑल दैट सो वी कैन वर्क आउट द कन्वीनियंट डेट्स एंड दैट वुड बी ए नाइस आइडिया
हाँ उसमें क्या होगा डॉक्टर साहब 25 इंस्टीट्यूशन है ऑल ओवर लीडिंग इंस्टीट्यूशन हम उनको भी इनवाइट कर सकते हैं उसमें और डीएसटी को भी इसमें इन्वॉल्व कर सकते हैं और थोड़ा माइनर हमारे पास कंटीजेंसी है बट ये जुलाई तक की है हमारा भी नेक्स्ट इम्प्रूव अगर करेंगे तो देखते हैं सो आई विल वर्क आउट एंड गेट बैक टू यू सर
चौहान साहब ज्वाइन कर रहे हैं
डॉक्टर अंसारी
यस
we got the CVs of the speakers for the next session.
Good morning sir, good morning Professor Loya.
Good morning sir.
Good morning, sir.
Good morning, sir.
So you would be projecting
good morning,
this.
Professor Handal.
Good morning. Good morning.
Yeah.
You would be projecting the CV in the screen, no?
Yeah.
Sorry.
Yeah.
Okay. Dr. Chauhan, namaskar.
Namaskar, sir. Namaskar.
Dr. Dir Singh, Dr. Chauhan, we were for NDRI one workshop. We were there with you in 2000 for 15 days.
Yeah.
It was a good program there. I have come from Professor Loya's lab that time. In 2000, 15 days that a scientist guest house.
Yeah. We have one guest house.
Yeah.
Dr. Om, good morning and good evening for you.
Good evening, sir. Namaskar. I was just trying to.
Good morning, sir.
Good morning कहते हैं तो आप
Good evening. Good morning.
Sir,
डॉक्टर साहब ये जो पीछे की पिक्चर है ये कहाँ की है सैन फ्रांसिस्को साइड की है
ये actually it's from Washington State basically.
अच्छा, वाशिंगटन स्टेट। ऐसा
West.
लगता है वो जैसे सैन फ्रांसिस्को में वो है ना, वहाँ पे एक पार्क है जो नेशनल पार्क है, वैसे वहाँ भी ऐसा वेरी सिंपल नियर सैन फ्रांसिस्को, look like
Right, they're also right. That is true. That is true.
Nice
Similar to
background,
that.
sir.
Very nice.
It's a good pre-conference chatting, sir, in the morning before we start the conference.
That's what I thought. Let me just
Yeah,
try
yeah.
to see for some time. Then we'll go.
And we have the daily opportunity since 3 days. Daily morning we meet and chat for some time.
I think that's also very nice because
Awesome.
that's the opportunity during conferences, meeting each other and chatting informally, talking about some really certain things which are not still public or not have been published and all that, and activities also. So it's very I think socializing is very important part of these get-togethers.
Yes, yes.
बट स्लोली एंड स्लोली सर, वैसे भी मोबाइल फोन तो लगते नहीं है, तो नाउ दे आर लुकिंग फॉर द इंटरनेट एक्चुअली, वो ज्यादा कभी फोन लग रहे हैं। सो अब वीडियो कॉलिंग पे ज्यादा हो गया है कंपेयर टू, क्योंकि बीएसएनएल का जो है फोन इज ऑलमोस्ट डिफिकल्ट टू गेट द कनेक्टिविटी।
I see. But it's amazing. Technology is so useful. Before this pandemic, people were not using that much, and now in last 2 years, it has like literally everything is online. Very good.
Perfect.
Good level on daily basis, sir. Tremendous improvement.
Present करेंगे to introduce them, and आपको introduce करेंगे साहब, ठीक है ना? आपको इंट्रोड्यूस हम लोग करेंगे, ठीक है ना? तो चेयरपर्सन हाँ वो डॉक्टर मणिवन्नन है। तो पहले जैसे जो कीनोट स्पीकर हैं दुरू साहब को आप कर दें, और उसके बाद to introduce first the keynote speaker, Durusa, and then probably you might prefer introducing Professor Akbar Shah.
Yes, sir. Yes, sir. Yes, sir. That's my privilege.
So I said that do like that, and then alternatively you may arrange.
Okay, sir.
Good morning, Dr. Pradiman.
Good morning, sir. Good morning.
Good morning, Mishra.
Namaskar, sir.
Namaskar.
गुड मॉर्निंग डॉक्टर साहब, वीडियो ऑन करिए डॉक्टर साहब।
Good morning.
Actually,
Good morning.
दिख जाओ।
बहुत लंबे समय के बाद दर्शन हुए आपके।
वही कह रहे हैं, मिश्रा जी से काफी दिन हो गए बात किए हुए। हमारा और डॉक्टर मिश्रा का जो है पेपर शेयरिंग होता रहता है। He used to send his achievements, so we are very happy to sometime. It's excellent work.
I think he's doing excellent work. Sometimes I look at his postings on the LinkedIn.
Seeking your blessings, sir. Thank you.
You're doing excellent work.
Blessing का वीडियो ऑन होगा तब मिलेगा।
Sir, he is our product. We are proud of him, sir.
I think after meeting in this particular meeting, I'm thinking like next year, if it is in person, I should come there and we should meet in person.
Dr. C.V. Rao is okay now, sir. Because I could not.
I didn't get connected for a while actually, so I'm not sure how he's doing, but he must be doing okay.
Sir, Jaipur also long time now, sir. It was 2012 last time we conducted, sir.
Oh, I see. It has been a long time. Yeah. I didn't have any contacts for many years.
I have a
actually.
contact, so we are actually, but since last few months, actually, I could not.
I see. So then you know much more recent things.
Dr. Manik, good morning, sir. Dr. Manik शायद अभी है, हाँ तो join तो हुआ है.
Good morning, Deer Singh.
Good morning.
Good morning.
Good morning.
Good morning, Dr. Manik, sir.
Thank you, Dr. Chauhan.
Good morning.
Oh, that's some probably street hawker is why is this called?
I'm sorry.
कॉलोनी से शायद स्ट्रीट हॉकर की जो है ना आवाज आ रही है. That's the really sense of the Indian जो है स्ट्रीट हॉकर्स जो कितना कन्वीनियंट होता है. देखो ना इंडिया में सामने आ जाते थे सामान लेने, अभी सब बंद हो रहा धीरे.
And our this thing audio is so sensitive.
Yeah, correct.
That even little we open our mouth and then we can see that before we speak out, it appears on the screen that you are going to speak. जो इस आज के है ना डे 3 उनको भी भिजवा सकते हो. All are requested to please join. We are just
सर उसमें जो है बायोलॉजी में डीएनए एंड फिजिक्स में लेजर is most commonly used in public उसमें. Laser application is very now in medicine, in any sector actually laser is going to.
Correct. That's yeah, quite a bit. It's entering in the right and multiple areas.
Even in war, actually, laser is very much used now.
That has been actually, that's where it starts. Normally, a lot of times when we get technology out, it is already been used there and has been allowed to come out of that. And that goes under like a lot of secret research. So that's why by the time it becomes public, before that, it has been already used there. So in general, it comes there first.
Good morning, sir. Dr. Professor Akbar sir.
You are on mute.
Unmute है सब.
So, morning, Deer Singh. Good morning, Manivarnan.
Morning, sir.
Morning, sir.
Morning, Professor Lohia. And sir.
Good morning, sir. Good morning.
Right.
Morning, everyone. Good morning.
Good morning. Very good morning to all of you.
Good morning, sir.
Good morning. Nice to see you all again.
Same here.
Oh.
Good morning, madam.
Good morning, Dr. Manivannan. How are you?
Fine.
Hello, good morning, Dr. Paru.
Good morning.
Good morning, Dr. Hundal.
How are you?
Good morning, sir.
Good morning,
Namaste,
Professor
Kamboj,
Kamboj,
sir. Good morning.
Good morning, sir.
Good morning, Dr. Madan.
Good morning. Lohia sahab, good morning.
Good morning, sir. Good morning.
नमस्कार सर, सबको नमस्कार. कंबोज साहब को नमस्कार, मदान साहब को नमस्कार.
सबको नमस्कार.
Namaskar, sir.
Namaskar, sir.
Oh, how are you? All fine?
All fine, sir.
Morning, sir.
Good morning, Dr. Sharma.
Good morning.
You are mute.
Good morning,
Today
Dr.
you are logged in from Mrs. Mukta Sharma's ID, Dr. Sharma. Happy to see you at home.
Yeah, I am at home, so I just.
Good morning,
sir.
That's why you look more fresh. Hi, Pradeep. Good morning.
Good morning. Good morning. I'll just change it. Thank you.
Good morning, Sarmaji.
Good morning. Good morning, sir. Good morning, everybody.
Good morning, Dr. Madan.
Good morning. Good morning.
Set.
Good morning, Pradeep. You finish your breakfast. You're mute. You finish your breakfast. Not yet ready. Enjoying Sunday.
Well, so I had my gardening in the morning. I had my walk in the morning, and now you guys. Yeah.
How are pets doing?
Very good. Yeah, absolutely great. Yeah. So, how are you, Taru?
All fine. Good. Thank you so much.
So, good morning, Professor Lohia.
Good morning. Very good morning, sir.
Good morning, Professor Ansari. So, all great?
Good morning. Good morning. Yeah. All set.
Good.
Good morning, everybody. Good morning, Professor.
Good morning, Dr. Naqvi.
Dr. Taru, namaskar.
Namaste. Good morning, Dr.
Good morning. Good morning.
Good morning, sir. Hi,
Good morning. Good morning, Dr.
Good morning.
Dr.
Good morning, sir.
Pradeep.
Good morning, Dr. Rita.
Yeah, good
morning,
morning,
sir. Good morning.
Good morning. Good morning, everyone.
Good morning.
Good morning, Dr. Hundal. How are you, Dr. Hundal?
I'm very good, sir. Good
Congratulations,
morning.
Dr. Hundal. Congratulations.
Thank you. Thank you.
आपने बताया ही नहीं, हमने तो
Congratulations for
न्यूज़लेटर पढ़
what?
के पता किया. न्यूज़लेटर पढ़ी है तो आपको भी पता.
A very good morning to all of you. On behalf of ISSRF team, I welcome you to the third and last day of this exciting international conference on reproductive healthcare and 32nd annual meeting of Indian Society for the Study of Reproduction and Fertility, organized by ISSRF, University of Rajasthan, Jaipur. I am sure that
I think the voice is lost. We have lost the voice.
Yeah, no voice.
Yes, we lost the voice.
Nidhi, can you hear us?
Hi, Malini. Good morning.
Yeah, we appreciate your patience, sir. She'll get back. Yeah, thank you.
You're mute, Malini.
Hi, everyone.
Good morning.
Good morning. क्या चल रहा है?
Dr. Sharma, namaskar.
Good morning, Dr. Lohia, Dr. Sharma.
Namaskar, sir. Namaskar, Dr. Madan, sir.
Namaskar.
Good morning, Dr. Rita Singh. Good morning, Dr. Madan, sir. Good morning, Dr. Akbar Shah. Good morning, sir.
Good morning, sir.
Very good morning.
Very good morning. Right. So you are relaxed today, Sunday?
Yeah, yeah, I am at home.
At home.
Yes. How are you, sir?
I am doing good, sir. Very good. Yeah.
Great.
So how is your son doing? How is your daughter doing?
Yeah, everybody is fine. My daughter was here. For this month, she left.
Yes, that is the best way of saying everybody is fine.
Yeah, everybody is fine.
You should keep smiling and you are fine.
Yes. Thank you, sir.
Dr. Akbar Shah, Dr. Sharma's daughter,
Yes.
made a very magnificent home.
Yeah.
Here. I
Thank
was
you.
fortunate enough to see a couple of glimpses of that.
Thank you, Daru, for the comment. Very nice.
sharing your screen from the very good morning to all of you. I think there was some internet issue. So I'll start from the beginning. So a very good morning to one and all. On behalf of ISSRF team, we welcome you to the third and last day of this international conference on reproduction healthcare and 32nd annual meeting of the Indian Society for the study of reproduction and fertility organized by ISSRF, University of Rajasthan, Jaipur. So I'm sure this day is also going to be exciting as last 2 days, and we hope to see your participation. So we will start with our first oration with Professor S.S. Guraya Memorial Oration. And for this, the chairpersons are Dr. S.S. Hundal, who is Professor and Head Department of Zoology at Punjab Agricultural University, Ludhiana. And Dr. Hundal's research interests are on animal physiology, environmental contaminants, eco-friendly remediation of agro-waste. We welcome you, sir. And the next chairperson for this session is Mrs. Surinder Guraya, wife of Professor S.S. Guraya. And I think on their behalf, her son is joining. We welcome you, sir, and we really appreciate you that despite of time differences, you are able to join. And the next chairperson for this session is Professor P.P. Mathur, who is Vice Chancellor, Birla Global University, Bhubaneswar. But due to some reason, he's not able to join it. So over to you, sir, for chairing this session. Thank you, and we welcome you all.
Thank you for this honor. I also welcome Dr. Gurmeet, the elder son of Dr. Guraya. Before I request the speaker, I would like to say a few lines introducing Dr. Guraya, though many of us in the organizing committee and otherwise know of them, but there are many students and young scientists who would like to know, because Dr. Guraya was an Indian biologist who is known for his contributions in the field of reproductive physiology and developmental biology. Amongst the many awards and honors that he had, he was elected fellow of the Indian National Science Academy, National Academy of Sciences, National Academy of Agricultural Sciences, and he was awarded by CSIR for the Shanti Swarup Bhatnagar Prize for Science and Technology way back in 1973. He did his bachelor's in 1954 and subsequently 56 and 59 he completed his master's and doctorate from the Punjab University, Chandigarh. Then in 65, from 62 to 65, he went to United States for a postgrad for a PDF, joining back as pool officer, then as a reader at Udaipur University, now known as Mohanlal Sukhadia University. And in 1971, he joined as professor at Punjab Agricultural University, and he continued there until he retired in 1992 as Dean, College of Basic Sciences and Humanities. As his legacy, he did pioneering research in the correlation between the structure and function of reproductive organs and elucidated their evolutionary aspects, with special emphasis on the ovarian and testicular compartments. His research publications are like 215 research papers and over 10 books, and he was associated with national and international organizations. With this little brief, ICMR also awarded him with the Basanti Devi Amir Chand Prize. He was also director of the Advanced Center of Reproductive Biology, awarded by ICMR. His biographical brief has been published in the 40th volume of the Memoirs of Fellows of the Indian National Science Academy in 2013. We were deeply grieved when he left us in July 10 years ago. So with this introduction of Dr. Guraya, I will now introduce Dr. M.S. Chauhan, whose research interests are in assisted reproductive biotechnology, IVF, embryonic stem cell, and animal cloning. He has established the IVF and cloning procedures and technology and produced, because of this, there were production of several calves. He is widely and variously awarded and decorated as the Fellow of the Indian National Science Academy, Fellow of the National Academy of Science, National Academy of Agricultural Sciences, National Academy of Dairy Sciences, Rafi Ahmad Kidwai Award by ICR, Dr. P. Bhattacharya Award, Lifetime Achievement Award in Animal Sciences. ISSRF has awarded him with the Dr. Lavsetkar Award. Then he has outstanding contributions in animal sciences and other awards by DBT and the Professor G.P. Talwar Middle Career Scientist Award, again by SSRF. He has 160 original research articles in peer-reviewed papers, 9 reviews, 7 books, and 17 book chapters. I invite you, sir, Dr. M.S. Chauhan, presently Director cum Vice Chancellor, National Dairy Research Institute, Karnal, to present his oration lecture on recent advances in stem cell and animal cloning techniques. Dr. Chauhan, please.
Okay, thank you very much. And Honorable Chair, Professor S.S. Handel, and also the son of Madam Surinder Guraya, and son of the Professor Guraya. As it has been said that Professor Guraya was also the mentor when I joined, to me, when I joined the PAU Ludhiana Zoology Department in 1986. I worked with him in his lab, and that time he was the Dean of the Basic Science. But what I learned from him that he was a very dedicated, very hardworking person. Even after the administrative, the job, after 5 o'clock, he used to come in our laboratory, small, the animal house, and there he used to sit there up to 8:30 sometimes, or sometimes 9 o'clock. So every day we used to meet him and then learn all these things. He was very motivating, very inspiring person. And we know that because of his always like his work, which has been already elaborated by Professor Handel, that the work which has been done by him in the ovarian function, in mammalian ovarian function, and the book which was published by him is Ovarian, the biology from the Springer Bernlag, and also the testicular biology in mammals. And so he was really encouraging, he was really motivating factor to all of us. And because of its fundamental and basic research, which we have learned from him, we were able to establish something in terms of the assisted reproductive technology in large animals. But before that, I would like to thanks to Professor N.K. Loya, Honorable President of ISSRF, Professor Ansari, and the organizers of this conference, ISSRF-2022. So my topic, which is here, is recent advances in stem cells and animal cloning technology. I will elaborate the work which has been done by us in our laboratory. And after getting the knowledge of the basic and fundamental knowledge from Professor Guraya, I joined NDRI in 1987, and then subsequently I joined the lab of Professor M.L. Madan, who is also the witness of this deliberations today. And there that time there was the work which was being done in case of mice, and some part of the work which was being done in case of the human being. But as far as the large animals is concerned, particularly buffalo, it was not established much. And then so this IBF, which was initiated by us in long back, where we were facing a lot of hurdles there, like in terms of through this oocyte maturation process initially. And then subsequently the maturing them and fertilizing them through in vitro and getting them to the 4 to 8 cell stage. It was very difficult time during that period because many factors were responsible for the culturing of the oocytes. And what we have observed, this block at the 4 to 8 cell stage in case of bovine, particularly in case of buffalo. We struggle much and we have done many basic and the fundamental changes of the media and the culture conditions And then subsequently, it took us another 5 to 8 years to achieve the morula stage. And then from morula, again, it was very difficult to reach to blastocyst stage, because in case of large animals, we believe that unless until you are not getting blastocyst, so you cannot say that your embryos are viable. And not only that, you have to get them transplanted to the recipient animals. And once you get the calves, then you can say that your system of IVF system is accurate. And so whatever your target is there, you can achieve. So the other focus, what we have done is in between, a lot of publications came, not from the other part of the country, but from our lab too. And where we have changed many things in terms of looking all these factors, yes, the physiological factors and the genomic factors. But what we have, our focus was to develop a simple protocol for culture system in case of bovine. And this is one example. We can see that where what we have done is we have taken the oocytes, which was surrounded with the cumulus cells, and then developed them to the blastocyst stage. But you see that here the maturation and subsequent the development to morula and blastocyst stage was very, very low. And here, like what we have done is by adding the simple oviductal epithelial cells, we believe that because if you give the in vivo environment outside the body under in vitro system, so probably you will have a maximum the success rate here. And you can see one example here where we have taken this oviductal epithelial cells and then culturing them with these oocytes, fertilized egg, and then develop to the blastocyst stage. So this was a very simple protocol which has been initiated. Then subsequently we have done all these the other media tests in our laboratory, and also some of the synthetic oviductal fluid which we have prepared particularly for the buffalo oocytes and for embryo the development. And you can see that after doing after using this different type of medium and then modifying them subsequently, we could achieve the morula and blastocyst significantly high by using the SOF and TCM19 supplemented with the fetal bovine serum and the bovine epithelial cells. But here you see that if you compare with the human beings, so in case of human, you no need to go to blastocyst stage. You have to have only 4 to 8 cell stage where you can go for implantation to so this is again in case of the large animals, it become a very tough for us to develop to the blastocyst stage. And still the success rate, if you talk the success rate, it is around 40%. But nevertheless, we can have a number of embryos on the bench, which can be subsequently utilized for either for basic and fundamental research, and in our case, you can use for the applied research. Where you can have a number of calves produced, and these are the calves which has been produced, and of course under the leadership of Professor M.L. Madan, he was there. He was here in our laboratory as leading this program. We went little further where we have done the OPU technology there in case of the cattle, the sahiwal, and where we were understanding also to how to get the oocytes from the live animals through by watching under the ultrasonography, and also then oocytes recover. This here is a very small example where we have taken this initiation, and then in 2010 we were able to produce the first the OPU IVF calf in India wholly, and it was from the indigenous cow. And then now later on, this technology is being utilized in everywhere in India now. Over thousands calves has been produced using the OPU and IVF technology. Then the other part, which was here, this oocytes the cryopreservations, which was very important aspects, because we were getting maximum oocytes from the slaughterhouse, and where the limitations again was that whether these oocytes can be preserved further. And because besides the research on bovine, we were looking forward to to establish the basic and fundamental aspects of research in case of the mammalian oocytes. And then, because you know that once this protocol system is well established, so it can be used for the creation of the oocyte bank, and also the oocyte preservation for the patient with the ovarian hyperstimulation syndrome in case of human being. And also the oocyte donation program, which can be used for human, and also they prevent fertility loss through the surgery. And in many cases, where the patient are there, the cancer patient, they want to preserve the oocytes. So these were our aim. What we were able to establish the conventional method, and then subsequently enhancing them to the vitrification method, and where you can have just to have the egg loaded in the straw, and it can be directly plunged into the liquid nitrogen to avoid the crystal formations, eye crystal formations. But even then, after doing all these things, we were able to establish this by getting the blastocysts. And also some of the blastocysts we have implanted, but none of them developed to the calf, and this is again limitations here. But however, the blastocyst production was around 18% from the oocytes. But we have done the work by using the embryos, where we could achieve the calf the production by using this vitrification method. So a lot of work is need to be done in this area. As I said, that we were getting very frequently number of blastocysts through in vitro the fertilization in case of bovine, in case of buffalo particularly. And what we have initiated this advanced assisted reproductive technology further by utilizing these blastocysts, and you can see that how to get these for the stem cells, for the embryonic stem cells, and you can see that this is the blastocyst from the mouse, and you can see the inner cell mast cells, which is clearly visible. You can isolate these inner cell mast cells and then culture further to develop the embryonic stem cell line. But in case of the buffalo, again, it became a very difficult to visualize clear-cut inner cell mast cells, but we have used many methods, which was, and some of the methods which was already established in outside, but because of the high granular lipid granules are there in case of buffalo, it became very difficult. But now over a period, by using the different system protocol, we were able to develop the embryonic stem cell lines. So this is the method where you have inner cell mast cells. Then from there, you have to separate them out and then culture for long term several passages. And we can say that even after 40, 45 passages. And by seeing all these factors, whether they are still maintaining the stemness, then you can say that these are the embryonic stem cells. Of course, these some of the factors which are responsible for developing the embryonic stem cells, LIF, FGF, and BMP4, and these factors which we have studied. And because these, we have to see that how we can maintain the culture conditions that so that these stem cells, embryonic stem cells, should not be differentiated. So this is some of the immunocytochemical analysis what we have seen by of taking these embryonic stem cells over 173, 75 passages. So you can see this expressing all these pluripotent markers OCT4, NANOG, and SOX and FOX, and these markers were well established. And now, after doing all these things, we were able to have 5 embryonic stem cell lines with us. So these are the stem cell lines which was which can be utilized for further basic and fundamental research, of course. And but what we have seen that these the factors OCT4, NANOG, and SOX are very, very important for core regulatory network of the embryonic stem cells. And after doing these things, after taking them further, and also differentiating them with just adding the retinic acids, formation of embryonic stem cells, and also differentiating them to the epithelials like and fibroblasts type of cells or neuron type of cells. So we have now 5 embryonic stem cell lines with us. Anybody require those cells, so can be provided to them. We have seen that further whether, because these are the pluripotent stem cells, so maybe they are useful for the clone production, because we need to have undifferentiated donor cells. And here we have used this first, the embryonic stem cells, and then we produce clone animals, Garima, and she is now as the mother of 6 the calves. So these were the basic and fundamental research. In between, what we have done is to see that whether these pluripotent stem cells, embryonic stem cells, can be utilized for further transfection of the GFP of the gene, which need to be utilized further for making a transgenic animals. So we have seen this, that transfection was there, and in terms of the somatic cells, you can see that these cells, then embryonic stem cells, which were subsequently developed to the blastocyst stage. And these are some of the very, very important factor, because what we have done is change the retinic acid. By using the retinic acid, we have developed to them them like the germ cell state. They are different, I think. Okay, so what we have used is transfected them to the cell lines, and these cells were subsequently used for development of the embryos. But in this case, where you can see that these transgenic cells works fairly well here. You can see that this as compared to the non-transgenic. So this is well established protocol here in our laboratory, where we can have transfected cells produce transgenic embryos. So these then the embryonic stem cells, because now we move further, where we have studied further in terms of whether these embryonic stem cells can be developed to the sperm type of cells or oocyte type of cells or germ cells. And this is the one study which has been carried out in our laboratory by Dr. Syed Saha. And here you can see that these are the cells which was showing these some sort of the 2 cell type of embryos, and then 4 cell type of embryos by directing them by leading towards the embryonic type of cells. And you can see that further the blastocyst type of embryos. So this is the observations what we have made there, and this by doing this we could get this blastocyst, the hatch blastocyst. These are some of the hatching stage of the blastocyst, and we have checked all the parameters which was responsible for depicting the germ cells, and all like nano, VASA, and all the genes. And we believe that these stem cells can be directed to the blastocyst stage, to the embryonic stage, to the germ cell stage. And this is a very important aspect, because tomorrow we have a nowadays we observe that around 15 to 20% infertility in case of human being. And this type of study where we have embryonic stem cells can be differentiated to the germ cells, and which can be subsequently utilized for transplantation or for the overcome the infertility. We have also done in our case here at Karnal by taking the spermatogonial stem cells, where you can see that spermatogonial cells, this is seminiferous tubules, where you can see the spermatogonia and spermatocytes and spermatids. And there are just a very few number of these cells available, and it is believed that 0.0 to 0.03% adult mouse cells are the embryonic stem cells. So maybe in case of the large animals, the amount may be same. But these stem cells can be utilized further and can be enriched further, which can be utilized further for implantations, and which will subsequently take part in the spermatogenesis and produce embryo. So this is a method what we have done in case of the large animals. In case of the buffalo, taking out these testes and then taking out the seminiferous tubules, and then do the spermatogonial type of cells, and then subsequently enriching them, and then maintaining the 80% of the embryonic, over 80% of enriched spermatogonial stem cells, which was showing all the markers which are for maintaining the pluripotency here. So these are the markers which have been seen, and similar type of work has been done by many part of the other this western part of the country. Here you can see that these cells are responsible also the expression of the mRNA, and which is necessary that the place and TAF and Thai mRNA, if they are showing that, you can say these cells are having a capacity of self-renewal activity, and you can say that these cells are the embryonic, the spermatogonial stem cells. In our lab, because we were dealing all the assisted reproductive technology, and then so we have initiated the work with the animal cloning, and there why we need animal the clone animals. This is just little away to human research, but here you can see that the availability of the semen, available semen for artificial insemination program is limited to us, and so with this available semen, you can have only around 100 million animals can be inseminated, but because we have a breeding population of female is over 133 million, so we need to have more semen, and therefore the cloning technology is required, because the availability of bull for the semen is also very limited. And we can see that today in case of buffalo, around 700, 800 quality, super quality or superior bulls are available to us, and these bulls cannot be used for, may not cover the whole population of the breedable female. So therefore, we need to have a focus on the development of the quality or superior quality bulls, and therefore this technique has been initiated at NDRI. Of course, in long back, the work which has been already done by Wilmette and group, where they have used the macro manipulated system, and and by producing the dolly, the sheep dolly. But you can see that this is a very tedious, and not only it requires this the expensive equipment, but it also requires the skill, manpower. But what we have done is we have simplified this by doing this handmade cloning, where we have a mature oocytes, and then mature them further for little more time, around 28 hours in vitro, and where you can have extruded polar body here, and just near to the polar body, one can have the metaphase 2 stage here, and if you cut this, you will remove this nucleus, and similarly, this the ooplasm can be used here for further, for the base of the donor cells, which was obtained from the high yield animals, and it is like just removing the yolk from the boiled egg, and once you have a removed yolk, so 2 yolk can be used here, and by using the donor cells here, where you have a somatic cells and then develop them to the blastocyst stage. Of course, it looks very simple, but of course, a little effort is required in terms of the fusing them, reconstructing them, reprogramming them, and developing to the blastocyst stage. And these are the typical blastocyst stage embryos produced from the through the handmade cloning. You can see the embryos, and they are more or less phenotypically same, but there some of these cells are in the embryos are very like they arrested in a smaller stage. So these are the work which has been done. Of course, the team which was responsible for this, Dr. Singla and Dr. Manik, and of course initiated by Dr. Madan initially long back, and we were able to establish the first ever cloned buffalo calf in the world. So these were the well recognized, not only in India, but even in New York Times, which we got a satisfaction highly. We were fully satisfied with the work which has been carried out by us in India at NDRI. Of course, there are many factors responsible for the factors, the somatic cells factors, technical factors which are responsible for generating the quality embryos, quality that to the blastocyst stage, which can be used for implantation through embryo transfer. And then also some of the factors, electrical factors, and so many factors like the media factors is also very important. And then, so after taking care of all these factors, one can develop them to the blastocyst stage. And these are the, say for example, the somatic cells factors like A cell cycle, and also their epigenetic modifications are responsible for generating the quality embryos to the blastocyst stage. And these are see that also the cell stage. If you are taking the cells from the fetal, so this blastocyst production you can see here. And if you are taking from the higher age, so the blastocyst production will be low. But at the same time, you have to check that whether they are viable blastocysts or not by putting them to the recipient animals. And if you get the calf, so you can say that these the blastocysts which were generated from the clone animals, through the cloning, through the hand-guided cloning, they were viable. And this is the one example. You can see that initially the success rate was very, very low, but after it was in 2010 where we were able to establish the Garima 2 as by using the embryonic stem cells, and you can see that it was the 14 recipients which was implanted to 14 embryos which was implanted to 6 animals, and 1 calf was born. This was from the embryonic stem cells. So probably the embryonic stem cells, because they are the pluripotent and they have a stemness, they are undifferentiated cells. So we could get this first the calf produced from the embryonic stem cells. But now we were using very frequently somatic cells, and not only somatic cells, somatic cells from the dead the animals also. And we were able to produce the calf here very routinely at NDRI. But as I said, the suicide factors and also the reprogramming is very, very important, because we have seen that today in our lab, two scientists, Dr. Naresh Lokar and Dr. Manoj is working, and they we used to have a discussion that how we can achieve more the embryos and then subsequently more the calf born. But we have checked all these factors, and now we were able to have the normal animals, and by doing all these the things like taking care of the epigenetic factors, reprogramming or epigenetic modifiers we are using, also taking care of methylation pattern, which is very, very important for getting the normal embryos. Again, many times we got a limitation in terms of once we have the final calf about to be delivered, but because of the sometimes the little like the problem in case of recipient or stillbirth, we lost many such calves, the clone calves. So this is the limitations. Again, we are taking care of these aspects. This is one example in front of you that where we have a reconstructed oocytes developed to the embryos, clone embryos, and then you can see that by using the different media, just CR2 medium and then SOF and this medium, you can see that this success rate in terms of the blastocyst production is also here. You can see the low, and in case of the basic media, but we were able to establish these RBCL media, which can give us the around 40% blastocyst. But again, the limitations in terms of the getting the ratio of the inner cell mass cells and the trophectodermal cells. And because of this ratio, sometimes we get this large calf syndrome. And this is, we now, because of the fundamental aspects, we have checked here the basic, medium, and all these things by taking these additives, because what we are doing earlier that we were using the fetal bovine serum, and which was, we were not knowing that how much components are inside of this fetal bovine, the serum. So we have checked this, and now we are getting the very normal type of the calves. In between, we have done all these research in terms of taking care of the trophectodermal cells and also the inner cell mass cells. And what we have seen that these cells are sometimes get irregular while doing or while culturing or developing them to the blastocyst stage. But then subsequently we took all these parameters into control, and here we have done some of the work, like where we have taken the cells from the ear cells, from the IVF embryo, from urine, and
Dr.
from
Chauhan,
the
you will please try to conclude.
Yeah. Sorry, but within this, and these are like all these all these factors which was responsible for generating the quality embryos. We have taken care of this, but still a lot of work is required, because today the success rate is very low, around 6% success rate we could get in terms of the delivery of calves if you use the 100 embryos for the embryo transfer. So here we have done, as I said, that we have taken all these cells, and also this is one example where we have used the valuable wool which was dyed 10 years before, and from that wool we were able to produce the calf. And what we have done is we have taken the somatic cells from the sperm which was available with us, and these somatic cells produce the same calf, and probably this is going to help us to have a further quality bull reproduction. Also, this can be used for the conservation of the animals, and this is one example which has been done here in case of the wild buffalo, which was we have ASA, we have produced the PASA through the cloning. Many such calves, clone calves, have been produced by us. Today, we can say that 24 calves which has been produced at NDRA canal, and also the similar is this technology has been extended to the Central Institute for Research on Buffalo. and where the from one single donor animals, 7 clone calves was produced by them. Anyway, thank you so much. And this is the team which was responsible for doing all these things. Of course, the initial mentorship of Professor Guraya, I can say here, because he was the person who taught us the oocytes and sperm and spermatogenesis and oogenesis and all the fundamental and basic aspects, histology and histochemistry of oocytes and sperm. And also then Dr. M.L. Madan, who has taken this initiation lead by producing the first IVF calf and then giving us this opportunity by a very good laboratory facility with all these the scientists and the students. And my friend Dr. Manik is also joining here. So this is Dr. Manik, Dr. Palta, and Dr. S.K. Singla, of course, Dr. Manoj, and then Naresh Logal is there. They are working in this lab. So we are looking forward. Besides this applied type of research, we have generated the basic and fundamental aspects of these stem cells, the spermatogonial stem cells and then embryonic stem cells, and all these like the factors which are responsible for development of the embryos under in vitro system. Thank you so much, and thank you to the Professor Loya and Honorable President of ISSRF and Professor Ansari and the organizers of the ISSRF. And thank you so much for your kind attention.
Thank you, Dr. Chauhan. You have very well elucidated the role of stem cells and the recent technologies, because as you have said, this is very important, which has to be translated so that it reaches the farmer's doorstep. You have updated everyone on this new technology. I thank you very much for your very widely researched and well-presented talk. So now back to you, Dr. Loya.
Thank you so much, sir, for chairing the session, and thank you to the speaker for giving a wonderful talk. We'll move ahead to our next session, which is on fertility preservation and ART. And the chairpersons for this session are Dr. Bharti Malhotra, Senior Professor, HOD Microbiology, SMS Medical College, Jaipur. Dr. Bharti Malhotra is first to start molecular diagnosis lab in state, regional reference lab for meningitis, first to detect Zika in state and investigate first outbreak in country. And that's how I have met ma'am at BISR, Jaipur. She's first to start COVID testing in state and SARS-CoV-2 NGS sequencing. Almost 5,000 sequencing has been done. Welcome, ma'am. And the other chairperson for this session is Dr. B. Manivannan, who is Vice President, Plant Operations and R&D, Vaccine Life Sciences, Himachal Pradesh. Dr. Mani has technical capabilities on strategies and regulatory requirements for lab to launch product deliverables of pharma and biotech products with a specialization for vaccines. I welcome both the chairpersons and I request you both to please chair the session. Welcome, sir. Welcome, ma'am.
Thank you, Barkha. Thank you, organizers, for inviting me. And I would really appreciate Dr. Loya's, persistent efforts to enlighten us with the latest science. And thanks a lot for being part of inviting me as part of your scientific community. So I'm really pleased to introduce Professor Durusha. She has many fellowships to her credit. She has the Royal College of Obstetricians and Gynecologists. She has 15 orations of various organizations. She was the first to get the FIGO Merit Award, the Black Swan Award, the Mahatma Gandhi Award, and the OP Recognition Award. So it's really an honor to have her with us to deliver her talk on does luteal support differ in frozen ART cycles. Over to you, ma'am, and thanks for being here with us.
Good morning, everyone. And first of all, I'd like to thank ISSRF President, Professor Loya, and Secretary General, Dr. Sharma, for having invited me to this very beautiful conference. I want to thank everyone for all the scientists, for all the work they have done, which has helped us clinicians in doing what we can do for our patients. And I think there's a little bit of a area which I'm going to cover related to IVF, and that is something which is going to be, sort of talking about how we use your technology into our clinical practice so that we can absolutely take it further with our patients. So over to the presentation. I'm speaking from an iPad because I'm not in the country. I did not carry my laptop, and I've requested the organizers to help me to share the screen so that I can have control over my presentation. So I'm not able to see my presentation.
Wait, just a moment, ma'am.
Yeah.
We are sharing the screen.
You're sharing the screen? Yes.
Yes, ma'am. Just
So
one
should
minute.
I stop share?
Do you want us to share, or do you like?
No, I have shared. Just a minute. Let me share it myself. Okay, you can stop sharing.
Sure. Okay, sure.
Okay, can you see my screen?
No.
No, not yet.
Now?
The share screen.
I'm sharing the screen. Can you see it?
No.
Not yet, ma'am.
Not yet.
Just give me a minute, please. Can you see now? I don't know why it's coming through.
Ma'am, you want us to share?
Okay, you share it. Let me see. Can you see it?
Yeah.
Okay.
We have started now.
I'm not seeing it. Okay. Okay, can you see now?
Oh, there is a screen, but is it the slide of yours?
I'm going to, I need to have the control if you don't mind. Can I have the control?
Ma'am, we have, but yeah, if we are sharing it, we can only change it.
No, I would like to share the content and I would like to have the control, please.
Ma'am, I'm sorry, I'm afraid we may not have those privileges set up here. You may simply request us to move to the next slide. Then we can do that for you.
No, I'll sharing my screen and I'll control it. You can leave the control, please.
I mean, that is what, ma'am. I think we set a kind of an option here, making multiple participants can share simultaneously, and we were wondering, why you couldn't share your screen. We could not see anything. Yeah.
Can you see it now?
No, I'm afraid. I'm sorry. No. Yeah.
Okay, then you can share it, please. I don't know why you're not able to see it.
We request the organizers to keep the control. Please.
We are sharing.
Tell me when you're ready, please.
This is ready. Start.
Okay. I'm going to be speaking on does luteal support differ in frozen ART cycles? And the areas for discussion are frozen thawed embryo transfer, the role of progesterone in luteal support, optimizing luteal support in FET cycles, and evidence-based recommendations at the end of my talk. Now, if you look at what's happening today in the field of assisted reproduction, initially way back in the 90s, we had a lot of fresh cycles which were ongoing with with pregnancy rates which were remaining around, between 2017 or so, around 20 to 25%. And there were a large number of multiple pregnancy rates which were happening because a lot of embryos were being transferred. But at the same time, because of the advances in the scientific field of vitrification, we started using rapid vitrification for freezing our embryos. And then we started getting great results so that the pregnancy rates got higher with frozen cycles as compared to fresh cycles. And the multiple pregnancy rates started getting lower only because when the rates got lower was because we gave this option, gave us a chance to put in a single embryo transfer. It helped to reduce the ovarian hyperstimulation, which is usually associated when we do a fresh cycle where we do ovarian stimulation. And invariably when we do the ovarian stimulation, because of the large number of follicles which are growing, there's a higher estrogen level and the endometrium starts growing faster. And there's an endometrial embryo asynchrony which develops, which does not allow good pregnancy rates or good success rates. And therefore, we need to put in the embryo actually at the right time, wherein the endometrium may be overdeveloped, the embryo is less developed, giving us those loss of success rates. And hence, with the vitrification, we earlier had slow freezing, which didn't give us the great results. But then when vitrification came in, we had freeze-all rescue as a rescue strategy, because whenever we found that the embryos were formed, but the endometrium was not ready, we just froze all the embryos, stopped that cycle, and converted that cycle into a segmented cycle where we did the embryo transfer in the next cycle. But since we got such great results that now it has become almost in many clinics, a universal freeze-all policy, especially in patients with polycystic ovarian syndrome, where we do get a larger number of embryos because of, even though we may stimulate less, we still may end up with larger number of embryos, and therefore we tend to freeze them before we transfer them in the next cycle. Now, we also know that progesterone is responsible for the window of implantation. That is the time when, between 5 to 7 days after ovulation, that progesterone is at its peak. And usually it's at a peak of about 10 nanograms per ml in that luteal phase, which is the window of implantation where the endometrium is so well developed and the embryo can implant itself. And hence, we also know that in the fresh IVF cycles, the endogenous progesterone is definitely lower or deficient, because when we use GnRH agonist and antagonist to prevent a premature LH surge, there is inhibition of LH secretion, and therefore there is a deficiency of progesterone which is released endogenously. And hence, we need to use exogenous progesterone to achieve success in assisted reproduction. The luteal phase, if you look at it in a fresh ART cycle, where you're using a natural cycle when there's only a single follicle developing, the level may be up to 200 picograms per milliliter. But when in an ART cycle we stimulate, we get multiple follicles with estrogen levels going between 1500 to 3000 picograms per ml. And this progesterone insufficiency, which occurs in ART cycles, occurs due to mainly 3 reasons. As I mentioned earlier, agonist and antagonist use. Second is because there are a higher amount of estradiol into circulation, it suppresses the FSH and LH. and then it reduces the stimulation to the corpus luteum, thus reducing the secretion of progesterone. At the same time, when we do an ovum pickup, we are aspirating out the granulosa cells, and therefore there's less of a corpus luteum mass, which definitely leads to a diminished amount of progesterone in circulation, leading to a luteal phase insufficiency, and therefore sometimes may be the reason for causing infertility. Hence, we know that the luteal phase in a natural cycle versus a stimulated cycle is a little different. In a natural cycle, the progesterone levels may go up to 10 nanograms per ml for good implantation to occur, whilst in a stimulated cycle, the levels may go up to 30 to 50 nanograms per ml in order to get a good response or a good success rate. So the best outcomes or the strategies which we use to improve our outcomes when we are focusing on the luteal phase is that besides looking at the endometrial embryonic synchronicity, we need to do optimal timing of the embryo transfer. We need to prepare the endometrium in the best possible way, and we have to optimize the luteal support. And this is one area where there's a lot of controversy. We still don't have a consensus on what really is the best support for our patients. If you look at the luteal phase support for fresh ET cycles, the Cochrane database looked at almost 94 randomized controlled trials with 26,198 women, wherein we found that the HCG or progesterone given during the luteal phase definitely helps to improve the live birth rates or ongoing pregnancy rates when compared to a placebo or no treatment. But whether we added any estrogen to the luteal phase or we used any route of progesterone, it did not show any improvement in the outcome. So this was a Cochrane database of 2015, and that is what it said at that time for fresh ET cycles. Now, coming to the frozen embryo transfer cycles, the luteal support is a little different. The reason being, in a natural cycle or in a modified natural cycle, if we use that, there is a corpus luteum present, and it tends to sort of release its progesterone, and also molecules like BEGF and relaxin, which are helpful for implantation. But at the same time, we can also use artificial cycles wherein we program the cycle with estrogen and progesterone, create an artificial cycle, do not allow ovulation to occur, and hence there is no corpus luteum present. Therefore, there is no release of endogenous progesterone, which will then necessitating the use of exogenous progesterone to help with implantation. Now, the natural cycle FET is offered to those who have got an ovulatory cycle. But as mentioned earlier, mainly with PCOS patients where we use frozen embryo transfer cycles, in those patients, there's sometimes irregular periods going to 3 months, 4 months a cycle. And therefore, it becomes impossible for us to do any kind of ART cycle in those patients. And hence, using a natural cycle in those patients does not help. But in patients who do not respond to any other form of treatment, our use of natural cycle is meant mainly so that we can synchronize the endometrium and the embryo and transfer the embryo during the physiological implantations period. But the problem with a natural cycle is there is a spontaneous LH surge, which needs to be very closely monitored with LH and P levels, progesterone levels, and that becomes very difficult in a clinical scenario for us to do. And hence we may, and of course, if you look at the results of a natural cycle, where if you use progesterone for the luteal support or you use HCG for the luteal support, this systematic review and meta-analysis, which included 15 studies, showed that there definitely is a high, 1.5 times higher chance of a woman conceiving with use of with the use of progesterone as compared to not using or compared to using HCG. And the live birth rate is also higher in patients who have used progesterone versus HCG. So therefore, the sort of the basis is set that you need progesterone for luteal phase support following a natural cycle, FET. But at this point in time, there is no evidence to support use of HCG in the luteal phase support for natural cycle FET. Coming to the modified natural FET cycle, the reason we find it difficult to monitor such a patient and keep monitoring their LH levels to look for an LH surge is a clinical problem. And hence we use a modified natural cycle wherein the HCG is used as a trigger to bring about ovulation. And therefore, once the trigger is done, the trigger is done usually when we find that the endometrium is developed as per the standard criteria, which is required when the endometrium is well developed. At the same time, the dominant follicle should be more than 17 millimeters. The endometrial thickness is more than 7 millimeters. And the progesterone should be less than 1.5 nanogram. That means there is no luteinization which has occurred. And therefore, in this situation, when we have looked at the RCTs of 18 studies, which included 3,000 women, it was found that whether you give only the HCG, is it sufficient to support the luteal phase, was the question asked. But then they found that there's no difference between injection HCG or no injection added to the luteal phase in the FET cycle. So progesterone use is definitely helpful, but HCG use may not be helpful when we use it in a situation where you're using it as a luteal support. Now, coming to the artificial or programmed HRT FET cycles, you'll find that we are doing this mainly to mimic the menstrual cycles. We start the estradiol and then we follow it up with progesterone when the endometrium is well prepared, which may take sometimes almost 14 to 18 days to prepare the endometrium, and depending on the response of the patient, and starting the estrogen early in the cycle. The advantages are that it helps women who have got anovulatory cycles, for those who cannot reach us for close monitoring, and it gives us the flexibility of adding the progesterone when we feel that the endometrium is ready. So if you look at this cycle, how it looks, wherein day 2 of the cycle, we start with the oral or transdermal estrogen in a dose of about 6 milligrams per day. This helps to prevent any natural ovulation which it may occur, so that we can suppress the pituitary and we can prevent natural ovulation to occur. There are some clinics who would use an agonist or an antagonist to suppress or to downregulate the pituitary so that it does not interfere in the treatment. Now here you will find that we keep giving the estrogen at 6 milligram a day, monitor the patient at 7th day, see if the endometrium is growing well. If it's growing well, we continue the same dose. If it's not growing well, we increase the dose until the endometrial thickness is reached and the quality of the endometrium is reached based on ultrasound. We also would then add the progesterone, which would be in the form of either vaginal, rectal, intramuscular, or subcutaneous, and we would transfer the embryo on the 5th or 6th day of initiating the progesterone. Now, when we use luteal phase in the programmed artificial cycles, as I mentioned to you earlier, we need to give the support in a larger dose because there is no corpus luteum, which is secreting endogenous progesterone. And therefore, till about 10 weeks of pregnancy, we need to continue the progesterone till the placenta takes over. It is shown in the fresh cycles that there's again a controversy. There are some centers who would stop the progesterone in fresh cycles as soon as they see the heartbeat of the baby, or they would stop it at about 9 weeks when they expect the placenta to take over. But practically, if you see, most of the clinics would still continue the progesterone till about 10 to 12 weeks of pregnancy. Now, when you have an absent corpus luteum, you know that there's a decreased secretion of VEGF and relaxin, as I mentioned earlier, which both help in the increased angiogenesis of the corpus luteum. And VEGF normally improves angiogenesis, and since it is not present, we are worried about it not being there, and relaxin, which helps to relax the uterus, both these are not there, and therefore the role of this is served by giving progesterone, which helps in the implantation. And therefore, when we have a reduced secretion of relaxin and VEGF, what we have found is that there's a reduction in the systemic vascular compliance, and this increases the risk of hypertensive disorders of pregnancy. And therefore, today there is a move that we should stop using universal freeze-all for all patients, instead use only a rescue freeze-all so that we limit the number of hypertensive disorders of pregnancy. When we use serum progesterone in the luteal phase, the treatment outcomes, if you look at the systematic review and meta-analysis published in December 2021, this included 21 studies with 6,175 FET cycles, of which 5,800 are on artificial cycle. Only 294 are natural cycle FET cycles. And both day 3 and 5 transfers were included. Women included were between ages 18 to 15 years with BMI going between 18 to 37 kilograms per square meter, and both autologous and donor cycles were included. The progesterone levels were measured at different times in the luteal phase, and different formulations have been used. Now, if you look at the outcome in this, what it shows is that when the progesterone level is less than 10 nanograms per ml, it will show that the pregnancies would occur with a higher pregnancy, would get better results. When the progesterone cutoff between 10 to 20, again, you will find that the pregnancy rates are higher in this group, but better results are obtained. And in the third group, where 20 to 30 nanograms is there, again, the pregnancy rates are higher as compared to having a low progesterone, less than 10 nanograms per ml. But when the progesterone cutoff goes above 30 nanograms per ml, we find that the pregnancy rates start reducing. And therefore, it's very important for us to know what are the progesterone levels on the day prior to the embryo transfer. When the levels of progesterone are less than 10 just prior to embryo transfer, we'll find that the pregnancy rates are lower and miscarriages are higher. And therefore, it sort of gives us an opportunity, if we do this test, that we may add progesterone at this level before doing the embryo transfer, or if we cannot get the levels higher, we freeze the embryos and transfer in the next cycle. But above 10 nanogram per ml, there is a little uncertainty whether increasing the progesterone level is going to be associated with better treatment outcomes. They're almost similar. And the reason for this is that probably when we are using vaginal progesterone, the levels which we see in the serum is much lower as compared to intramuscular or subcutaneous progesterone. But definitely the endometrial tissue levels are pretty high as compared to the serum levels. In this meta-analysis, they included patients who had used vaginal progesterone and intramuscular, and therefore they were not able to reach a conclusion on this. Second thing is there are different pharmacokinetics of different routes of progesterone, which I will discuss later. And a progesterone level above 30 nanograms may be detrimental, which is supposed to be, it's maybe possible, but probably because the endometrial receptors get saturated at a level of 3.14 nanograms per ml at the endometrial level. And probably these are the reasons because of which the pregnancy rates are not showing any benefit with a higher dose of serum progesterone. If you look at our own data, when we did the progesterone levels on the day of beta HCG, and we find that as you look at a fresh cycle and a frozen embryo transfer cycle, when the levels are less than 10, you'll find that their progesterone, the clinical pregnancy rates are pretty low. As the progesterone levels go on rising, you'll find the pregnancy rates also increase. Between 10 to 30, you will find that the clinical pregnancy rate is definitely higher in an FET cycle as compared to a fresh cycle, though the serum progesterone levels are lower as compared to the fresh ET. If you go to the 30 to 50 nanogram per ml, we found that the frozen embryo transfer again showed a lower progesterone as compared to a fresh, whilst the pregnancy rates, clinical pregnancy rates and live birth rates are much higher as compared to the fresh ET. But when we went above 50 nanograms, what we found is that the pregnancy rates diminished, even in the fresh and the frozen cycles, mainly in the frozen cycles, and even the live birth rates were lower. Compared to this bar, you'll find that with over 50, overall, you'll find that the pregnancy rate and clinical pregnancy rates get lower when the progesterone levels go above 50. So in short, too much of progesterone, too little of progesterone is also not great for the patient, and therefore we must try and maintain at the level when we do the HCG test, that is 14 days after the embryo is transferred, we must try and achieve a level of between 30 to 50 nanograms per ml and not go beyond 50. When we use exogenous progesterone in luteal support of FET cycles, as mentioned before, the circulating progesterone levels are definitely associated with the live births and miscarriage rate. We know that progesterone supplementation can help to rescue cycles with low progesterone. So if you look at what evidence is available on this, based on the various progesterones used, I mean, if you go into their bioavailability, we know that the oral progesterone does not give us good results in ART because their bioavailability is pretty low and maintains levels only for 6 to 7 hours, whilst with the intramuscular route, it remains for 48 hours and you get a good progesterone level in the plasma, whilst in the vaginal route, you find that in the vaginal route, you'll find that the endometrial levels are raised, but the serum levels remain low, less than 10 nanograms. And hence today we tend to use the intramuscular route, and today even the subcutaneous progesterone is available, wherein it's a recent innovation and it is better tolerated. It does not give rise to so much pain. It is known to be the patient can take it herself. It has showed no differences in the endometrial receptor assay or endometrial histology in about 24 donors administered subcutaneous versus intramuscular progesterone. And it is something which will reduce the stress hormones like prolactin and cortisol significantly when it is used with a subcutaneous route. So the rescue of this protocol in this very nice studies has shown that in this particular study, what they did was they gave 600 vaginal milligram per day of luteal support with micronized vaginal progesterone. And when they gave that they found that the levels were less than 10. So they increased the dose to 1200 in those women who had less levels, and then they retested after 2 days. And they found that the levels still remain 10 nanograms per ml in almost 1/3 of those women. And this, as I mentioned earlier, that these could be the various reasons why it will not help. And hence doubling the dose of vaginal progesterone may not be the ideal situation. Now, if you look at what happens when you compare vaginal supplementation with subcutaneous progesterone, what they found is that those patients who were not doing well with the vaginal supplementation were on the day of before the embryo transfer, if the levels were less than 10, they were supplemented with subcutaneous progesterone. And they found that 38% of the women who had low levels with vaginal progesterone, when they were given subcutaneous progesterone, 98% of them reached the levels which were required. And even the reproductive outcomes seen in these women who were rescued by giving the subcutaneous progesterone helped them to get similar reproductive outcomes. And hence there is a possibility of rescuing a protocol if you do the embryo if you do the progesterone levels on the day before the FET, and this is shown very beautifully here with the orange bar showing where the progesterone was rescued by giving even a 1-day injection of luteal progesterone, which is then followed up after the embryo transfer. Now, whether to do a single or you do multiple measurements of progesterone, whether you should do it 1 day before ET, whether we should do it on the day of trigger, when should we do it, as it's not really been, confirmed, but there is a study which showed that if you give it 1 day before the ET and you get good levels, you do the embryo transfer, but then when you do the day of HCG, you will find that the progesterone levels may have dropped on the day of HCG. And hence it is important to do the progesterone 1 day before ET and on the day of HCG, so that if you find that the levels have dropped, you can add on intramuscular or subcutaneous progesterone to support the luteal phase. And this customization needs to be done in almost every cycle. So coming to the evidence-based recommendations today, which are available, it's said that the luteal phase support may differ depending on the endometrial preparation, whether how you prepare the endometrium is important, and therefore this is a level 1A evidence. So the progesterone has to be, luteal support has to be good. Second is that there's no difference found in the clinical efficacy, whether we use a natural cycle, a modified natural, or programmed endometrial preparation protocols. This is also level 1A. Third is if in natural or modified natural FET cycles, if you add additional luteal phase support, means you add extra support after giving the HCG trigger, you may not improve it may not improve the outcomes in that cycle, and this is again level 1A. And fourth is that due to absence of corpus luteum in programmed FET cycles, luteal phase support must definitely be provided. And there is no consensus regarding which progesterone to use for the FET cycles. Today, we still don't have a consensus on that, but we know that the serum progesterone levels, which we use as a marker, is something in the clinical scenario wherein we get better, we can evaluate or we can predict better when we do the serum progesterone levels. And therefore, we prefer to use progesterone, which is going to give us levels above 10 nanograms per ml on the day before embryo transfer. And based on studies achieving this, we find that during the, this is exactly what I said, it's a level 1A evidence. And for luteal support in programmed FET cycles, either if you use 180 milligram per day vaginal gel or 50 to 100 microgram per day intramuscular progesterone, they give you similar clinical efficacy with the level 2B evidence. And currently there is insufficient data on oral dydrogesterone administration for the luteal support in FET cycles. So I thank you very much for this opportunity to share my my evidence, which I have brought in, and something which in the clinical scenario we keep using all the time, and based on what we find in patients in the clinical scenario as compared to the lab scenario, where you do actually levels at the endometrial level, receptor level, etc. So again, thank you very much for having me here.
Thank you, madam, for your very lucid talk and describing in detail how you manage it clinically and the do's and the don'ts of giving various combinations. It's a really great work you are doing, ma'am. Thank you so much for your talk. Now, I would like to request Dr. Manivan to introduce the next speaker.
Yeah, thank you, madam. Good morning, everyone. Good morning, Dr. Bhartiya. And I am particularly grateful to Professor Lohia and Dr. Ansari to place me in this session where my teacher and mentor is one of the speakers. Thank you, sir. Now I take the privilege of introducing my teacher, Professor M.A. Barsha. First, the photograph is very nice, sir. we call him in our college days Rajinikanth, that is superstar of our department.
And even this photograph was taken when I was in EPA in USA.
Okay, sir.
Okay, very beautiful.
Beautiful profile photograph, sir.
Yes, thank you. Thank you.
I take this privilege to introduce you, sir.
Thank you so much.
Professor Akbar Shah, research interest is endocrinology, reproductive biology, careers of reproductive system, toxicology mainly, and now currently he is focusing his complete interest on alternatives to animal experiments. He is regarded as the man of Epididymis. He is going to speak on epididymal maturation today, and we call him as a man of Epididymis. And he has he is fond of epididymal segmentation those days, master in histology, and he taught us the histological techniques those days. And I don't think anyone can explain a semi-thin section and ultra-thin section better than him. and he can spend hours together in microscope, and he can pierce through the cytoplasm. Am I right, sir?
Yes, yes, thank you.
He could not pierce through the nucleus, but cytoplasm is a master. And he taught us how to explain the cytoplasmic contents and how to explain the histological slides. Thank you, sir. Thank you for being a mentor. I was the student of him for MSc and MPhil projects. And your writing skill also, I have to speak a few words. He shows varieties on his writing skills. Paper writing is a master. And I still remember one current science paper in 1988 or 89 somewhere, sir. The introduction was written in one sentence. It is a one-page introduction, was written in one sentence. I mean, we used to cite your paper with among our research scholars. Even my Professor Patan also used to appreciate this kind of writing skills. And particularly when he writes about the paper on Epididymis, and the skill is totally different, sir. With this brief word, please project his slide, please. His CV, please. His CV, please. He has several awards. Professor Akbar Shah is the visiting professor of Kentucky University. He is the founder, chair of a Doran Camp, Alternatives to Animal Sciences. And it has started in Bharadasa University, Tiruchirappalli, and it is continued by the university now. And he is the visiting professor of South University, Riyadh. And Stanford University listed him as top 2 scientists in the field of toxicology in 2019. And he is recently got the award of Lamas Memorial Oration from Ames. He has more than 250 publications, and he is editor-in-chief of Journal of Endocrinology and Reproduction. We are proud to have him here, and he will be putting his expertise on epididymal sperm maturation. So over to Dr. Akbar Shah, please. Sir, please.
Yes, sir. Can you see the screen?
No, something different is coming, sir.
Some problem.
Organizer, they are focusing the screen, sir? Or you?
I think better they do it.
No, I think your screen is visible, but what you should do is put the PowerPoint to that display mode, because it is your email and screen which is visible.
Sir, better to have the organizers to give it. Fine, sir. It is
Let me see. This. Can you see the PowerPoint now?
Yeah, it's fine. Perfect.
Okay, let me see if you can move the slide once. It moves, right?
Yeah.
Okay, fine. Thank you. So, thank you, Manivandan, for your very elaborate introduction, reminiscence of the good old days we spent together at Jamal Muhammad College. And it is nostalgic to me also to be taken to that scenario of 1970s.
Your hard work, your example of hard work, sir. We worked even in railway station, sir.
So you mentioned in it. So thank you, I have chosen to speak on a very special topic. Perhaps nobody else in this conference has spoken about it. I speak about a dual role of epididymosomes. I do not know how many of you know about it, heard about it. Dual role of epididymosomes, 2 sides of the same coin, contribution to epididymal sperm maturation, as Manivandan rightly mentioned, and a unique finding recently, and to the disintegration of and liquefaction of the misshapen spermatozoa. Well, this is today's talk was originally an invited talk, but I would like to rebranded it as a talk in commemoration of the Lifetime Achievement Award conferred on me by the ISSRF. And my colleagues have taken pride in projecting the award, which was conferred on me by ISSRF. They have made a frame like this. I really enjoy it. I thank Dr. Lohia and his team, Dr. R.S. Sharma and Dr. Ansari, for and the selection committee to have chosen me for this award. Well, as rightly said by Manivarnan, I have been engaged in research for well over 40 years on aspects of male reproductive biology, particularly towards understanding of the issues concerning male fertility, the causes of male infertility and subfertility, which have required people to go for a great lot of IVF and artificial insemination kind of things. So it's not a very pleasant thing to be sharing and discussing, but it really happens. So when my students were engaged in trying to find out what really causes this deterioration of the male fertility. So we have using, as again rightly said by Manivarnan, I didn't go into genes and genomics and kind of topics. Tools, I have been limiting my investigation using the conventional approaches of histology, histochemistry, histopathology, a little bit of biochemistry, immunocytochemistry, and then great lot of transmission electron microscopy and spermatology. So we were looking at spermatogenesis, spermiogenesis, and EXR biology, post-testicular sperm maturation, particularly concerning reproductives, epididymis, vas deferens, and so on. And we were thus interested in unraveling the mysteries of male reproductive biology, andrology, and to apply the knowledge in understanding the mechanistic perspectives of male infertility and subfertility. And finally, incidentally, to find agents and targets for male contraceptive attack. Well, we did, this is more a kind of a review presentation, therefore I'm not going to focus on any one particular experiment and the data coming out of it. Though originally I planned it, for it, I converted it into commemoration talk, so I go into a little bit of backtracking my journey through the andrology research. So we were using animal models, Winster rats, Swiss mouse, and bonnet monkey. And we were hypothesizing that among the various reasons for the increase of male infertility and subfertility have been exposure to environmental contaminants, dietary toxins, and so on, and even medicinal plants. So we looked at phosphomidon, dichlorvos, malathion, dietary toxin, aflatoxin B1, environmental and occupational heavy metal contaminant, which is chromium, medicinal plant extract, the Andrograph hispaniculata, which is greatly used in these days in the corona COVID days. And then phytotherapeutics, pure compounds of vincristine, piperin, plumbagin, andrographylide, ursolic acid, quercetin, and neoquercetin, and a little bit of human samples coming from fertility clinics. In those days, I had collaboration with Professor T.C. Anand Kumar, Dr. T.C. Anand Kumar, so I had quite a bit of samples coming from infertile men. So again, my emphasis has been is that histological techniques, and you can see we were targeting essentially testis and spermatogenesis, and to look at what happens when these animal models are exposed to toxicants, reproductive toxicants, and what happens to the testis. And more so, I have a lot of interest in epididymis because of the association with the great stalwarts of epidemiology of the yesterday years, particularly people like Hermo, Robaire, and others. So a lot of studies, a lot of emphasis on epididymis, and particularly about, as again Manivarnan said, looking at the zonation or segmentation of the epididymis, and to look at the contribution of epididymal epithelial cell types of the different segments to the post-testicular sperm maturation. So the sperm arriving at the initial segment of the epididymis are not motile, and at the cauda they are bigger motile, and the whole thing takes place because of a lot of changes that take place in the protein profile of the sperm, starting from the head of the epididymis to the tail of the epididymis. So the proteins of the epididymis are epididymal epithelium, which are essentially concerned with the epididymal or rather post-testicular sperm maturation. So we have been emphasizing on testis and spermatogenesis and epididymis, post-testicular sperm maturation, and trying to find what these toxicants would do to the aspects of spermatogenesis and aspects of sperm maturation. And take you direct to the topic. I'm not telling you what treatment it has been, a variety of treatments, but mean that the point is that we need to, these treatments lead to mostly infertility or fertility of the animal models that we were experimenting on, like mouse, rat, and monkey. So what you see here is the picture photograph of a testis, where you can see that the seminiferous tubules are totally bereft of cells which look like sperm. Rather, you are getting a total derangement of spermatogenesis, and rather you get the abortive spermatogenesis, wherein the cells get exfoliated, discharged in the same manner as the sperm would do, and they get moved on away from the testis, seminiferous tubules. And you see also generation of multinuclear giant cells. These are beautiful to look at. One should really look through the microscope to enjoy the fantastic and fascination of these kind of cells that we look at. Now, what is important is that total arrest of spermatogenesis ending up in cells which are not looking like sperm at all. And these cells arrive at the epididymis. You have the section of the epididymis where you get in the lumen, you get spermatozoa produced in some of the seminiferous tubules that are effective. And also these kind of giant cells are aberrant cells. Also, they come to be present in the epididymis. So now the question is that testis is not very effective in functionally towards production of spermatozoa, and it does something different from that and produces aberrant cells very different from spermatozoa. Therefore, they are not ending up at sperm. So the question you asked is what happens to these cells when they arrive at the epididymis? That is question number one. The second, another thing in a similar situation and experimentation we found was that kind of a spindle poison that was tested, aflatoxin B1, when we found that the spindle fibers were totally in trouble, as a result of which the paired chromosomes, they fail to move towards the folds and end up as small dots of chromatin. We call it multiple micronuclear giant cells, as you will see here. And again, interestingly, here again, very rarely you get some spermatozoa. Otherwise, it is bereft of sperm. So these cells, the multiple micronucleate giant cells, and also the spermatozoa which are thus produced, they happen to arrive at the epididymis. So you have these cells, single cells with the chromatin, pairs of chromatin looking as a chromatoid body. So these are present in the epididymis. So here again, in the epididymis, these chromatoid bodies, you can perhaps undergo disintegration, but the cells still remain in the lumen of the epididymis. So in as much as what would happen to those cells which are, the giant cells from the testis, the multiple micronucleate giant cells from the testis, what happens to these cells when they arrive at the epididymis? The another scenario is that when we give these kinds of treatments, a different domain, different scenario altogether, in as much as there could be good spermatogenesis, but still the spermatozoa that are produced are not normal. They are many abnormal in the sense that they could undergo all kinds of changes like teratozospermia, estenozospermia, all kinds of things. So we call it abnormal spermatozoa. So large number of sperm which are produced in the testis were of morphologies are stuck, inefficiency, they were unviable. And you could see here very fascinating photographs of spermatozoa where the outer dense fibrils undergo a kind of excoriation. They discharge from the peripheral sheath, and you get one half ring of outer dense fibrils are totally missing. So these are sperm abnormalities. Your mid-piece abnormality, this is a normal sperm, and where the mid-piece is undergone derangement, derailment, and you could see that the mitochondria totally get disorganized. They separate out, and there is total problem in the middle piece. And we can, as I said, I had a connection with Professor Anand Kumar, who used to give some samples of sperm from infertile men. And here you have the spermatozoa, human sperm. Earlier ones are animal sperm, these are human sperm. And here again, the mid-piece problems, mitochondria are totally disorganized. The outer dense fibrils are exfoliated. They are globospermia from different patients, as you could see, a lot of issues with the sperm. And yet another manifestation was that, usually the sperm carry an extra load of cytoplasm, the cytoplasmic droplet. And this is called, this is actually has a physiological role of aromatization of testosterone to estradiol during epididymal transit of sperm. So when the sperm arrive at the carda, this role is fulfilled and the sperm should shed the cytoplasmic droplet. But due to some problem in the spermatogenesis, the sperm processing, the droplet is failed to be shed, and so you have the retention of the cytoplasmic droplet. This is only to just highlight. This is another beautiful picture we took. Like this is ethidium bromide, acridine orange stained spermatozoa, where the cytoplasmic droplet here is retained, and the more importantly, the flagellum is coiled back on itself as a wick. We call it lasso sperm. So just to explain to you the different kinds of abnormalities, the manifestations that will come up. So having said about this, what happens in the testis, what would happen? I mean, these all the spermatogenic cells which have not ended up at spermatozoa, and the abnormal spermatozoa or unviable spermatozoa, either produced in the testis or ending up because of problem in the epididymal sperm maturation. So the question I've asked is it that these animals, rather the patients, the men who represent these abnormalities, these issues, have no redemption at all? Is there not a mechanism in the body, in the male reproductive tract, which can handle this situation? So we hypothesize that it is not always doomed to the end. There should be some mechanism. The animal system, human system is such that there are many mechanisms which can circumvent the issues and help the animal or the patient still to produce some good sperm. So we thought that there is something happening in the epididymis where such abnormal spermatozoa, the aberrant germ cells which arrive at the epididymis, can still be dealt with by the epididymis. I used to call epididymis as a versatile organ. So it's got a lot of it can take the newer roles, the newer functionalities. So you see here, we found a very this is not a very systematically planned study. Here and there, we used to have photographs and then put them together and consolidate into stories like this, what I'm telling now. So you can see here among the spermatozoa in the epididymis, I would say these are all spermatozoa which are normal, and you get dense matrices, dense masses in the epididymal lumen, and these also had the spermatozoa and the germ cells. So we went into a higher level of analysis and electron microscopy. We found that these dense matrices were having spermatozoa and the germ cells entangled in it. And where there was clear seminal plasma outside this dense matrix, where also the sperm are present. So our hypothesis has been that this matrix is a mechanism in the human and animal system in the epididymis, a mechanism to deal with the abnormal spermatozoa and the aberrant cells in the aberrant spermatogenesis, such that there is segregation of such aberrant spermatozoa with the normal sperm. So this segregation would still protect the sperm that are normal and still take care of the abnormal spermatozoa. Now, this is very, very special picture, as you could see here. This is the dense matrix. With all the spermatozoa inside, they are all very defective. They are teratospermic, and you can see outside, just outside the bordering there, plenty of spermatozoa, which in our impression, they are normal and therefore they don't get into the dense matrix. So you have a system of the epididymis producing a dense material, which forms into a matrix that segregates the abnormal spermatozoa and leaves the normal spermatozoa aside to be further processed. So we found that further in the dense matrix, these defective or abnormal spermatozoa are gradually disintegrated, and there is a dissolution of the content such that you get dense substances that are produced, you may call it lithofusin material, whereupon you can see that the content of the the whole spermatozoa are disintegrated and taken to dissolution. So this mechanism is operative, and perhaps we were the first to explain it, to suggest it to happen in the epididymis. So then we hypothesize. So as I said, it is the epididymis which should be producing this material. Nobody has ever described how this material is produced. We are reporting for the first time the very existence of this material in the epididymis and unusual situations of experimental manipulations and context of infertility and subfertility. So we were looking for the part of the epididymis which is producing it, and these are all very accidental or serendipitous discoveries. This is a normal epididymal tubule duct at the initial segment of the animal epididymis. If we don't get that portion in the human, and as you could see here, these cells, the principal cells of the epididymis, in this unusual situation of toxicity inflictment, could see that the epididymal epithelial principal cells would produce protuberances, large sac-like structures, cytoplasmic protuberances, which we call as episomes or exosomes. I would prefer to call it aposome rather than exosome, because exosomes, in the modern context of stem cells, the exosomes produce small blobs from the cell which carry some physiological material to the outside. So I prefer to call them as aposomes. Okay, so you could see that the whole lumen is filled with aposome. There is a reason why a physiological, though it is pathological situation, it is a physiological requirement in the animal to be producing this material for some physiological purpose. And very interestingly, we could hit up at a lucky person hits up at some good sections, which tells good end, provides good end to the story. So here the story is coming to a good end at this stage. You can see that the lumen of the epididymis is filled with spermatozoa, maybe normal, most of them are abnormal, and the aberrant cells which are produced due to failure or aborting of the spermatogenesis. And you have this dense material, the large masses produced from the epididymal epithelial cells, what I call as the aposomes. And you can see that these masses, these aposomal material has been coalescing with each other and form into a continuous dense substance. And this is the one which will go on to take over these defective spermatozoa and the aberrant spermatogenic cells, what we have seen in the. So this is how the aposomes get released into the lumen of the epididymis. These are the aposomes and these are the spermatozoa. And again, it is not very deliberate plant study. For some reason, we went for higher level pictures, and we found that these aposomes at higher magnifications were seen to contain some material, a spherical, very peculiar organization, not very much reported in the literature. And we cross-checked with one or two papers published by Sullivan and his group, C.S. and Sullivan, and he called these materials as epididymosomes. That was the first time we came across this term, epididymosome. That was in 2010s and 20s. I mean, yes, 2010. Yeah, that period. So epididymosomes. So we went for higher level pictures, and of course, we confirmed that these spherules which are present in the episomes, in the cytoplasmic mass of the episomes, they are the epididymosomes. Well, further confirmation, very clear evidence that the episomes carry a fluid matrix in which you get the epididymosomes. And again, as I said, again serendipity, accidental hitting at some material. And here is the picture where you can see that the dense matrix. The dense matrix has spermatozoa in the process of disintegration. Here is sperm tail. And you can see the epididymosomes in it. And in the same ambience and environment, you can see the disintegration of the sperm and the end product of the disintegration, namely the lipofuscin material. So this is, well, as I said, one should be lucky to have pictures like this. We could shoot at some images. So So the point is, again, a second stage, summing up, the epididymis is capable of, under adverse conditions, is able to produce episomes. The episomes carry in them the epididymosomes. The episomes form the dense matrix in which the defective sperm and the aberrant gels get entangled, and where they undergo total disintegration and dissolution. And finally, what really causes the disintegration? Well, the matrix provides an environment for a condition for the sperm to undergo dissolution, but the epididymosomes are the ones which are associating with the sperm, with the defective germ cells, so that they get totally disintegrated. This is one stage in the story. So what we did was, we wanted to check if there were publications, information about epididymosomes and their role. We came across, really, there were some, at least half a dozen publications, particularly from Sullivan Group. They have been given a good coverage of the epididymosomes. I'm not going into the details of it. More important, what is important is that the early days of epidydysome understanding, it was proposed that over and above the kind of sperm which I mentioned in the first slide, there are also a number of sperm which these epididymosomes carry from the epididymal epithelial cells for a different purpose altogether, but still, like this, the proteins which get added on to the surface of the spermatozoa, rendering them motile. Sullivan could see that these epididymosomes also happen to be associated with the sperm, but don't get confused with the epidydymosome role in disintegration, which I mentioned earlier. This is a very clear physiological role of contribution of epidydymosome to, you can see that the epidydymosome is interacting with the sperm plasma membrane, providing some proteins, very special proteins. I'm not describing those proteins that are here. So those proteins get associated with the spermatozoa, contributing to the epididymal sperm maturation in a manner very different from the proteins which are secreted in the murocrine manner. This is apocrine secretion. The conventional protein secretion of the epididymis is murocrine, totally in a dissolved form, so they interact with the sperm. And so that is one role which is already known for epididymosomes. And again, Sullivan's group, epidydymosome, proteosomes, and liposomes, and their roles in mammalian male reproductive physiology. So they went on to attribute a role to physiological maturation of epididymosomes to physiological maturation of sperm. Also, they mentioned some contribution to some kind of RNAs which these epididymosomes would carry, and these RNAs may be mRNAs or sRNAs, and they hypothesized that since the sperm is no more capable of transcription, there could be some mRNAs which the epididymosomes would transfer to the spermatozoa, which could be translated to protein, and the siRNAs could be useful in the modulation of the sperm chromatin. So that is what this paper was telling. Another paper, Rayleigh et al., that are published in 2016. Also, they characterized the mouse epididymosomes and found a profile of microRNAs and potential mechanism for modification of the sperm epigenome, epigenetic modification of the spermatozoa by contribution from the epidydymosome. So physiological maturation through proteins, modulation providing for the mRNA, providing for the modulation of the epigenome. These were the roles associated with the. This is a publication that was published in 2018 in Frontiers in Endocrinology, and this is the first time I come across the picture like this. You can see the episome, which you call the apical flaps, and the hypothesis, the derivation here is that the understanding here is that the apical flap discharges the epididymosomes, and the epididymosomes contribute to physiological maturation of the sperm. And our finding goes a step further. This is not actually discharging the epididymosomes. The episomes carry the epididymosomes, and these epididymosomes could be released in this manner as one mechanism. And in another route, the whole content could become the dense matrix, and the epididymosomes contained in these dense matrices could contribute to disintegration of the spermatozoa. So another paper of Sullivan, little bit of hypothetically making a mention, just touching upon what we have discovered. The group suggested that there are two kinds of epididymosomes. One physiological and another contributing to management of the ROS that are produced by the defective spermatozoa. Not seclusion, not the dense matrix, but a kind of secluding the viable spermatozoa from the unviable ones, particularly from the ROS from the unviable ones. This suggested there is another category of epidydymosome, and that was in 2015, right? And I would like to take you to a summing up. It is getting close to the time. So this study shows for the first time that the aberrant spermatozoa, the unviable spermatozoa, are handled by we call them mishapen. The editor of the journal which published this article used this word mishapen spermatozoa, meaning all the giant cells, aberrant cells, unviable sperm. Well, they all get segregated from the viable ones by the dense matrix present in the episomes. And the newer pathological role for epididymosomes present in the episomes and exosomes, apart from their known physiological roles to contribute to disintegration and dissolution of dead and defective spermatozoa and germ cell debris, we have shown it. And of course, there is no need for going for a understanding of the biochemical mechanism. And we had the pleasure of having this particular portion. When the earlier talks are all published in other articles in other journals, but this dense matrix and the epididymosomal contribution to disintegration of the sperm, that is the publication that came in a paper in 2020-21 in Andrologia. And very interestingly, I'm really amazed by looking at this particular article, which again appeared in Andrologia, but that was in July 2001. Our paper appeared in September 2020, and then later print came in 21. And immediately after that, we saw there was a group of scientists from India, Paul and Tirumala and people from Andhra Pradesh Veterinary Institute. They have written a review of the epididymosomes where they have mentioned upon contribution to post-testicular sperm maturation, role of epididymosomal cargo in epigenetic modification, transfer of crucial fertility modulating proteins in sperm surface, alterations in the siRNA in epididymal sperm, and incidentally, they also included elimination of abnormal spermatozoa. The paper does not produce much of evidence for this understanding, but we have by that time published our paper explaining the contribution of epididymosomes to elimination of abnormal spermatozoa. So having said this, I want to sum up in one sentence this particular part of the study have made a reasonably good, outstanding discovery that epididymis is reiterating my emphasis that it is the versatile organ. It can take into new roles. It can take to a lot of adaptations. So when there is a situation wherein the spermatogenesis is in a disarray, the epididymis is still able to manage the situation, handle the situation in such a way that at least some spermatozoa are still protected from the unviable ones, from the all kinds of onslaughts. So the situation is such that you still can believe and expect the men, the infertile men or subfertile men, to produce some spermatozoa. That we know now that these are the ones which are used for artificial insemination or at the extreme situation for the in vitro fertilization. And the great contribution of maintaining these spermatozoa very viable goes to comes from the epididymis in the form of the epididymosomes, which mean the episomes and epididymosomes. Episomes providing for the environment for the dissolution, and the epididymosomes contributing to total dissolution of the aberrant spermatozoa. It has been a very elaborate study over 40 years, I said. the major contribution to this study was Faisal Punathodi, and therefore he is the co-author in the paper. But then I have touched upon discoveries made by all these people. Time to read, particularly I should mention the name of this person who is the chairperson today, Manivarnan, who was my student in postgraduate and MPhil, and a lot of other PhD scholars who helped me in developing a good story in terms of testicular problems in infertility and epididymis sperm maturation. I thank DSD, ISSRF, UGC for the funds. And I don't have an electron microscopy facility. All these micrographs, semitine and electron micrographs were obtained at Christian Medical College and Hospital, Vellore. Very profuse thanks to them for the support. And I thank each one of you for listening. And to Professor Lohia and his team for the wonderful opportunity. Thank you so much. I shall be happy to answer questions.
Yeah, thank you, sir. Very nice presentation with lots of information. Many appreciation in chat box also, sir.
Thank you.
Good that you have shown that you are the first to. If I'm right, you are the first to introduce the. Sir.
Dr. Manivarnan, could you please proceed? Next presentation without spending more time on your comments.
We are over to Bharti. Over to Dr. Bharti for introducing the next speaker. Dr. Bharti, please.
Hello. I have the honor of introducing Dr. Taru Sharma. Dr. Taru Sharma is Director, National Institute of Animal Biotechnology at Hyderabad. Her research interests are reproductive physiology, biotechnology with special emphasis on embryogenomics and stem cell biology. She has many awards to her credit. She is the Young Scientist and Gold Medal Award from Indian Science Congress, the Neil Lagris Memorial Award, the A. Roy Honorary Award, the Punjab Rao Deshmukh Award, Bharat Ratna Subramaniam Award, the Research Excellence Award, the National Bioscience Award, then ICAR Rafi Ahmed Kidwai Award, and she's also a fellow of NAS, NASI, and Academia Panel in WINS. And she has many publications to her credit. She has mentored more than 24 students of MBSc and PhD. She has authored a couple of books, edited important compilations, and most important, she has 4 patents to her credit and many international publications. It's really an honor to have you with us, Dr. Taru Sharma. And your talk, we invite you for your talk, The Potential of Mesenchymal Stem Cells Conditioned Media for Cellular Therapy and Tissue Engineering. I request Madam to please deliver your talk.
Thank you so much, Dr. Bharti, for your kind introduction. Give me a minute. I share my slides. I suppose I'm all good. Can I move on? Dr. Bharti. Dr. Manivarnan, am I all fine?
Yeah, fine. Please go ahead.
All right. Thank you so much, Dr. Bharti, once again. Very good afternoon. I believe it's 12:01. Good afternoon to one and all. The chairs, and especially Dr. Bharti. I really, ISSRF and 32nd meeting and talking at ISSRF. It's a happy afternoon as ever. Thank you very much to Professor Lohia and Dr. R.S. Sharma for letting me share some of the work which we have done through this platform. For this day in this session, after Dr. Autophagy has elaborated so fantastically well the epididymal physiology, I would now switch gears and take you in a little different area, and we'll talk about the stem cell biology. And for today's talk, I have chosen at ISSRF Forum, I've been sharing the work which we have done using the adult, earlier embryonic stem cell, of late adult stem cells, and their use for different therapeutics. But today I shall focus mainly on the conditioned media, which originates from these cells. As I was introduced, I'm at NAB. I'm 2 months and a week old here. So the work which I'm going to share was all done at IVRI, my laboratory for reproductive physiology and stem cell laboratory, where I spent, not only I did my doctorate, but where I spent more than 3 decades. So I move on with my talk. As we all know that, yes, I mean, there is a revolution. It's not the revolutionized. But in animal sciences, almost 1.5 decades back, when we saw not much was really being done. So we started using, doing a small experiments. In fact, we were IVF laboratory basically, and generating different buffalo embryos or goat embryos. So earlier we used, these bovine origin embryonic stem cell for very many purposes, mainly for the basic studies. But of late, we focused using the adult stem cells. So we were taking the marrow origin cells and the fetal origin cells. And in fact, like a very greedy scientist, we left no tissue which would give us adult stem cells. So why exactly is so important? This cartoon is loud enough to explain. And if some of my very esteemed members of ISSRF remember the work which I shared in the platform at Jammu, wherein we did say that what exactly would it happen if we use adult stem cells in an allogenic mode for the spinal cord injury, and we used canine because that's the model we have been working, mainly canines as well as livestock, because our OPD back at ICRI was full with such kind of patients which were in fact not being addressed directly or indirectly. So with this, I move on. And this is the slide. What exactly I want to communicate through this slide, because the ISSRF is the only platform, not only having the animal veterinary scientists, but also having the medical fraternity and the basic biologist. So I believe the doctors in the group would really agree with me. For all the clinical work, you really need best preclinical model. And so is true for stem cell therapy. So instead using a small animals, if one could really go for the large animal species, it could be anything. So a couple of references and a lot of work which I have been sharing from last decade or so, using either the canine, the caprine, or the buffalo. And what do we do? The choice remains of the laboratory, what best application you need it for, and what exactly is a specific purpose for which you would be needing this preclinical models. So with this little bit of importance of the animal research, and especially involving the large animals, I move on. But I would really like to tap this esteemed group that for the preclinical models, especially with the stem cell therapy, if someone is really looking for, please don't hesitate reaching us or whatever is known to us. We would really be pleased to shake hand and work on a common platform. All right. So what happens when we really transplant these MSCs? Of course, from dish to the, from as Dr. Suri was saying, it is not only from bench to bedside. From bedside also you get many stories which you learn and make your research accordingly little improved. So when we put these cells, they do one of the 3 things or all the 3 things precisely. They get transdifferentiated into the kind of clinical status we have given them. Since these adult cells, they have a very good immunomodulatory potential. Besides, they secrete a lot of mitogens, and the list is long. So these are the cells. Body has its own repair mechanism. So the niche cells, they automatically come. But when we give these cells, they also go and they also pinch the niche area cells of that particular clinical condition and allow them to further proliferate and transdifferentiate. Besides, they themselves get transdifferentiate, and they all secrete different biomolecules, as I said, and in turn, the niche area cells which were pinched by these cells transplanted also gets the lot of biomolecules secreted. These two boxes, I'm not going to focus on these two boxes, but meanwhile, people can really read what exactly, why do we really are with the stem cells. But I'm going to focus over here because my talk focuses on conditioned media. They do have integrating and the interacting abilities with the host tissues. And in turn, they do allow secretion of various mitogens. And by doing so, not only they, but as I said in the previous slide, they also, pinch the niche area cells, and altogether it hastens the tissue repair mechanism. With that, this was a paper of Wang in 2014, it came. With that, I move on. What exactly is this conditioned media? This is a secretome. And the cells we have been using for this particular work, all the adult stem cell originated conditioned media. The secretome precisely has various soluble proteins and the extracellular vesicles, having exosomes as well as the microvesicles. The newsletter day before yesterday, which was launched and inaugurated. And one of the editors, Dr. Vikas, who was a part of my team, has written an elaborated article on that exosomes, macrovesicles, and work is being continued in the lab away from Hyderabad at ISSRF Isaac. Well, what the soluble proteins? There are cytokines, chemokines, various mitogenic growth factors, as well as proteases. Okay, having said so, this was a paper which came in 2013, and when we read this paper, I got a detail of the same over here. This is a very good slide I personally like, because whenever you sit with students and talk through this cartoon, this particular table is very enriched to talk. So what does it tell? It says that the conditioned media has all so much. TGF alpha to allow the cells to get differentiated, TGF beta to have the cells which will in turn give more of the growth factors. You have FGF, which will allow more of the fibroblasts to flow in, and VEGF for angiogenesis, and the list is very long. This is the list of the paper, which later on International Federation of Cell Biology also quoted this paper time and again. And I keep this table with me in most of the conditioned media work. With that, we moved. And before I move and share the data, the key added advantage of using this over the stem cells is because it's comprising of soluble factors, which includes all that which I showed in the picture 2 slides back. Both of the, whenever we did our work on conditioned media, we always kept our stem cells together so that we can compare, because we were always getting a scarless wound and a healing rate was better, but we always compared. And, one can really think of using in a xenogenic mode besides the allogenic mode. And our strategy was, because conditioned media, we were using differentiation material, but of late we started lyophilizing it and then using it. Storage and handling is very easy. Put it in your pocket and move. And that is what our field veterinarians and people who use, they need it. Or at best, you need a 4 degrees centigrade temperature for this conditioned media approach using different things. So then we sat together and we drew a picture for ourselves that when we transplant MSCs, it is probably giving all this, like all immunomodulation being done, improves angiogenesis, and it helps movement of fibroblasts and keratinocytes, forming granulation, tissue granulation, and anti-scarring as well. So this cartoon is more or less similar, which I explained a while ago. And having understood this, we generated some of our data, which I'll be sharing here. But before that, I'll also let you know the story. Why did we move with conditioned media? This is a slide in maybe 2010 or 2011. At OPD, there was a pet which was suffering with chronic diabetic wound, and all the treatment was really not working. So some of our clinical colleagues shared, can we really move on with the stem cell treatment? We knew nothing. So, but we tried, and then we tried not only the stem cells, we did try the conditioned media. It did not take a month for this to get cured, and it was all a happy situation. So what we did, we made one MSc student, Mateen Ansari, work at it, and he created a diabetic model, rat model, diabetic as well as non-diabetic. And we use, I'll be very capsule sharing it. So we used it both cells as well as conditioned media in the diabetic model as well as in the non-diabetic model. And we said, and the paper is out there, we said that yes, we can use in a xenogenic mode. And with that, we moved and generated little more data for us through Westerns and ELISAs. The point, why did we do that? It's not that lyophilization, I already discussed with the gelation, the lyophilized powder and mixed it in a gelation media and move on. But there was another point for us. What is the time when we really collect this conditioned media? So our ELISAs really enriched us, saying that it is not the first 3 days. You need to wait for at least 4 days. I'll share that in detail. So after this, then there was a UPCAR project with Dr. Vikas, and this was the work we conducted using a goat model and generated all the information for goat model and used it in a guinea pig model, again the same way, and the results were fantastic. And his project was very, very well taken at UPCAR, when that is a UP Uttar Pradesh Science and Technology Ministry, from where he was funded. And you can appreciate the treated and the control pictures of a histomorphograms out here. And this table is clear to say, and we said in the end, using a caprine original conditioned media in the guinea pig model, that it did improve the wound healing rate as well as the quality of the healed wound. So after that, we became a little more wiser, and we made elaborated experiments. Here we generated actually we have generated all kinds of conditioned media. It was a thumb rule for all the students and scholars in the laboratory. Please do not trash conditioned media, store it, and we would in turn lyophilize it. But this piece of work which I'm sharing, 3 conditioned media of canine origin, caprine origin, and guinea pig. Guinea pig, because we wanted to do the allogenic study as well, since our experimental model was guinea pig and the excisional wound we created in guinea pig. Similar thing, lyophilization and mixing into the laminin gel. And these are the set procedure which we have been sharing at the ISSRF platform. Dr. Pratish's work, and he did not stop there. After joining CMC Vellore, he moved to Australia through Endeavor Fellowship, and he is right now at Tennessee with the Fulbright Nehru Fellowship, continuing the work in a similar line. Maybe next year he would share the work which he's conducted over there. So we moved on with this experiment, and what did we find? This is the work we generated. First, we had to generate cell by all means and do the ICC to localize this angiogenic factors over here, and then generate the Westerns for all 3, canine, caprine, and guinea pigs. And the similar thing, excuse me, similar thing, that what exactly is the best time. So 72 hours was not bad, but 96 was the best out of it. So this became by default 96 hours, post 96 hours, collect the conditioned media. And now all the work, whatever I'm sharing, the conditioned media is always collected after 96 hours. So this picture is a very happy picture when you compare these heel wound, the quality of the heel wounds and the detailed post incision in all the three models, canine, caprine, and guinea pigs. So one can clearly appreciate this as well as a graphical representation of a wound contraction and also the pictorial representation. And I would fail if I don't say that why 28 days, because that's the time physiologically is recommended, and that's the one which we have been following through and through. This is all the beautiful histomorphograph which we generated with the help of pathology division over there, and the epithelialization, neovascularization, collagen thickness, as well as arrangement was put in a graphical way with clarity. What we said, not only we published in 2020, what we said it does contain a cocktail of mitogens, and it's a better for wound healing allogenic one for sure. And we also said that if we administer this allogenic conditioned media, it could be proposed as a novel therapeutic agent in treatment of particularly the skin wound dressings, and this may provide a very easy alternate for cell-based therapy. I always thought, and I'm still thinking, why can't we have those handy plus kind of thing in the supermarket, saying that the veterinary animal scientist group has generated. I think we have neared towards that when I shared so. Then two chairs, I do have 6 minutes or so, so I'll share this work as well. So the biomesh, then after that, we were working with the scaffolds. I shared 2 scaffolds only, a couple of them we worked. Then we moved with the biomesh, impregnated with the different MSCs and its conditioned media, because by this time, our lyophilization and gelation process was at place, and the stem cells were doing very well using this scaffold. So we also use it for conditioned media. And this is what exactly it is. For this group, I may like to say, once we impregnate this biomesh to use as a scaffold, not only we use a fresh and frozen thawed one as well. I'll not deviate to talk about that, but I'll focus on conditioned media, what I'm really continuing now. And this was a work when we used again the same wound model using a guinea pig, and we have we use the lyophilized conditioned media and MSCs only, and this is only the media wherein we grew the MSCs, or wherein the conditioned media which we collected, it was a modified knockout conditioned media. So this is all the picture, and this work was published in Biomedicine and Pharmacotherapy, further enhancing the role of this lyophilized conditioned media work. And these are the pictures of the histomicrographs of the skin healed wounds of the model of which we used for the biomesh, which was having the conditioned media in a lyophilized mode. And this was a quality of the healed wound. So what we said thus, if you use this conditioned media onto the scaffold for better quality wound healing, it does have a capacity. And mesh, we said it can be used as a vehicle for the delivery of not only the stem cells to the wound bed, but also the conditioned media. I'll take another maybe 1.5 to 2 minutes to say, then we thought that we were using a non-biological scaffolds. Why not use a biological scaffold? So we moved on to the periosteum. Why periosteum? Because now we wanted to move away from wound to the bone repair. So we chose periosteum. This wise group would really agree and appreciate the choice of periosteum. So this is a way we use a periosteum, decellularize the periosteum, and once we decellularize, again, the pathologically it helped us making a difference, no cells and cells and no cells and cells. Both HE as well as a mesenteric staining is allowed to make us clear that how best they were decellularized. We again went on to recellularize these biological scaffolds, and we wanted to compare the non-biological as well as the biological metrics in the now this time the radius healing. So we created a 10 mm segmental defect in the mid-diaphysis of radius bone. For this, we used rabbit because the guinea pig radius becomes very small, and there's a issue when we work. So we use a rabbit model here. So we used hydroxyapatite all the times, and with biomesh, which was augmented with the conditioned media, lyophilized conditioned media, and we use a biological scaffold also. So what we said, the radiographic images.
Ma'am, please speed up. Sorry.
Yes, I will. So this is for 1 month and 2 months in different groups, and radiographs are clear enough to say what exactly we did. So I will skip it. Only I'll say this periosteum, decentralized periosteum, when we augmented with the conditioned media, it could be used very efficiently for fracture repair and therapeutics in the veterinary orthopedics. Another half a minute. What now we were generating different hydrogels of a silk fibron extraction, did a dilation work, MTT assays, generated different SDS page, and our SAM pictures said how good our hydrogel. So this work is continuing over there. And what I was showing to this platform, the use of stem cells and the publication in stem cells, all the work in the last year. I'm happy to share this slide wherein I am saying that yes, the conditioned media is doing equally well, and we have applied a provisional patent for the biomesh scaffold, which we were augmented with a conditioned media. One technology we have given for commercialization for the conditioned media formulation for wound healing specifically, not for the bone work. I shall fail in my duties if I don't acknowledge the team which has worked, all the students and colleagues, clinical colleagues, specifically when we go for the bone model, the pathology group, specifically Dr. Sai Kumar and Dr. Karikal and Dr. Rath at CDRI, wherein we used all the in vivo imager there. At NIAB, a fraction of a second I'll take, in last 2 months when I joined, we started where hydrogel where we left. Here we have colleagues, Dr. Sandeep Goyal was already working on a stem cells. So we joined hands, and the third partner, the team is swelling, but right now we made 2 grants. We wrote 2 grants, and one we submitted wherein we used Dr. Gandhi because she's a person who uses a biosensor platform. And me, Dr. Goyal and Dr. Gandhi would be moving on with that. And I thank ISSRF and chairs for and I thank esteemed colleagues for the patience hearing. Thank you so much.
Thank you, Dr. Taru, for your very nice presentation and the beautiful work you have done, how you've proven how you're using MSCs for wound healing and the scaffold work. They are really exemplary, and I think that really proves the use of these MSCs. So would you like to take some questions? I can see some in the chat box. That would be nice if you can answer.
My pleasure, my pleasure.
So there are some in the chat box. Would you like to read and comment on those?
I'll do so. Give me a minute.
It can be done later on also.
Whatever
you can answer in the chat box.
Okay.
Yeah, we can move to the next speaker. Thank
you,
you, ma'am,
so
to
much.
balance the timings.
Sir,
thank you.
Okay, thank you, ma'am. Thank you so
We
much
don't
for
have
your
both
nice.
the next oral presenter, so we can take like a few question answers.
Okay, great.
So I'm privileged. Thank you, Dr. Bharti. Yeah, I can see. Thank you, Dr. Kamboj, Dr. Sandeep Goyal, and Dr. Rajesh. Dr. Rita has asked about that. Dr. Rita has said the immunomodulators and MSC conditioned media, those facilitate. Well, Dr. Rita, here immunomodulation is not an issue. We don't have any cells. This is only the fluid, So we can do away with that. This is the answer for your question. And Dr. Rajesh, Dr. Deepa, All right, you said about the cardiac defect, very interesting. 2 days back from the Jubilee Hills, we had one surgeon, cardiac surgeon. He does a lot of open heart surgery. He came to us and he did show interest, and I don't know how do we move on, but we did have a discussion. So thank you very much for that. Dr. Kamboj, thank you so much. Always you motivate. Thank you for that. My colleague, Dr. Goyal, thank you. Dr. Sudipta, thank you very much. Dr. Tirumala Rao, all right, thank you. Malini, thanks Malini. Thank you, Dr. Tirumala. Dr. Deepa Bhartiya, thank you. I really need best wishes. And we had to move on. Only the team is new, but we are allowed, the work continues. Thank you, Dr. Kuldeep, for that. I think the chat box is over, Dr. Manivanan.
Yes, sir.
They are not
Thank you.
speakers, so if some oral questions, it will be my pleasure taking that.
Thank you. Thank you, ma'am, to finish in time. The next speaker would be
Sir, excuse me, sir. We don't have this these speakers present, so I would request you to conclude this session.
Okay. Both speakers are not available.
No, sir. No, sir.
Okay. So the session is balanced now. Yeah. Thank you. Thank you. Thank you. We have a wonderful session. We feel good to have this nice session, and almost all the speakers were seniors and they are well known in their own field. Dr. Durusha spoke about the role of progesterone in luteal support during fetal embryo transfer cycle. Particularly, he has shown the evidence that the HCG has less role in luteal support. Dr. Akbar Shah gave a lot of information on epididymal sperm maturation, and particularly has shown how epididymis is so sensitive when exposed to toxic substances. Dr. Taru Sharma, again, he is expertise in their own field. He was speaking about how mesenchymal stem cells could be used in tissue engineering, particularly in wound healing. So with this, I am thankful to the organizers for giving this opportunity. Now, Dr. Bharti can give the concluding remark.
So I would like to once again thank the speakers for their very lucid talk, and Dr. Durusha, Dr. Taru Sharma, Dr. Abraska, excellent talks, really leaders in their field, and it was so, we were honored to hear you and have you as
thank you, Dr. Bharti. Thank you.
Speakers in our conference. And I would once again like to thank the organizers, Dr. Loya and Dr. Ansari and Barkha for inviting us. And it's so exciting to look at the such great talks and such good work being done in our country. Like I'm being a medical microbiologist, we are, it's so exciting to see this kind of work in the basic sciences, both in veterinary field and in the human field. So honored to be part of this group and this conference. Thank you so much, everyone.
Thank you, Dr. Bharti, to be a co-chair with me. Very nice.
Thank
Over
you.
to the organizers now. Thank you.
Thank you, sir, and thank you, ma'am, for wonderfully chairing the session. Thank you to the keynote speaker, invited speakers, and oral presenters were not there for the wonderfully giving the talk. So we will move to our next session, which is translational technologies from the animal sciences for reproductive health. And the chairpersons for this session are Padma Shri Dr. M.L. Madan, whom we have already interacted in the inaugural session. Welcome, sir. And Dr. G. Taru Sharma, Director, NIAB Hyderabad, and whom we just heard in the previous session. Welcome, ma'am. I would request both of you to please chair this session. Over to you, sir and ma'am. Thank you.
Thank you very much. Sir. Sir, you are mute, sir. Madan, sir, you are mute, please.
Thank you very much. Firstly, it was a scintillating talk, Taro, and enjoyed. And now it's very good that you are chairing the session in here along with
Thank you, sir.
This session, as you said it earlier, that we are going towards an area where we have got a large amount of collaboration and cooperation, in which the science from which one aspect of investigation is going and being taken up for the what we call as the bedside situations. And now this session, which is out for us today, is also the one which is going to illustrate several of these technologies which are available and have been used or are in the process of use for various aspects of reproductive health. I think, Taro, it will be good that we call in the speakers and listen to them, and in the end, we might like to have some comments to make, because we are already late in terms of the timings.
Sure.
So,
do I go?
Like to call the first speaker, Taro?
Sir, do I introduce Nakvi, sir?
Yes, please.
Okay.
Go ahead.
Fine. Thank you very much, respected Professor Emil Madan. And in this session, as was introduced by the organizers, the very first speaker is Dr. SMK Nakvi, the former director of ICR CSWRI, a very reproductive physiologist. Sir has his own expertise and his work, deep science, and especially involving the small ruminant, the sheep in particular. His expertise. He has a lot of laurels for him, as detailed out here. A good number of peer-reviewed papers, book chapters, popular articles, training manuals. His research interests, particularly, as I said, small ruminants, and in the small ruminants, sheep. Doesn't mean that he did not work on goats. He did do work on that also. So today, for this invited talk, he would speak on gene interregulation for augmenting reproduction and fertility. Over to you, Dr. SMK Nakvi. Welcome, and the floor is yours. Please share your slides, and we go on with you.
Give me one minute, please. Yeah?
Please take 1.5 minutes.
Yeah.
We can see you, not your slides.
That's why. Just a minute, please. I'm not able to load it.
First, you keep your PowerPoint presentation open, Dr. Nakvi.
That's why. I'm just trying to. It was open, but sometimes.
No problems. No problems. Open it and then go for the shared screen.
Sir, you can click share screen and start sharing your screen. Now you have been made the co-host again. I think you logged off into them. Yeah.
You have to press share. And if you have opened up your...
Mail your slides to us.
This slide is open. I'm not able to share it. I was sharing it earlier.
Click share. Press on the share, then you will get all on the screen.
Dr. Nakvi, first open and minimize, and then go to the share.
Yeah, I open it and then minimize
Put
it.
the PowerPoint, minimize it,
Yes.
and then go to the share. When it comes on the share, then click on that.
But that will come on the screen. Yeah.
It is not coming, sir. It is. I think I missed this.
Can organizers help, please? Can organizers help if they have his presentation?
We don't have his
Have you sent to a presentation?
Oh, yes.
Organizer?
Again, I'm opening this.
Dr. Nakvi, if you could mail me your presentation, I'll immediately open it up here.
Okay. This is sharing. This is sharing screen. Then I will open the slides.
Yeah. If you have minimized, then press on that.
Is it now?
No.
No.
My slide is there.
No, Dr. Naqvi, kindly mail me your slides. I'll do it from you. In a minute. Okay, fine. Oh, here you go.
Yes.
Yeah, you are there.
Is the slides is there?
Slides are there.
Now you yes, expand. Yeah.
Yeah.
Slideshow mode.
Acha, slideshow.
In the bottom you see lower cursor.
Yeah.
Yeah, you go, move to your
right. Slideshow, from beginning.
Sir, where 67% is written, just before that, left, you click on that symbol.
Yeah.
When it is written 67%, just left to that is a symbol, just click on that.
This one. Yeah, you reach. Click.
Yeah.
Welcome, most welcome. Go on. Please go on.
Thank you very much. Yeah. Sorry for inconvenience, actually.
It's okay.
Honorable Chairman of the session, most respected and honored Padam Shri Dr. M.L. Madan sir. And I know that my association with Dr. Madan is the last 4.5 decades since I joined my master degree at NDRA Karnal. I know his how efficient he is in transforming his capabilities into abilities. When I joined, I saw his laboratory was in very primitive stage and very hard working and all association with his students, so he could transform this laboratory in a world famous laboratory now. Now, I remember those days when we started the radioimmunoassay in his laboratory and how much it took that to standardize even the small hormone. Dr. Suri was there with me, and then LH standardization took even so much time and extraction of the hormones from the blood, and then from that laboratory now it has come so many advancement. I know about his students that they are having the very big position in his careers. There are Vice Chancellor, the best example is MS Chauhan, who is now Vice Chancellor of the NDRI, and ADG Dr. Prakash, and many directors of the research institutions, and also many of his students in abroad in decorating the very good positions. With this, actually, I am very much thankful that his interest was not only on the basic and advanced sciences, but also is always concerned about the stakeholder of the livestock production. Am I audible to you, sir? Hello.
Please go ahead.
Then I remembered that when I was there working in the MSc under his leadership, he sent us to the field and then realized that the problem of the farmers and how best we can do by using the reproductive physiology or reproductive biology science which we are making in the laboratory, it can be transferred for the welfare of the poor farmers, the livestock owners in the country. With this, again, I saw the co-chairperson, Dr. Taru. She is a colleague to me, and I know about his capability and his hard working, and is working in the field of the most advanced aspect of the science. And at the outset, I also thank the organizers of the ISSRF, particularly the president of ISSRF, Dr. Lohia, and Dr. Ansari and his colleague for giving me this opportunity to talk about the very poor animals of the livestock species, that is sheep. It is small but very beautiful in the sense that is providing and working. It's the first domesticated 10,000 years back, and since then is serving to the humankind by providing the cloth as well as the food is concerned. With this background, I would like to share that sheep, which we talk about the sheep species attributability, we consider is a future animal of India or of the world also, because these recent studies done in the East African countries that shows that because of the very heat stress, the climatic change and the global climate condition is concerned, the most livestock will suffer. And these two species of the small ruminant, I think they will survive, and they can sustain the high degrees of the climatic change, high degrees of the stress, and even then they can survive, they can thrive, and they can produce mutton, they can produce the food and fur for the humankind. That we know that there is a problem of India is not only the human population, but probably problem is also livestock population in the country. We know that about 17.5% of the human population, working population in the country in India, and the livestock is also about 11%, 535 million. And because of the very restricted or very, limited natural resources available in the country, that fate of the livestock production, what will be the fate of the livestock, unless we talk of their production potential, and especially we do not have the water for percent natural resources. And these two species, we talk of the future animals, but also we say that these animals are blessed by the Lord Isa Masih, when you start at rear and maintain these animals. And with this background, I must say that even the production potential of the Indian sheep is comparatively low. And where we have to look into then how we can improve their production potential so that it can give them much and more production level of productivity. We are second as far as sheep population in the country, but the production, if you talk, there is a very less of the wool we are producing. Mutton is also very less comparatively the figure if we compare with the total population. And we do not have the export potential of the mutton. Whatever the mutton is being produced in the country, it is being consumed by the Indian consumptions only. Okay. There is hardly, because we are producing about 770 million kg of the mutton that all consumed by the Indians, and no scope for the export, because the cost of mutton is almost same if you see the world price is available. So that these figures indicates that there is a lot more to do for as far as the improvement is concerned for their productivity. And when we talk of the reproduction, that why reproduction is very important for sheep production. Now, because the farmer's interest is only for number of lamb produced per unit time by one animal. So because more and more production is major interest of the farmers, because it gives about 70% of the total income of the farmers. And how it can be done, because until unless we talk about the reproductive efficiency of these animals, because the mutton production is directly proportional to the reproductive efficiency of the animal. So my topic today, I would like to talk about the refinement of the reproductive technology, the simplification of the reproductive technology, and their utilization at the farmer's level, at farmer's door, and that can subsequently impact their total production and productivity of the animals, so that they can get more and more income, which is the major emphasis nowadays by the government of India, also to increase the income of the farmers, or doubling the income of farmers. So there are major issues of reproductive efficiency is concerned, because animals, we see that as far as their age of first service is concerned, interlambing period is concerned, this is very high as we compare with the many advanced countries. So there is ample scope that if we can increase the reproductive efficiency, probably there will be much more increase. Then second thing, that we are talking about the very artificial insemination technique, which is viable enough in many large animals, and it is being subsequently utilized by almost all the countries for extensive exploration of the germ plasm and for improvement of the livestock. But it is still a question in case of the sheep production system is concerned. The low ability of elite rams, because we do not have the animals, and then there is not a single ram semen bank or a center in the country so far for the sheep. The problem is that when we talk of the artificial insemination, in case of the large ruminant is well established, and it is giving the wonderful results and increase the efficiency of productivity of the large animals, cattle and buffaloes. But what about the small ruminant? That is another part. That today we are producing about inseminating 76 million insemination, and we have the more than 235 frozen semen bank established in large ruminant. But there is nothing. AI result in field is not acceptable today, even in case of sheep. And there is no accredited semen collection AI center presently. These are the issues. Cryopreservation ram semen is another question worldwide. we are not able to use the cryopreserved reproductive for insemination even today for the sheep. Post ability, fertilizing ability is a question, and the technologies which is concerned about the transcervical or non-invasive type of the artificial insemination techniques are not available even today perfectly. We try to estimate how much REM requirement will be there to cover the female population. To cover about 74.3 million sheep, that breedable ewes we have just estimated about 45 million. We require about 13.8 lakhs of the elite ML. If you go for the natural mating, which is practiced today in the country, if you go for the fresh chilled semen, it will be at least 10 times less. And if you go frozen semen, which is not available, it will be drastically reduce the total requirement of the sheep REM. And for last 2 decades or 3 decades, we have been trying to come out with a very efficient technology for the REM semen freezing. And with our efforts in our laboratory, we were following the empirical type of research, altering different dilution rates, cooling rates, and then freezing rate, and the thawing through the, and then objective assessment for the computer assessed CASA techniques. We have done a large number of experimentation, and we now established a cryopreservation protocol for REM semen, which is efficiently working for all type of the breeds in all type of the season, and giving the post-thaw mortality invariably about 70%. This is the one of the achievements of the laboratory, where we can claim that REM semen can be frozen, and with giving the post-thaw mortality more than 70%. But problem was this, then when we using the frozen semen in the REM semen, frozen REM semen for the artificial insemination, if we go for the cervical insemination, non-invasive type, we don't get the lambing. The problem was that the post-thaw mortality is there, but we have lost, the post-thaw viability and fertilizing ability of the spermatozoa, so that the technique, if the sperms, post-thaw sperms are now injected or into the uterine horn, probably we get the good results. So by using the laparoscopic AI in the sheep, we could get the 44%, and invariably now many laboratories are getting 50%, and the latest figure has come more than 50%, which is acceptable. But only thing is that this is not the answer for the field condition. We can get the high fertilization rate, we can use the economic use of the semen, and these are some advantage for the laparoscopy AI, but it is for form or very established institutions where we can use the frozen semen by using the laparoscopy. We have developed different type of the laparoscopic, very simplified technique, so that we can, within 2 minutes, we can inseminate. But this is again the problem as far as the stakeholder is concerned, and the technique to be taken to the farm condition. Why actually this is happening? That when the semen is deposited or cervical non-invasive, we don't get the lambing. Major part is that they are not able to move from the os cervix to the uterus or the fertilization site and sheep. And we have done a large number of specimens collected from the slaughterhouses, and then we see that anatomical features of the sheep cervix is very tedious, and it is having some complication. That there are funnel type structure which is not eccentric. Even a simple needle cannot pass through the cervix, and this is a major problem. And the goat, probably this is relatively less tortuous canal, and number of folds are very dense. This is the silicone mold fold, which we have tried to understand the anatomical feature. We tried to cervical, transcervical artificial insemination using different type of the methods, and the instrumentation developed by us for our animals, by putting the rest different recumbency structure, and then using the cradle special design for this part, and we are able to penetrate some of the animals there. And we could get about 10 to 20% lambing results. But this is the major part of this, that how best we can understand when the whole lamb is passing through the same.
Excuse me, please. Dr. Pushpakant can mute himself, please.
But during estrus cycle or during estrus period, even small needle cannot pass through. But when we talk about the parturition time or delivery of the lamb is concerned, whole lamb pass through the same canal. So there must be some physiological and biochemical changes. So this is to be understand that what is happening, which can be, if supported by artificially during estrus cycle, can we do it? So we tried many type of the things that many pharmaceuticals agents, oxytocin, relaxin, and epidocin. We could see that it was relaxed because there is a tensile strength given by this collagen and the elastin by elasticity. But this thing happening, and by using our efforts, we could see that this cervix is relaxed, but it even and penetration was very easy for the catheter, and we were able to deposit the semen right into the uterus. We have used even the slaughter. We slaughtered the animals by using the even dye was injected, and we were successful. But unfortunately, even after putting the frozen third semen in the uterus or uterine horn, we did not get any lambing, very hardly any lambing. So the major aspect of the artificial insemination is still required to be answered by the national laboratories. That we want, this is a challenge, and as two scientists, as Dr. Madan said many times, that two scientists, the one who accept challenges and try to solve that problem, and that and goes to the field conditions. So laparoscopy was not answer, but even today the major part is that fertilizing ability of the spermatozoa to be addressed now, and then even after depositing semen or cervical, they are having enough viability to move themselves from the cervix to the fertilizing site. That is a major challenge. The second part of the embryo transfer technology, which is very common in large ruminant.
Dr. Naqvi, please hurry up. Please.
Yes, I will hurry up. That we have tried and simplified the technology for the laparoscope added embryo transfer, which was within 2-3 minutes we were able to transfer. This is our record that we could collect 24 embryos, and it was published in a veterinary record in a single time. And this can be propagated easily. This embryos were frozen first time in our institute in 1998, and after 60 days of the frozen time, we could thaw it, and we can again produce the elite animals out of that. This is the embryo recovery and transfer. That part is already non-surgical embryo transfer is not possible even today.
You go faster, we have time limitation.
Yes, I will just finish.
Yeah.
The another challenge with us
minutes.
that another challenge with us the early pregnancy diagnosis, that in human beings it is available, HCG test and everything, but there is nothing this type of the things available. Even CCMP has claimed that they have patented that even from this that they can strips can be developed for the early pregnancy diagnosis. So far this ultrasound is being maintained. We have developed different type of the cradle and standardized the ultrasonography with the early pregnancy diagnosis. We got the patent also for this. And these are the animals. That second part is very interesting. I would like to talk about prolificacy of the animals, that each animal can produce number of lambs. If number of lambs are produced in a definite time, probably definitely increase the productivity of the animals. So far, 3 type of these genes has been found word, the bone morphology protein 1b and the bone morphology protein 15 and growth differentiation factor 9 in different type of the animals. We are lucky. And this is a very interesting story, which I would like to, I would take 1 or 2 minutes for this. That in 1998, when Dr. Madan was the DDG, he is rather insisted to CSWRI to take out this. When other people, the story was this, that 250 years back, and some people from the Australia that took these animals, which is available, Garol type of breed in Sundarban area of Bengal, as a miniature animal, as a just show.
Dr. Naqvi, you have last minute, please.
Just please, let me give the 20 minutes. I will just, this interesting story which I would like to share with you, that this 1998 only we could get this Garol from the Bengal, which was having the extraordinary gene in it, and we tried to propagated in our animals. And the major problem was this, that when we brought it into the different environment, this is their survivability, adaptability was a question. And then they were not able to mate unless we use the reproductive technology for artificial insemination using fresh human, and we could make 300 animals at this institute. And first of all, we just bred these animals with this high body weight Malpra breed, which is giving only 1 lamb in a year, and this Carol was giving about 2 to 3 lambs in per lambing system. So but when we got the progeny, it was lower in size, motility is higher, and it was not acceptable. With this again, we tried with using the more blood of the Malpra sheep, so that the less blood is coming from the Carol, so size was increased. And lastly, because of the mothering ability was introduced by using the Patnavadi sheep, because the milk was more in those animals, so the survivability of the neonate animals increased, and then we are proud that we could come up with a Visham sheep which is carrying this FEGB gene. And this is the thing that at least 50% increase in the farmer's income was possible by using the indigenously make in India type of the work, and then future sheep for the more lamb and more life and more body weight. And this is already given to so many I mean states for their increasing the prolificacy income, and about 80% prolificacy is giving because a single gene, so that it is propagating in the progeny sentence. This is the, again, I can escape. This is a success story of this type of the animals that at least now we are having and supplying to for the country. Many states have been benefited by using that FEGB gene, which shall produce this is WRI. And this is the one example success story which I am given one time. If it is 4 animals are produced, they will not survive. But by giving the special type of the nutrition, they all 4 survive. At 17 kg is expected at the 3 months of age, but it was converted to 71 kg in 3 months. So it is a big thing, and then giving the special type of the this milk replacer type, the frost, it was possible to get and increase the body weight. This is the one thing which we would like to share just last few minutes, just 1 or 2 minutes, that what is challenge. Then this FEGB gene was taken from the India to Australia and then to Israel, and Israel has developed the multi-utility type of the sheep which is required to be developed in our country by using this type of thing, wherein they can get the milk, wool, as well as body weight is concerned. And this is the another technology which is very important for the sponge for synchronization, because if we import this type of the device, is very costly. It's not possible for our farmers. We developed the sponge technology for synchronization, which is giving 95% to 100% success rate. And its cost is reduced only 4 to 10 rupees per animal. We have used in about 60,000 sponges was taken to the different type of different corner of the country, and about the success rate of limbic rate is 63%, because artificial insemination in the is only possible when it is coupled with the stress synchronization, and the device is available with us, and it has proved to be given the very good lambing. The losses because of the
conclude, Doctor.
Yes. Okay.
Please conclude.
This is last point. This is an event type of the vaccine as we produce when we could with the DBT work we have taken. Second vaccine was improved. Invariably for 3 years they were giving the more and more ovulation rate, but because of the getting more ovulation rate, more lambs were produced and they did not survive. So this is the last one. I think I may thank you, sir, for question sharing. Thank you very much, sir.
I think you have taken us to a vast canvas from one end to the other end, and I wish that we had more details of these things concentrated over into fashion where we have got the crust of it. But you have very clearly indicated that how well we are in terms of bringing a genetic transformation with respect to fertility. And that also that how we are now talking in terms of having a better reproductive potential. Thank you, Dr. Naqvi, for this presentation. The next presentation, Taro, please go ahead.
All right, sir. All right. Thank you, Dr. Naqvi, for sharing this good work. So next we have, please unshare your slides. Yeah. So next we have, next presentation is by a colleague, another physiologist. Dr. Prem Singh Yadav. Dr. Yadav, you're there? Dr. Yadav, can we see you?
Here, madam. I'm here.
Good afternoon, Dr. Yadav.
Good afternoon, madam. Good afternoon.
Very happy to have you as a second speaker. Dr. Prem Singh Yadav is currently a team leader at a very important institute of this country, Central Institute of Research in Buffalo, located at Haryana, Hisar. He is a principal scientist at CIRB, and he's leading a team which has produced a clone buffalo bull, Hisar Gaurav, in 2017.
Hello.
And please mute. I request everybody, please mute yourself. Thank you so much. Dr. Yadav has done many good work related to assisted reproductive technology. Today, he will share application of the translational technologies in stem cell research for reproductive health. He also has enough laurels to him. I know it personally, and it is not written over here, but and he's a wonderful human being and a very good team leader. Over to you, Dr. Yadav. So 20 minutes are assigned to you, Dr. Yadav. It is 1 o'clock. Thank you. Go on.
Yeah.
Yeah, slides are very clear.
Okay.
Please continue. Thank you.
Thank you. Padam Shri, Most Honorable Professor Madan, Madam Taru Sharma, Director at IAB, and all delegates who are listening. I'm thankful to organizers for giving this opportunity to me. I will speak on stem cell applications, though Madam Taru have already told, but she has covered the clinical aspects. I will cover some other aspects, what are the applications in different fields. So everyone knows that stem cells are capable of dividing symmetrically and renewing themselves for long periods. And these are unspecialized cells which can give rise to specialized cells. So there are different types of cells, totipotent, pluripotent, multipotent. So our concern is mainly on the pluripotent and multipotent cells which can differentiate and give rise to other type of cells. In livestock species particularly, the applications are transgenesis, cloning, generation of chimeras, obtaining germ cells to treat infertility, studies on early embryonic development, and rapid screening of chemicals and drugs, and examining complex processes such as genomic imprinting and gene targeting. As you know, the source of the embryonic stem cell is this darker part which is known as inner cell mass. In a good blastocyst, there are about 30 to 35 cells in this dark part which are known as inner cell mass cells. And these inner cell mass, if propagated, they become the embryonic stem cells, and which can be utilized for different applications. This I have tabulated what are the applications of the stem cells in different species. Some are first are the general applications in animal model, human clinical therapy, application in veterinary and regenerative medicine, and derivation of pluripotent or iPS cells. This way, for conservation of genetic diversity, or using the donor cells for cloning transgenic, these are the general applications which can be used in any of the species. In canines, there is a particular application, canine dilated cardiomyopathy, spinal injury. Madam has already shown some injuries and even with diabetes and how to treat them with the stem cells. In equine model, particularly they damage their tendons and ligaments while they are racing. So this can be very good application in equines, and this can also be applied to human beings. In cattle and buffaloes, enhancing milk, biofarming through transgenic milk animals, reduction in emission of the gene greenhouse gases, in vitro meat production. These are applications in cattle and buffalo. Pigs have another important application because their organs are similar to human beings, and the organs and cells can be created for xenotransplantation and biofarming. In sheep and goat, the transgenic sheep and goat can used for production of in vitro mutton and chicken and conservation of genetic diversity. In poultry also, there is a lot of application of the stem cells, and these can be used for production of vaccines, particularly various therapeutic uses and minimizing the release of nutrients into the environment. So this covers all animal species where the stem cells have their specialized applications. So I will show you a little about the fetal stem cells, because embryonic stem cells are still not fully explored in the case of animals, but now the long-term cell cultures of the embryonic stem cells have been established in pigs in Germany. And there are some other reports from different countries. But fetal stem cells, they can be harvested from the amniotic fluid. Fetal stem cells can have equally good important criteria that they can be harvested from the umbilical cord matrix, amniotic fluid, amniotic membrane, and placenta. These are discarded following the birth, and less ethical reservations are involved. Amniotic fluid cells, you can have a look on how these can be collected, cultured, and multiplied. These cells, amniotic cells, have also potential to differentiate into other cell lineage, and they represent an intermediate stage of pluripotent ES cells and lineage-restricted adult stem cells. Similarly, umbilical cord matrix cells can also be utilized for this purpose. They also show equally good behavior in terms of their pluripotency. And fetal stem cells, even from the fetal fibroblast, they also show the characteristics of the stem cells, and they can also be differentiated. They can be differentiated into different three lineages, which can be utilized for further treatments. Amniotic wall cells, these are also utilized in human beings for treatment of the burn injury, because they don't have, these cells don't have any blood capillaries. So as such, the part of the amnion can be utilized for burn injury repair. And these are some characteristics, and we need to do the chromosomal studies and gene expression to establish the cells. In equines, I will show you little important aspect, because we have worked on equines also. And one most important thing is that the equine cells can be differentiated. Amniotic fluid cells can be differentiated into tenogenic cells. This we have proved by using a PMP12 protein to get the amniotic cells differentiated into tenogenic differentiation. So this is a very important application in horse, and this can also be utilized in human beings. So bone marrow morphogenic protein 12 induces tenogenic differentiation in mesenchymal stem cells derived from the equine amniotic fluid. And these are the differentiated cells, and this is the flow cytometry analysis of the equine amniotic fluids, which can be differentiated into tenogenic cells. There are commercial applications and commercial firms which are developing. These are some of the firms' wet stem strategy. They are using the amniotic fluid and other cells for treatment. Wet cell approach cells. So in different parts of the world, these animal stem cells are being used commercially also. So differentiation potential or the plasticity of the cultured cells into cells types like adipocytes, osteocytes, or neurocytes confirm which that the specific strains and morphology of the cells can be achieved. Equine amniotic fluid cells can differentiate into tenogenic cells, as I have already told. Another thing that we can make the stem cells by IPS technology, and in IPS technology, earlier it was a belief that once a ball have or a cell have crossed a particular lineage, it cannot be reverted back. But now with the forcible insertion of the genes, it can be reverted back, and using transposons also, the cells can be made IPS cells which have all pluripotent characteristics like the embryonic stem cells. So in conclusion of differentiation, Another applications of stem cells and the reproductive biotechnologies are in the biomedical applications. In Europe, medical agency approved human antithrombin 3 produced in the mammary gland of transgenic goats, which can be used, now has been approved for treatment. So Uterine is the recombinant human produced by recombinant DNA technology using genetically engineered goats, in which DNA sequence for human antithrombin has been introduced, along with a mammary gland specific DNA sequence, which directs expression of AT in the milk. So these are another transgenic biomedicine application in different species. I will like to show a little bit about the cloning also in few slides, what we have achieved in this country. So we have worked on 3 objectives of production of multiple clones, improvement of success in cloning, calf production, and evaluation of the. So this is the procedure. I will not go in detail, but we use the somatic cells and oocytes. Oocytes are matured, and the zona is removed, and the cytoplast is taken, and the cytoplast, the somatic cell is fused to get the embryos which are transferred in the animals. So this is a big achievement that 7 clones from a single breeding bull have been achieved, and this has been recorded in the India Book of Records of highest number of clones from a single animal, and also the recloning of a clone bull has been recorded in India Book of Records. We have multiple clones from the 4 animals at CIRB and NDRI, and we have also cloned a female which is producing the highest milk in this country in an organized farm at CIRB since inception of CIRB. Its dam yield is 4,810 liters. So these are the achievements, present day achievements of multiple cloning in buffalo. As far as the improvement of the success rate, when we started in 2018, the success rate was 1%, now which has been achieved more than 6 to 8%. And for this, we have used heifers as recipients and better calf management to get more calves and to keep them surviving and keep them healthy. So treatment of epigenetic modifiers also have improved the embryo production as well as the pregnancy rate. In evaluation of the clone bulls, it is most important aspect. All clones with their growth, fertility, and male clones has been established a similar node like non-clones. We have produced more than 75 progeny using cloned bull semen for AI, indicating their normalcy. Gestation, growth, health, and cloned bulls of progeny are normal. Some of the cloned embryos have altered DNA, but we have solved that problem also by using the epigenetic modifiers. Sperm transcriptomics studies demonstrated that mRNA and miRNA are similar to non-cloned bulls. So this have been highlighted. It has been tweeted to PMO, and ICR has also given team award for this work. And this was published in the Current Science on the cover page. We cloned a Assamese buffalo clone which was cloned in the field. So you can have a look that this is top ranked bulls 4354 4 clones we have produced. These are the 2 newborn clones at NDRI which have been produced in last 1 month. In a paper on 5-year study, we have studied the cellular physiology, cell cycle, embryo development, and concluded that growth, health, and fertility of the cloned bulls is similar to non-cloned bulls. This has also been tested on 4 bulls that AI and IVF-based fertility of cloned bulls is similar to non-cloned bulls. So these are the cloned bulls. And these are the 2 progenies of the clone bulls which have become bulls, and now they are producing excellent semen. So this proves that the next generation of the clone animals is also equally good. So these are the progeny of the clone bull at CIR, Vishar, and at organized dairy farm which we have MOU. And these are the progenies produced at NDRI Karnal recently with the 2 clone bull semen. So plenty of progenies have been produced both at both institutes and at some farmers' places who consented for this purpose. So these are some research that we evaluated the telomere length, and we found that these are comparable to the non-cloned animals. And sperm, miRNA, and mRNA are also similar to non-cloned bulls. These 2 photographs I will show that these are the cloned bulls at present available at CIRB, SAR. These are available at CIRB, SAR. And these are the clone bulls which are present at NDRI Karnal. So now we have more than 15 male clones which can produce more than 15 lakh semen doses. And these needs to be utilized for the breed improvement programs. So what we learned that multiple cloning is successful, decloning is successful, male clones have similar parameters, and progeny of clone bulls are normal. Telomere length, all the metallurgy and blood biochemistry and growth parameters are normal. So overall, I have shown the progress. I will not repeat it, but we have produced 75 progenies. We have more than 25,000 semen doses, established a somatic cell bank with elite animals of 60 animals. Male progenies, clone bulls are donating semen, and female progenies are pregnant and near to calving. So with this, I thank for the opportunity and patient listening. Thank you very much.
Thank you. Thank you, Dr. Yadav, for an elucid presentation.
Thank you,
taken us to an area in which that we have to be knowing more and more, particularly with respect to its implications in several aspects of reproduction, particularly the regenerative reproduction, as we talk of the regenerative medicine. I think that not only that, but our concerns, which were earlier with respect to the human populations when they get subjected to conditions of exposure to radiotherapy. At that time, that the various measures are being thought of today to save these human populations as far as their genetic cells is concerned. But here is the technology which you have, which the people, you and your group have bought in from a canal and this, and they have progressed to a level where we can have a young one being produced from a cell instead of the gametic cell. And therefore, that is a real advance. I know that as far as its utilization in countries' technology, Britain has just opened up it in terms of it for human populations, but I am sure that its demand will come because of the pressure which the science is putting on having the area going ahead for the betterment of human population. Thank you very much. And now, Taro, next.
Thank you, sir. Thank you very much. Thank you.
Right. Thank you very much, sir. Thank you, Dr. Yadav, for being very precise, and I'm very happy the way your work is leading on. Best wishes to you and your team.
Thank you.
Since he has respected time, we are left with 2 minutes. I think we can take 1 or 2 questions. And I would have a quick point for myself to understand. You said that you have got 25,000 semen doses from these clone bull, Dr. Yadav.
Yes, yes.
So my point is that have you used this semen somewhere, or what are your plans?
Yeah, we have used some semen. We have produced more than 2 dozen progenies at CIRB. We have MOU with a organized dairy farm at Sirsa, which they have 600 animals.
Wonderful.
So we produce more
That's
than
very nice to know. Thank you. Now
more than 50 progenies there.
Very good. Thank you. So now my point is that when we use the semen produced from this clone bull, do you really go through the permission from CPCSCA, or we can just please let me know.
We have permission from the Institute Ethics Committee for using this for this project as a whole, and now we also have one project from which has been approved by DBT, so that we can make use of this clone bull semen. We have written to our ICR, and our DDG and DG are taking up with the Department of Animal Husbandry so that it can be utilized and the bulls can be given to semen freezing stations. So that
no, my point was kind of different. My point was because it's not a semen from anyway, we can catch up later. It's a bit policy decision.
Yeah, it is a policy decision, and we are
Thank you so much. Thank you so much, Dr. Yadav. So may I introduce the next speaker? May I do that? Madan sir, may I do that? Dr. Madan, may I introduce?
Yes, please. I had said that you go ahead and announce.
Thank you so much. So next speaker is a young physiologist again, who is working on the male physiology, and he's Dr. Dilip Kumar Swain. Dr. Dilip is currently assistant professor at a sperm signaling laboratory at Dubasu, Mathura. And his work I personally know because a couple of DPT grants he works in. It's a very outstanding piece of work he has. His research interests are in sperm signaling, molecular basis of non-genomic signaling, and he's also looking towards and must have been started working on exosome and ion channels. Ion channels he was focusing earlier. He's got a couple of awards, and he's a gold medal holder at a master's level. He did his PhD from Karnal, and he graduated for his BSc from OUAT. Dr. Dilip Swain will talk on the title, which is detailed out in the slides. I invite Dr. Dilip to go on for his presentation. It is 1:20. You had 20 minutes. Please go on and share your slides.
So thank you so much, ma'am, for giving me this opportunity to present. I have shared my slides. These are visible.
They are visible. Put them on a slideshow mode, Dr. Dilip.
Ma'am, is it fine now?
It is not. It is not.
Put them full.
Go for slideshow, Dr. Dilip. Yes.
Ma'am, is it fine now?
No. You have not yet put them in a slideshow.
Ma'am, it is in the slideshow mode.
I don't know. Make it.
Can you stop sharing the screen, Dr. Dilip, and reshare? That would work sometimes.
You have to put it on the slide.
Yeah.
Is it okay, ma'am?
You can unshare and share again. You can unshare and share again.
Actually, I think somebody else is sharing. Okay.
It's okay now.
Now you share. Please share. Perfect. Go on. Go on, please go on.
So good afternoon to all. Esteemed inspiration to me, Madan sir, and esteemed mentor, ma'am Taru ma'am. Thank you so much to all the organizers of ISSRF to give an opportunity to speak on this big platform. The topic is deciphering the key signaling pathways of ion channels and hormones in regulating spermatozoa fertilizing competence in oviductine. There is a new dimension to understand male fertility. Before this August gathering, I need to say that a few things which need to build this hypothesis, and the journey was begun in 2013-14. When I entered this area in understanding the basic fundamentals behind the sperm and the sperm function. And I strongly believe that the semen as a whole is very complex, and it is very difficult to understand the sperm functionality. The new concepts which are coming into this sperm biology, that is the sperm subpopulation, and every individual sperm is having its own signature for fertilizing competence, making the science more complex. In spite, we have lots of development in technological front and also scientific front, but still we are not able to fully understand this particular part, that is the fundamental sperm physiology, which needs our attention. So I thought I should share another slide to you. From a sperm cell to a fully developed Homo sapiens, and still some people think that I am not progressive. This is a very famous quote. And another one, this article actually changed the entire mindset of the last 100 years of the sperm biology. That was published in Biophysics in 2020, where we came to know that the sperm swims, but that those are the asymmetric movements of the flagella, which causes the rotation of the sperm head. And earlier we are considering it was the sperm tail which is moving. So these things are coming into picture now, and these are making both the intervention of the technology as well as the fundamental science to integrate to more understand the physiology. So where we started, actually, I need to present the holistic approach which we have followed from 2012-13 and till now 2022. We started from this was the first work where we characterized the voltage-gated sodium channels in the bull spermatozoa. Our study reported that these channels are involved in the process of regulation of motility, capacitation, and acrosome reaction, but it shows concentration and species-specific variation, and we compared with buffalo and also the goat spermatozoa. This was the second study from our group where we characterize how these voltage-gated sodium channels are involved in the process of regulation of molecular events of capacitation. And if you block the sodium channels, what will happen to the spermatozoa? Capacitation and acrosome reaction. This was the third study from our group, that is voltage-gated potassium channels. One of the most important channels which regulate the volume of the spermatozoa while it moves in the oviduct, and it decides that whether the spermatozoa is going to show swelling or osmotic imbalance, hyperpolarization like events in the oviduct. And this study elucidated that yes, bull spermatozoa, if they are blocked with potassium channels, then they do not show the motility, fast motility and capacitation. This was another study from our group that is regarding voltage-gated proton channels, and where we characterized that if these channels are blocked, then the sperm are failed to show the capacitation, because these are those channels which shows the extrusion of the the hydrogen ions when the progesterone acts on the sperm membrane. So these studies shows that intracellular and extracellular pH regulations are very important, and they say us that in the oviduct a very precise and time-based mechanism operates, and this switching on and switching off of these ion channels regulate whether the sperm is capable of fertilization or not. Another study from our group where we characterized TRPV1, that was in 2018, and this channel is preferentially associated with the thermotaxics event of the spermatozoa. When the spermatozoa moves from the uterotubal junction, it requires a chemical gradient, a thermal gradient, and an hormone gradient. This particular thermal gradient is sensed by the spermatozoa. Even in the oviduct, where the temperature is 1 to 2 degrees centigrade higher as compared to the external environment, where the sperm gets adapted and moved towards the oocyte, requires its sensing power. And that sensing comes through the TRPV1 channel. And if you block it, then the thermal sensitivity in the spermatozoa is lost. So these are some of the studies, preliminary studies, 5-6 year studies. We have characterized around 7 sets of ion channel, their functionality, their association with the sperm function. And from there, we developed this model. And this model was a simulating model, and which we thought that it is being occurring inside the oviduct, where the oocyte is waiting with the mature cumulus cells, which are secreting the progesterone. Near to the oocyte, it is in micromolar concentration, and as you move away, it maintains nanomolar, picomolar, and a gradual process of sperm selection occurs. Now here a question arises: why fundamentally selection process starts? Whether all the spermatozoa are equally capable, or is there any mechanism is there which are making the sperm to crosstalk with the oviduct, and with the presence of some of the ion channels, some of the hormones, some of the chemical modulators, all these things need to be elucidated. Many things are known, but the exact mechanism how this sperm selection occurs, that requires attention. And from here we began our study again. That is these are the current studies we have carried out in the last 2 years, where classical seminal plasma experiments we started. What we carried out, now we simply remove the seminal plasma and dissolve the sperm pellet in the sperm tube medium. And another one is with the seminal plasma. And what we observe that if the seminal plasma is removed, then the degree of capacitation reduced under the influence of the progesterone. Same to that, acrosome reaction reduces. Same to that, the mitochondrial transmembrane potential, which is required for the prerequisite of the capacitation process, that also significantly reduces when you are removing the seminal plasma. Then once you go for this apoptotic spermatozoa, it appears that seminal plasma prevents this spermatozoa from undergoing apoptosis. Next one is that intact membrane with viability, that also reduces when we are removing the seminal plasma. Free radical content, it means seminal plasma provides antioxidant defense, and if free radical content is increasing, as such, then they will not respond to progesterone, because action of the progesterone increases intracellular free radical. So we have seen that the free radical content is also rising. Then alkaline intracellular pH, another requirement for the induction of the capacitation. If you remove the seminal plasma, then the pH becomes acidic inside the spermatozoa. Then another one, that is polarization process, because this is the event which decides whether the sperm will undergo the process of capacitation or not. If seminal plasma is present, then yes, there is a possibility of more capacitation compared to the without seminal plasma. Then the last part where we come to the motility and motion part, where we saw that removal of the seminal plasma reduces motility, fast motile population spermatozoa reduces, slow motile population increases, and the circular motile percentage increases. And then we came to the kinematic analysis, where you found that there are 3 divisions of the subpopulation, which are showing 150 to 200 micrometer per second curvilinear velocity, 200 to 300, and more than 300. So it says that this seminal plasma constituents are favoring the process of the motion, the viability, the apoptosis, the capacitation, and the acrosome reaction. So we all together, once we characterized that, we found this summary that seminal plasma plays important role. And there is a possibility that when we are freezing the semen, we are diluting the seminal plasma to a lot. And there is a possibility that this dilution may reduces the effect of the seminal plasma, and therefore we are not getting that quality of the post motility or post quality of the spermatozoa. Possibility is there and needs further elucidation. Then we carried out tracking studies, because I have an advanced CASA where I didn't do the motion or kinematic analysis. Rather, I do the sorting analysis, where I sorted 20,000 spermatozoa from one sample, and we pull out that this spermatozoa is not homogeneous, it is heterogeneous, having 2 to 3 populations. And these 2 to 3 populations are showing differential responsiveness. And this differential responsiveness is due to their differential capacity to respond to the hormones and the chemical messengers. So our study shows that there are 3 subpopulations are there in bovine semen, and 3 in buffalo, but 2 in case of goat semen. And these are some of the studies, and this is the diagram which we have developed, that responsiveness of the spermatozoa totally depends whether they are being swim upped, means they are moving towards the gradient or they are not moving. So to further validate, we carried out another series of studies, and these series of studies are nothing but the swim up studies, where we developed a technology. From this project, we have developed this technology, that standardization and development of a new swim up technique for getting better spermatozoa. And by this technique, we are seeing that the responsiveness of the spermatozoa to the progesterone is increasing. So these are some of the classical studies we have carried out by taking sperm talc and another medium with sperm talc with progesterone in nanomolar and picomolar concentration. And we have marked that recovery of fertile, motile, viable, intact acrosome spermatozoa increases with the addition of a progesterone concentration in the sperm talc medium. So these are some of the studies. I'm just skipping, but outcome of this protocol was this one. Now we have seen the tubal fluid, which is a classical one, where the sperm is homogeneous. Sperm talc, here 2 subpopulations are seen, but in the sperm talc capacitation come progesterone medium, if you see, then we are getting a very fine difference between this faster group of spermatozoa, better group of spermatozoa compared to the lower population. So this was the development, and the summary was that we have developed a technique by which we can get better spermatozoa with higher fertilizing competence. To further, again, we carried out this subpopulation study. As I mentioned, that when you go for the tracking study, we will get 3 subpopulations. So we thought that why not to further characterize them? Why not to see that how they are responding in vitro medium, and are there any mechanism by which they can be integrated into the in vivo conditions? So our study shows that yes, subpopulations exist. Fast motile, slow motile, circular motile spermatozoa are there because of intrinsic property. But we have seen the population which are fast motile, they are responding more to that of the progesterone gradient compared to the others. So some of these are these classical experiments which we have carried out to classify this spermatozoa. You can see that there are a heterogeneous population of cells on the basis of kinematics. This is linearity, then average path velocity, Intracellular calcium means those who are having high intracellular calcium, they cannot be capacitated. Those which are medium, they will be capacitated. Those which are low, they may not show the process of capacitation. And we are on the process of justifying these results, earlier results. So these are some of the data which I'm just skipping. Now, coming to another point where I want to show that how we have drawn the conclusion that the semen is existing with the subpopulation. Differential medium is existing outside. Then is there a possibility that there is an interplay is existing? Because this interplay study taken 2 years of time. And we focused on different interplay mechanisms at a time. So we developed these 8 signaling pathways which are classical and which occurs. So we thought that we should characterize. This was our master diagram, which we focused. And this year, fortunately, we are having an acceptance from a journal where it is going to be published very soon. And we characterize progesterone cat-spore pathway, intracellular calcium pathway, cyclic MP PKA pathway, MAPK pathway, AKT SRC kinase pathway, GABA receptor pathway, tyrosine phosphorylation pathway, TRPB1 pathway, endocannabinoid receptor pathway, and lastly, we developed this summary diagram where we are saying that spermatozoa is responding to multiple signaling pathway at a time. It is not a single pathway which is occurring, and if you are blocking that single pathway, it may hamper the process, but it will not completely abolish. And these 2 diagrams summarize our activity, that how we have blocked several pathways during our study in vitro conditions, and we are seeing how these pathway blocking is affecting the process of capacitation and acrosome reaction. So these are interplay pathways. New findings: semen ejaculates, so 3 subpopulations which are differentially responsive to progesterone. Free radicals, intracellular alkylation play major role in progesterone signaling. Tracking and sorting depict the presence of different kinetic population of sperm cells. And this is mediated through novel GABA pathway. This was the new pathway which we have discovered that it may be occurring in bull spermatozoa. So Rome is not made in one day. Having said that, well, still we have to go a miles. Understanding the role of seminal exosomes, this is now my focus. Techniques for separation of sperm subpopulation. Understanding the fundamental biology of seminal plasma proteins, which yet to be understood in animal models. Development and standardization of multiparametric flow cytometry for sperm functional analysis. And microfluidics based technique for understanding the precise role of ion channels. This is my group. When I joined this Dubasu Mathura, Dr. Sarojit Yadav was my head of the department. He helped me a lot in doing all these experiments. She was in my project, Dr. Pratishta, who helped me a lot. This is our laboratory group, and these are my real heroes for which I am presenting today. Dharmendra Singh Chauhan, Abhishek Misra, Hanuman, Nadeem, Rishi, Akhya Rajawat, and Dilip. They are the real heroes behind this story, what I told you in the last 10 to 15 minutes of time. So thank you so much to Government of India, particularly Department of Biotechnology, for funding me so that I have carried out this kind of studies. Thank you so much. As I said, sir, I have not got an opportunity to study the ion channels because I don't have any electrophysiological setups. But I believe that these ion channels are the major regulators of the sperm function, particularly in the oviduct. I should not forget the lecture which was presented by respected Agrasa sir, that when he was saying about the epididymosomes, I also believe that we have already started when we are taking the epididymis secretions, particularly the cauda secretions, and we are incubating with the spermatozoa. We are seeing population of the spermatozoa are decreased into 2, and they are less responsive to that of the progesterone. So it clearly says that there is a complexity still exists, and there are many lacunae there which need to be understood in the coming years. And coming to the seminal plasma exosomes, they are also having the targeting molecules which are signaling. And we have to have a complete holistic idea. Now, integration of all these will give us an idea how actually seminal plasma is regulating sperm function. So thank you so much for present hearing. And I should not forget to thank you, Madan sir, who was the Honorable Vice Chancellor during the selection process of mine in Dubasu. So he was the man behind my selection. I should not forget Ma'am Taru, who is always instrumental in helping me in the DBT presentations, funding mechanisms of the project. I should thank all the students, all my colleagues who are there with me, always helping. And I should not forget to thank my wife, who is always helping me to go to the lab and work and do something. So thank you so much all.
Thank you, Dilip, for this lovely presentation. I would love to see that if there are some questions, there might be some questions into there, one or two questions. Is there any question now?
Sir, may I ask one question, sir?
Yes, please, go ahead.
Thank you, sir. Dr. Dilip, it's a really scintillating presentation. Very nice to hear you. I have one doubt. You told that semen plasma components may benefit, addition of semen plasma components or addition of semen plasma may benefit or enhance the motility or viability or fertilization accumulation capacity in the spermatozoa. Have you fractioned the semen plasma components or like proteins, have you isolated and added to the spermatozoa to see their effect?
Sir, thank you so much for this question. This was in 2017 and already we have a publication from that. We isolated this sperm plus seminal plasma proteins, and we have incubated with a concentration gradient from 0.1 picogram to 1 microgram. And we have carried out 7 sets of studies where we have seen that if the seminal plasma is in micrograms, then it has seminal plasma proteins in microgram, then it enhances motility. Once you increasing the percentage of this seminal plasma proteins, we have seen in vitro that the motility reduces and the sensitivity towards the chemical gradient also decreases.
Whether these proteins belongs to heparin and gelatin group or any other group?
Sir, we have not characterized these proteins. That's why in my conclusion slide, I have kept that second point. I have to work on this further, because we have isolated as a whole, but we have not characterized them into fractions. So it requires our further work.
Okay, thank you so
Dr.
much.
Dilip, in the chat box, there is a question for you by Dr. Sudipta. And Sudipta says, is there any difference in fertilizing capabilities of different subpopulations of spermatozoa? You may like to address.
So Sudipta, thank you so much for this question. Wonderful to hear you also. The point is that subpopulation studies, we are failed to isolate these subpopulations from this group. We have not yet developed a technique by which I can isolate the population. That's why we carried out the swim-up experiments. And when in the swim-up population, we have isolated the upper group, that is which is being characterized, that shows higher responsiveness to this progesterone and all other chemical gradients. So we hypothetically modeled that process into interplay, and we are seeing that this is the subpopulation which may have higher chances of fertilization as evident from motion, kinematics, and functional attributes. And we have compared this with the middle population and also the lower population in that group. So coming to a conclusion, yes, subpopulations are having differential responsiveness, but their fertilization outcome is yet to be validated. These are all in vitro conditions and in vitro studies. So I hope in coming years, I will come into certain conclusions that how I can isolate these subpopulations, characterize them, and I should have some fertilization trial data to present in front of you. Thank you.
Dr. Dilip, I have a question. You have used progesterone to segregate the different populations, right?
Yes, ma'am.
Yeah. But if you can, is it possible to use those segregated population for fertilization or in intrauterine transfer? Because already you are giving progesterone and they may be capacitated.
Yes, ma'am.
Premature capacity problem will be there.
The message should be very clear that progesterone in 1 picomolar and 1 nanomolar concentration is capacitative, and 1 micromolar concentration is said to be acrosome reacting. So I should not share everything because I am applying for a patent for this particular swim-up technology, which we are thinking that this is the best technique for isolating high or fast motile spermatozoa. We should not forget, ma'am, that those spermatozoa which are high motile or fast motile, they are fertilizing. We should say that those population of spermatozoa which are highly responsive, which are showing the process of true capacitation, they are actually having high capacity of fertilization. So this progesterone gradient, what we are using, this is in thousands below this picomolar concentration. And what we have thought of, now we have thought of that if within a time of 5 minutes, because the total incubation time is 1 hour, but within 5 minutes we have seen 5 to 10% of the spermatozoa undergo spontaneous acrosome reaction. And this part we are not able to avoid. So that's why we thought, why not to give the lower concentration of progesterone below picomolar or nanomolar, so that in femtomolar concentrations, I am saying, ma'am. So there we are seeing fast motile population is rising beyond 55 to 65%. And that is what the achievement is. So it needs another 2 to 3 years.
Thank you, Dr. Dilip. Thank you.
Yes, ma'am.
We have already a lot of field data available where it has been seen that it is not the motility which is important in terms of the speed, but it is the fertilizing capacity which they have. They may be the slowest moving, and there are some bulls who produce very slow moving spermatozoa, but they show a very high fertility rate. And so the thing can be corroborated onto this. Thank you very much, Dilip. It has been a very nice presentation, as usual. We have now to go to the next
Thank you,
presentation.
sir. Thank you, ma'am.
Thank you. So the next presenter is, we have Dr. Rajni Paul from ICR NDRI. Earlier, he was working at CSWRI. So the work which he'll present, I believe, is on a ram semen. Dr. Barkha, please share. Yes. Dr. Barkha, yes. Dr. Paul is a scientist. As I said, his research interests are on the elucidation of different mechanisms of sperm quiescences and cauda epididymis, production of recombinant proteins, particularly for the semen cryopreservation. And he's got a couple of awards to his credit, as cited here. This young researcher has 25 peer-reviewed papers to his credit. And oh my God, 35 book chapters he has, and 2 training manuals and popular articles. Dr. Paul would present a novel nanoliposomal membrane stabilizer, which is he's talking on a with the egg yolk and the semen preservation and a fertility rate of ram semen. Dr. Rajni Paul, please go on and present.
Thank you, ma'am. Thank you very much. Am I audible?
Yes, you are audible.
Thank you very much for your nice introduction. I am sharing my slide. Okay, I am just opening first.
Sir, if you are having difficulty,
hello,
sir, if you are not able to share, we can share from
Yes,
here.
I am sharing.
Okay, sure.
I'm sharing. Yes, I think it is now visible. Is it visible now?
Actually, it is your desktop is visible.
Okay.
You have to keep your PowerPoint on and then share and then bring it in the slideshow mode. You
Okay,
just
first I need
close the share. You close.
Okay, okay.
Open it up. Open the file.
Okay. And show. Open the file. I will
Unshare it first.
Okay, ma'am. I am
पहले
unsharing.
unshare करिए थोड़ा.
Okay, ma'am. I am unsharing. Unshare.
You close this.
Yes. I am
Alright.
unsharing. Then
Now you open your PowerPoint presentation at your desktop.
okay, it is present. Yes.
Okay. Now you go for share screen.
Okay.
And then click at your PowerPoint presentation.
Okay. Share screen. Okay. Is it visible?
And go to the slideshow mode.
Okay, ma'am.
Slideshow mode.
Is it coming?
The slides are coming,
Yes,
but they are not in slideshow show mode. Put in the show mode.
I have already put it in show mode.
Now you have to go down below. There is an.
Is it coming?
Full screen. We show single screen instead of multi screens. icon on your.
I have put now in share full screen mode. It is not coming.
No, it's there, but it is not. You have to put it the slides in the presentation mode.
Where it is? Close it. Close it. Close it. Close it. Reduce it. Reduce it first. This is not this right now already. Reduce. Right click. One second, you may stick here. This one escape. Escape.
See, if you have opened up the presentation, then below.
Okay. Is it okay now? It is okay. You tell me here it is okay. It is okay, sir. From my side, is it visible there?
It is not okay yet. You. Yeah.
Rajani, right bottom. If you see the percentage, behind the percentage, there is a full screen mode.
Yes, yes, I am doing that. You see.
Yes.
Share again.
Would you mind stopping the share and again re-click share screen, please? That will work. Yeah.
Is it coming, sir?
You are all right. You are all right now. Go
Okay.
to first slide.
Okay, sir.
First slide. And
Okay, sir.
You get 20 minutes. It is 1:53, Dr. Rajan.
Okay, okay, ma'am. Thank you. First of all, I thank to the organizer for giving me this opportunity to present my work in front of this August gathering. First I congratulate Padam Shri and Dr. M.L. Madam sir for achieving this milestone, and I also congratulate my teacher, Ma'am Turu ma'am, for becoming the director of new institute. Now I am presenting here my work which I did in Avekanagar CSWRI. As Dr. S.M. Naqvi already have briefed about the problem of cryopreserved ram semen. And the fertility rates of cryopreserved ram semen after cervical insemination in sheep is very low. It ranges between 0 to 33%. Many articles in international as well as from our laboratory, it was found that only up to 25 to 33%, that too with the transcervical AI. So with the normal cervical insemination in our laboratory or in Avekanagar, it is almost zero, the fertility rate of cryopreserved semen. The underlying cause was considered as the sublethal cryodamis, which mainly involves the membrane structures of sperm, that is the sperm membrane, acrosome, and mitochondria. Now, this damage mainly leads to diminished post-sperm motility and longevity after the insemination, that leads to failure of sperm migration through cervical canal and leading to failure of fertilization. Now, in the absence of a good fertility or acceptable fertility rate with the cryopreserved semen, liquid preserved semen was tried, and it was found that it is giving acceptable fertility rate of 50 to 60% if it is used within 8 to 10 hours of collection and dilution. But the problem arises when the storage time increases. Conception rate declines sharply. It reaches up to 30 to 40% after 24 hours, and after 48 hours only it remains 15 to 20%, while after 72 hours almost zero. So it is not possible to take this liquid preserved semen to longer distances for insemination purposes. So the underlying cause was found that it is the destabilization of sperm membrane due to cold shock during liquid preservation and oxidative damage taking place in the membrane lipids by the reactive oxygen traces which are produced during liquid preservation of semen, and that actually leading to low fertility rate. Now, cold shock sensitivity of sperm was considered that it depends on the types and proportion of fatty acids present in the sperm membrane. And it has been found that in the sperm membrane of sheep, boar, and stallion, which are more susceptible to cold shock, the unsaturated fatty acid is very high, 70 to 74%, and the ratio of cholesterol phospholipid is 0.35 to 0.38 as compared to human, rooster, rabbit, and monkey sperm, which are considered more resistant to cold shock because these sperm are having more saturated fat and low unsaturated 45 to 50% unsaturated fat and higher ratio of cholesterol to phospholipids, approximate, which is nearer to 1. Whereas in sheep, buffalo, and boar and stallion, it is only 0.35 to 0.38. This compositional differences in the fatty acids and cholesterol phospholipid ratio is making these sperm more vulnerable to cold shock and cryopreservation. Now, as a result, increasing the cholesterol content of spermatozoa membrane can increase its cold shocks resistance, and it has been found that by increasing cholesterol in the membrane with the help of methyl cyclodextrin coated cholesterol, the cryopreservation or cold shock resistance can be improved. So again, we know that vitamin E is a potent antioxidant which is normally present in cell membrane, and it provides protection against oxidative stress, as well as it provides chemical stability to the cell membrane bilayer. So therefore, delivery of these beneficial lipids, that is cholesterol, vitamin E, and saturated fatty acids to sperm membrane might reduce the cold shock and oxidative damage during semen preservation. However, being water insoluble, these lipid-like structures are poorly available to sperm when it is used as such in the semen extender. Therefore, a suitable delivery system should be prepared for better interaction of these molecules to sperm surfaces. Next, it was reported that liposome can fuse with the cell as well as with sperm membrane and deliver the membrane impermeable agents to the sperm. It was also reported that liposome can replenish the loss of phospholipids from the sperm membrane due to cryo injury caused during freezing thawing process. And it was also reported that liposome mediated transfer of the lipids and cholesterol to sperm membrane, followed by their rearrangement in the sperm membrane. Rearrangement of the sperm membrane components modifies the physicochemical properties of sperm membrane as well as its cryostability of the spermatozoa. Therefore, liposome could be a suitable delivery vehicle to transfer the beneficial lipids to the sperm membrane. With these hypotheses, the present study investigated the effect of supplementing saturated fatty acid-rich egg lecithin, cholesterol, and vitamin E in the form of liposome, both on semen preservation and fertility rates in sheep. Now, novel strategies which are used in this study were that a nanoliposomal structure was prepared consisting of egg lecithin, which is rich in saturated fatty acid, and low unsaturated fatty acid, only 25%, and it will be less susceptible to oxidative damage, as well as it will increase the stability of the sperm membrane when it gets incorporated. Besides, cholesterol was included into the formulation for increasing the structural stability of bilayer, as well as reducing the lipid phase transition effect at the low temperature when the semen is used to, at which semen is used to store. Now, vitamin E was also included in the liposome to counteract the lipid peroxidation caused by ROS and thus enhance the physical stability as well as chemical integrity of the bilayer. So the above beneficial additives were added in the form of liposomes to facilitate incorporation into the sperm membrane. Next. My slide is not moving. Okay. So this is the schematic outline of my work. that is egg lecithin, cholesterol, and vitamin E. These three components were incorporated to prepare a liposomal structure, and this liposome was incubated with the sperm membrane, before preservation, so that the liposome can interact with the sperm membrane, and it can transfer the components of lecithin, cholesterol, vitamin E to the sperm membrane, and thereby it can increase the cold shock resistance. So after this incubation of sperm with these liposomes, the sperm was cryopreserved as well as liquid preserved. We have tested both on cryopreservation as well as liquid preservation, and then it increased the membrane integrity, sperm motility, mitochondrial potential, cholesterol content on the sperm, as well as reduced the capacitation of the treated sperm. So this led to higher pregnancy rate in the liquid preserved semen. So in this study, we have conducted 5 experiments to analyze or assess each of these parts. In the first experiment, first we synthesized the nanoliposomes by using these 3 components, by using different ratios, and then we studied their physical properties as well as structural stability. And in experiment 2, we used these nanoliposomal preparations at a 2% level, along with 20% egg yolk as control, or 2% egg lecithin, crude egg lecithin as control. And we have assessed the liquid preservability of ram semen. And in experiment 3, after identifying a suitable nanoliposomal formulation from the previous experiment, we have selected one nanoliposomal formulation to identify the optimum concentration of the nanoliposome for liquid preservation of ram semen, for which we used graded concentration of the nanoliposome along with a control of 20% egg yolk. In experiment 4, the nanoliposomes was tested for cryopreservation of ram semen, and first we determined the optimum concentration for cryopreservation, for which we have randomly taken one preparation, and it was added at 3 different rates, 5%, 7%, and 9%, in comparison with 15% egg yolk as control. And it was found that 5% liposome was giving the best result for cryopreservation. Then with this 5% level, we then tested all other liposomal components, non-liposomal preparations, and then we found out the best performing composition of the nanoliposome for cryopreservation of ram semen. And lastly, in experiment 5, we assessed the fertility rate of liquid preserved semen after preserving the ram semen in the best performing liposomal preparation. Next, the slide is not moving from me.
Do it from your keyboard.
Yes, I am doing with my keyboard. Yes, I can move now. Screen sharing has stopped as the shared window is closed. Okay, so it can be again. Stopped.
Please share again.
Yes, I am sharing again the slides. Yes. So in the first experiment, as I have told you, we have synthesized the nanoliposome and characterized them. For these 3 components were taken at different ratios in gram, in terms of weight. They were taken in milligram in these ratios, and by factorial design, 9 combinations are prepared, and these 3 components in 9 combinations, they were taken and mixed with dissolved in organic solvent chloroform, and a thin film was prepared, and that was hydrated followed by sonication, and it gives to the production of liposome. These liposomal preparation were then characterized for their particle size, surface charge, functional groups, shape and size, and also their stability on liquid storage.
Your slides are not moving.
That's the
and
problem.
They are not
Yes,
in
now
the slide.
I have got now. So these are the results, that average particle size of the
just
liposome.
a minute, please.
Okay,
Your
ma'am.
slides are not moving.
Okay, ma'am.
You just click on resume slideshow. Okay.
Okay. Resume.
Just click on resume slideshow.
Okay, ma'am. So the particle size ranged between 158 to 220 nanometer in the prepared liposomal compositions, and their polydispersity index ranged between 0.1 to 0.35. Surface potential ranged between -30 to -37 millivolt. These parameters indicate that the liposomes are quite stable, because having minus surface potential and size.
Sorry to interfere, please. We cannot see your slides, what you're talking, and we are still seeing the experimental design slide.
Okay,
so just do it accordingly. Just
click
click on the resume slideshow, the blue rectangle.
Resume slideshow. Is it pause share, new share? It is there. Resume. It is not visible in a resume.
You have last 2 minutes to
can go straight away
conclude.
on to, you see that where there is that, the slides, there is a line to them. You can click on them, it will come over.
You come to the conclusion we can see now.
Yes.
But 41 slides, you are left with only 2 minutes.
Yes, I am just, result will be very quickly. It will be completed. Sir, it is visible, this slide?
Yes, it is in a reduced form, but go ahead.
Okay. So these are the properties of the nanoliposome. Their size, shape was spherical, as it is seen in the HRTM image, spherical to oval in shape. And out of these preparations, preparation number 7, composition number 7 was found to be having lowest size and higher surface charge. So it may be better composition based on the physical properties. Then these are the parameters, FTIR spectra, where we have seen, we have taken 4 composition, FTIR spectra of 4 composition.
I think your slides are still not moving. Why don't you just sum up for us?
Okay.
That will be very good.
Okay. So conclusion, is it visible?
No, they are not moving,
So,
as I said.
Okay, ma'am. Then I am just telling.
Kindly unshare.
In this mode, you click on you see that what you have slides on the left, you have a chain of those slides there. That's what we call the slide outlines over in there. So you click in each one of them, that at least it will come over here.
I am just resharing.
Could you please sum up for us? Yeah, this is better.
It is visible?
Yes.
Okay.
Conclusion is visible.
Okay. I am from this position, I am just telling. So after this experiment, we found that stabilizer, membrane stabilizer composition number 7, it possesses the smallest particle size, highest surface charge, and lowest PDI value. So this, and it also was more stable. After 45 days of liquid preservation, it was found to be stable, and it possessed, accordingly, it possessed the best physical attributes among the novel membrane stabilizer preparations, or the liposomal preparations. So we next experiment we did, that is effect of this novel nanoliposomal preparation on liquid preservation of ram semen. In this, we did 2 experiments. First, we identified the most effective liposomal preparation for liquid preservation, So this is the experimental outline. From different rams, we collected semen, pooled the semen, diluted, and then we divided it into groups. First one is control, 20% egg yolk, and the others are treatment containing 2% of
Kindly hasten up the presentation. You already timed out.
Okay, ma'am. So this is the experimental design. So after liquid preservation, we have analyzed the motility and other seminal parameters. So we got that rapid motility and VCL are comparable between these groups, control as well as treatment at 2% level of the liposome. However, rapid motility was highest among the liposomal groups in membrane stabilizer number 7. Other velocity parameters, VAP, VSL are comparable between these groups at this 2% level. Then we tested the antioxidant level or lipid peroxidation level. We found that lipid peroxidation was lowest in presence of these membrane stabilizers or nanoliposome as compared to the control egg yolk or control egg lecithin. So lipid peroxidation is reducing very much in presence of this membrane stabilizer, new membrane stabilizers. Then we tested the concentration, different concentration of these membrane stabilizer number 7, whether these are giving better result. So for this, we again conducted liquid preservation experiment by using different concentration of this membrane stabilizer ranging between 1% to 5% in comparison with 20% egg yolk. And here we found that with the dose dependent manner, the novel membrane stabilizer or lipid, it is increasing the total motility, rapid motility, as well as sperm velocity parameters. So ranging between 2 to 5% level, all these levels, this novel membrane stabilizer number 7 composition, it is giving significantly higher motility and velocity values as compared to egg yolk. Then we tested this novel membrane stabilizer for cryopreservation of ram semen. Here also we did 2 experiments. First, we tested the optimum concentration which will be effective for cryopreservation. So we tested 3 levels, 5%, 7%, and 9% of this membrane stabilizer number 7, along with 15% egg yolk as control. And after cryopreservation, we evaluated the seminal sperm motility parameters. We found that in presence of 5% membrane stabilizer, the motility, sperm total as well as rapid motility were significantly higher as compared to the egg yolk. So out of these 3 different percentages of membrane stabilizer, 5% was found to be better compared to 7 or 9%. So in the next experiment, we actually identified the best liposomal composition.
Dr. Rajni,
okay,
Dr. Rajni,
sir.
please conclude. Don't go further for additional slides.
Okay.
Please conclude.
Okay. So
go to last slide.
Okay.
Before thanks.
Okay. So these are the slides. I'm just going. Now, finally, after cryopreservation, we found that yes, the membrane stabilizer number 7 composition is also improving the post-hoc quality, all the qualities, motility, as well as the functional parameters like acrosome integrity, mitochondrial membrane potential, capacitation. These are improving after cryopreservation in presence of novel membrane stabilizer. So we tested finally on fertility rate of this these membrane stabilizer on liquid preserved semen. So 48-hour liquid preserved semen was used to test the fertility rate. There we found that after a series of fertility trial, we found that the novel membrane stabilizer composition number 7 is giving significantly higher pregnancy rate as compared to egg yolk. So in conclusion,
please close the talk as we request you, Dr. Rajni.
Okay, it is completed. So if patent has been filed for this novel membrane stabilizer and this work was carried out in Vivekananda CSWRI. So therefore, I am thankful to the director of Vivekananda CSWRI for providing me opportunity to carry out this work.
Thank you very much.
Thank you, ma'am.
Please unshare your slides.
Okay, ma'am.
Is there any question for him?
No, sir. He is really kind of over to you, Dr. Madan.
Is there any question?
Sir, I think we best keep taking questions because it's we are already late. He has taken almost double time. So I was told that
There is any
the
question?
session is not there.
If there is no question, so okay, then we can go to our last.
Thank you, ma'am. Thank you, sir.
Thank you.
So the next speaker is not there, I was told by the organizers. So,
he's not there.
Yeah, he's not here. Dr. Dharmendra Kumar. Is that right, Dr. Nidhi? This is what you mentioned.
Yes, ma'am. Yes, ma'am.
Yeah. So we are, we are done with the speakers, sir.
Dr. Tharu, would you like to say something before I conclude?
Sure, sir. Sure. Thank you very much, respected Dr. Madan. So at the outset, thank you, Professor Loya, for giving us chance to chair this important session, wherein the translational technologies of animal sciences for reproductive health. The session has had 4 outstanding speakers, and we were very thankful for Dr. Naqvi, who really elaborated on the detailed work in the RAM, not only semen freezing, but also the embryo transfer and generating the sponges work. We know it difficult, however, that's the only way one can really go for enhancing the production. Dr. Prem Singh was also very apt in elaborating things for us, and he really took up the questions and our concerns he could address, and we congratulate and compliment and say best wishes to him. Wherein a very good talk by, energetic talk by Dr. Dilip Swine on basic male physiology and the sperm physiology particularly was of great interest, and it drew a lot of questions and interaction in the chat box. And we are very happy with this clear way of moving ahead, because that's the area where not very many laboratories in the country, especially in the animal veterinary sciences, are working. There's a group at NINP which is doing, and a little bit of work at Duwasu which is being started, and none other than Professor Akbar Shah, who has elaborated the epididymal work in the previous session. And in the end, Dr. Rajni has shared his work, a good work, but the technology kind of could have favored him a little more. But in the end, we were very happy, Dr. Paul, wherein we could understand that your 7 number of fraction which you used for the ram semen, and that you have a specific outcome from that which you are looking forward for the patent. And we missed hearing Dr. Dharmendra in this session, and I enjoyed co-chairing it with this session. Rather, I'm privileged to be co-chairing this session with the very honorable, respectable Professor Emil Madan. Thank you to you, sir, for giving me a chance to express my views. Over to you.
Thank you. It was my pleasure also to see you, and that's why that I thought that you should be doing the job.
Thank you.
More into the system. I have not much to say, except that firstly thank Dr. Lohia for getting us involved into this, and second for flagging out this important area, which is coming more and more into what we call stride of reproductive health. Because today we understand that most of the advances which are coming in are coming through experimentations, and those experimentations have got the models, and those models is mostly provided by animals. As you can see that today, those techniques which have been all talked, if we see from yesterday, those which were being talked today, for example, starting from AI in itself, then the cryopreservation, and besides that, the technologies which go with embryo, the technologies which go with the fertilization processes, are all which have been standardized and then replicated. That's what we talk, translated over into the activity. And I'm happy that this type of an association continues. And I'm reminded of the day in Bombay, way back in late 80s, that when we met and I was present there, and then it was, as was commented in the inauguration time also, that this is the one society that which has kept an angle, that angle which is not myopic, but it is a broad angle in which that we're talking all sciences should come together. And that's what we should be strengthening in years to come. Thank you very much for my association with this session.
Thank you, sir.
Thank you so much, Honorable Sir, and thank you so much, ma'am, for wonderfully chairing the session. It was great to have your presence in this session. So since we are running a little late on time, we'll move on to our next session, which is Professor G.P. Talwar Gold Medal Oration. And for that, our chairpersons are Padma Bhushan Professor G.P. Talwar, and I think he needs no introduction. He's founder director, National Institute of Immunology, New Delhi, and currently he's director research, Talwar Research Foundation, Delhi. I think sir will be joining shortly. And the next chairperson is our very own Professor A.S. Ansari, professor at Department of Zoology, University of Rajasthan, whom we have already met in the inaugural session. So I welcome both of you, sir, to please chair this session. Over to you, sir, please. Thank you.
My slide is not moving.
Hello.
Yes, sir.
Yeah. This year's Professor G.P. Talwar Gold Medal Oration conferred to Dr. Pradeep Kumar Ji. He needs no introduction because we have seen vast introduction of the Dr. Pradeep in the chairmanship of the session. And now I request Dr. Pradeep Kumar to please initiate his oration.
We have spoken to Professor Talwar, and Professor Talwar had a little misunderstanding about the schedule, and he said that he will be available around 5 o'clock. We said that that is the valedictory function, and oration is at 2:15. So anytime he will be joining. Meanwhile, Dr. Pradeep may kindly start the oration.
Yes. Okay. Am I audible?
Yes, you're audible, Pradeep. Dr.
Okay.
Pradeep, you're audible.
Yes. Great. Thank you so much. Thank you, chairpersons.
Dr. Pradeep, you are audible.
Yes. I'm not audible?
Audible, your slides are not here and not in slide mode.
No, that will come.
Slides are
No, my slides will come. Is it coming?
yeah, slides are there. Only the slide, the presentation mode.
Okay, now what do I do? I should reshare it?
Yeah, do that.
So go to the presentation mode. Yeah, it's fine. No, not yet.
Is it visible?
No.
No.
Okay, 1 second.
I think you need lunch, Pradeep.
No, I had my lunch.
No, then we need lunch perhaps.
Yeah, you might need lunch. I don't. Okay. Share.
Wonderful.
Yes. You have to put, yeah, now it is okay.
Is it visible?
Yes.
Yeah, very well.
Is it moving?
Moving.
Yes.
Okay. Thank you, ISSRF, for thinking about me while deciding on a person to be awarded with this Professor G.P. Talwar Gold Medal. And also I thank the jury for finally selecting me for this award, prestigious Professor G.P. Talwar Gold Medal Oration of 2022. I'm going to dedicate this talk to my PhD mentor, Professor M.M. Laloria. He is a Manmohan Manohar Laloria. So he is a very pleasant guy, so that Manmohan term suits him. And he's Manohar because, he's a handsome guy. In addition to my getting PhD with him, I also got his daughter as my wife, and keeping her as my collaborator as well. So with that, let me come to the topic. I'm going to talk about this molecule called cyclin M1, some insights into its functional role in spermatogenesis. This is all about fertilization. The game is about one sperm, one male gamete, which is a terminally differentiated cell, fusing with an oocyte, which is another terminally differentiated cell. Both are haploid cells, and it makes a zygote when these two guys get a chance to fuse together. And the first two cells which fuse together, they are nullipotent. They have no potency whatsoever. But the moment they fuse, it makes the zygote within one day, like 24 hours, maybe far less than 24 hours, a totipotent cell. This is an amazing thing that two nullipotent haploid cells can make one diploid cell. That's a real marvelous thing. So the first component, the sperm, is produced in the testis. It matures. Many people talked about the sperm production and its maturation in the epididymis. It's mandatory that the sperm takes all that time in the epididymis before it can fertilize the oocyte, because the ultimate aim of the sperm is to fuse the oocyte. So the sperm are produced in the testis, and there are a bunch of cells called the germline stem cells. Call it type A spermatogonium in the case of human beings, and they can repopulate through symmetric division. They can also go through asymmetric division to produce differentiated cells serially to ultimately produce a haploid cell. And up till primary spermatocyte, it's all diploid, but after primary spermatocyte onwards, it's all haploid. So how this cell, which was dividing through mitosis all the way till here, till the primary spermatocyte, is getting to divide through meiosis is another big question that is there over here. So, we do work on all these aspects of spermatogenesis, the self-renewal of the spermatogonium, and also whether they are pluripotent or multipotent. This differentiation at every single step. And then comes the meiosis. We focus on that as well. And then how they ultimately differentiate. And then when they fuse together, how the deprogramming, I don't call it reprogramming, the oocyte is programmed, sperm is programmed, they get deprogrammed to produce a totipotent cell. So that's all the focus of my lab. And the sperm has this huge job of going and finding the oocyte. And the guys produce millions of sperm. And the women are very conservative. They produce just one oocyte per cycle in normal situation. And the sperm has the job of traveling a little long distance from the place where they are deposited all the way to reach the oocyte. Once it reaches the oocyte, then there is a huge wall there, multi-layered wall. It has to break all that thing, get in and in and in. And then comes the zona pellucida, another barrier which has to penetrate through the zona pellucida, get into the this perivitline space. Then it has to bind to the ulamal membrane to produce, to put the nucleus into the cytoplasm to produce the zygote. So lot of things the sperm has to do over there. And in a normal situation, everything goes normal. Nobody knows what's happening, but you get a baby. But then there are these 15% of the couple who would ultimately reach the ART clinic because they cannot make a baby on their own. I think Professor Kamboj was talking about it, and today it is not about contraception. It's all about maybe having babies, because India also is aging now. So once we are aging, we need to worry about having babies, and there are easier ways these days, like the PC, making a baby to somebody else, and we have all kinds of technologies. Why to go through all that task of making a baby yourself? You have ways to do. You can buy it through Swiggy or Zomato, but then there are people who need their babies. There comes a subfertility. That's any form of reduced fertility with prolonged time of unwanted non-conception, and then they will mature into infertility cases where for 1 year they tried, they could not have a baby. And there could be a lot of causes. Female factor, we won't talk about it. Male factor is what I would talk about. Psychosomatic disorders could be there, where the guy cannot deposit semen into the female genital tract. Then there could be spermatogenesis related problem causing all kinds of syndromes. And then there could be fertilization related issue, all that thing that I showed in the previous slide. The sperm cannot really execute all that thing that it has to do to reach the oocyte interior. Then even if that happens, maybe there could be cases where the early development is impaired. The sperm cannot activate the oocyte. So the couple, they reach the clinic, female is fine, the male factor is what we talk about. So you just look at the three red figures, and in case a guy produces less than 15 million sperm per milliliter, doctor calls him oligozoospermic. And if the motility is less than 40%, then the doctor calls him asthenozoospermic. And if the shape only 4% are normal, then they call him teratozoospermic. My argument is that you have 15 million sperm, 40% motile, and 4% with the normal shape, the very handsome one. The rest are not that handsome. Still, the guy cannot produce a baby. You need one sperm to make a baby. So, and this was what I was talking about. The sperm are deposited here. It has to climb up and up. Then, this female genital tract is not a comfortable zone for the sperm. Very, very hostile. And then, it has to climb up and reach there. So, in a normal situation, there are these hurdles, but even in the clinic, when the doctor has a sperm with him or her, and they can inseminate the lady wherever he or she wants, still the conception, the number of successful pregnancies very, very less. So in the ART clinic, doctor has all these tricks. They might do the swim up. Then, the husband can inseminate the lady, but still the doctor may go for an artificial insemination, and he can do intrauterine insemination. You can put the gamete in the fallopian tube. He can do IVF, take the sperm and the oocyte both out and fertilize and put it back into the uterus. And the doctor can do the dispersion of the cumulus, can also drill the zona pellucida. And if nothing works, the doctor can push the sperm into the oocyte through ICSI. Then you can have, in case the sperm are not there in the semen, then you can take it from Epididymis, even from the testes. And you can even take a round spermatid because it's a haploid cell, and you can inject into the oocyte. So making the sperm reach the oocyte is not a big deal. It can happen. And I would say that, semen analysis is pretty much descriptive, and it's not the real reason for the infertility. So this is what had been our theme for the last three decades. So we were trying to identify molecular defects, if it is there in the spermatozoa of infertile men, and whether that associates with the male factor infertility or not. So, and obviously there is no reason for me to tell that the proteins of the sperm are very important. They are involved in the development of the testes, epididymal maturation, capacitation, acrosome reaction, the sperm zona pellucida interaction, and oocyte embryo transition as well. So we recruit patients, and so we used to do 20 years ago. We used to do electrophoresis, 1D, 2D electrophoresis. Then whatever is differential displayed, pick them up, and then I try to identify what they are. Here, this is just a representative. Show that this is the proteome of a normal sperm, and this is the proteome from the sperm from infertile guy. So whatever is visible over here and absent over here, they are the proteins present only in the fertile individual. So we had a lot of proteins of that kind. So olden days, we will subject them to N-terminal sequencing. So it's kind of, 1 amino acid per cycle. So you might get 7 to 10 amino acids during this Edman degradation. So once you have the N-terminal sequence, you reverse translate, make degenerate primer, and use DT18 and do an RT-PCR. And you sequence it, and you identify proteins. And then over time, when mass spectroscopy came into the use of identifying proteins, so you slightly modify the protocol. You pick up the bands or spots from the gel, subject it to digestion, triptych digestion, and then you do MSMS to identify the proteins. And now today, you don't need to even do a gel, RNA gel. You take in the protein, cut into peptides. So you inject into a UPLC or a LPLC, and then push it into a mass spectrometer, identify the protein. So with all those things, you will see a lot of common proteins. Then there are some proteins present only in the fertile individual. There are some proteins present only in the infertile individual. I will focus on proteins present only in the fertile sperm. So a lot of proteins, you don't need to worry, reading this. These sperm proteins could be important in spermatogenesis, epididymal maturation, and we also check whether those proteins have any role to play in the zona pellucida interaction in vitro systems. And also we remove the zona pellucida to see whether the sperm can bind to the oocyte. So these little dark things that you see, they are the human sperm bound to the zona to the ulama surface of hamster egg. And then there are situations where you can block it all. So some of these proteins absolutely are necessary for binding to the ulamal surface. Their absence would mean that even if all attempts are made, other than ICSI, all the other protocols, approaches which a doctor might use for for in an aortic length might fail in case these proteins cannot go and bind to the oocyte. So we also see that some of the molecules are important in the early development. So the absence of some of the proteins might interfere with the early development of the zygote. So a bunch of proteins were handpicked based on a couple of parameters that we thought are important. So out of that, cyclin M1 is the protein that will be the protein of our focus in today's talk. So this protein is present in the testis. You can see this northern blot, a little bit of it is there, very heavily expressed in the brain. Not very surprising because many of the testis proteins are expressed in the brain. And interestingly, they had this little cyclin box, which made us feel that this protein is a member of the cyclin family. So we named it differently. Another lab in the United States, which also was working on this protein in the brain, called it an ancient conserved domain protein, ACDP. And then later, seeing its character, we changed the name to ACDK because it had a kinase activity. And then I started calling it cyclin-like protein because it had cyclin similarity. And finally, this protein society has named it cyclin M1. So this is the cyclin M1. It folds exactly like cyclin in homology modeling. Looking at the sequence, you can see that whatever I have underlined is the methionine. So this is one potential start site, and this is second potential start site. In the brain, this methionine, this ATG is used for making the transcripts, while in the testis, that long transcript is. By the way, this only has one single stop codon somewhere below. So all these three methionines, all the methionines, in fact, are in frame with the single stop codon. So what we see in the testis is the expression product that starts from here, but in the brain, and in the testis, what we see the expression product, is that it's starting from here. So that's the step that we have. This is the message, and this is in the brain, and that's in the testis. So this is the protein, huge amount of protein in the testis, in the brain, a real good amount in the testis as well. RT-PCR, the PCR confirms it. We sequence it all. We try to check when is this cyclin M1 getting expressed in the testis. So we got pups from week 1 onwards. This is week 12. It's a mature mouse. So if you look at it, all the stages, this protein is expressed, but the week 1 had very high expression, relatively less expression in the mature ones. When we did histochemistry, there are scattered cells in the immature testis, but by the time it becomes adolescent, you see a beautiful ring of cells in the testis, and that is retained in the testis of adult mouse as well. And those cells are positive for c-KIT. So one channel, the green channel is, I believe, c-KIT. The other one is cyclin M1. And similarly, these cells which are cyclin M1 positive are positive for OCT3 as well. So showing that they have some kind of stem cell potency. So we took those cells out through FACS and we put it in culture, and in the kind of medium that we use, which is supplemented with LIF and GDNF, it produces these beautiful bodies. They look like early embryos, so we call it SSC colonies, ES-like colonies, embryonic stem cell-like colonies. They are positive for GIFRA, integrin alpha, alkaline phosphatase, and CD9. So these things show that they have enough amount of stem cell potency. At the same time, there's a little memory left, which makes it like a germ cell. It has forgotten a lot of its memory, but it is still possibly a germ cell. The moment you withdraw LIF GDNF, it makes embryoid bodies, very beautiful embryoid bodies, which are positive for nestin, desmin, and PDX1 to show that ectodermal, mesodermal, and endodermal lineages are there. So that would mean that they do have true ES-like characteristics. We stimulated these cells with retinoic acid. The moment you stimulate with retinoic acid, so originally when you start off, so this is an RT-PCR to show that this starting material is positive for GIFRA, the single protein 42 and OCT3 to show that they are stem cell-like, did not have AFP, desmin, or nestin. But the moment you stimulate it with retinoic acid, GIFRA went, CFP42 went, OCT4 went. But then you start seeing the expression of AFP, DUS, and nestin. So to show that they do differentiate into all the 3 germline lineages. We had a cell line that's a GC1SPG, that's a spermatogonial cell line. We looked for the expression of this molecule in those cell line. So here is the cyclin M1. We treated with retinoic acid. Cyclin M1 level went down, and obviously stride is expressed to show that the retinoic acid signaling is working. So the moment you stimulate even the GC1 cell with retinoic acid, though you get stride or expression, cyclin M1 comes down. So that does mean that retinoic acid is a negative regulator of cyclin M1 expression. So then came this question: at which stage of development does cyclin M1 show its first appearance in the germ cell lineage? In case students are there, this is to show them, originally, when the fetus, when the early embryo development, you have a primordial germ cells, derivative of the epiblast, the proximal epiblast. They are bipotential. They don't, even if they are XX or XY, they don't have any bias at this point of time. Eventually, it makes gonocytes. And the gonocytes are the ones which will, show bias to produce spermatogonial stem cells. And then, if there is a Y chromosome with active SRY, under SRY influence, it will, differentiate into SSC, spermatogonial stem cell. In case SRY is not there, and the Y chromosome is not there, or SRY or part of SRY is not there, then that will go into a female. So that way, by default, all the embryos are female embryos in a way, I will say. The SRY is what makes a difference to convert female background into a male dominant phenotype. So those epiblasts will migrate and it will produce the gonocytes. In between, there is a primordial, the PGC will become gonocyte, and that will become a spermatogonium. So I did say that embryonic gonads are bipotential. So we looked for the expression of this molecule, cyclin M1, in embryonic stem cells. So this little blue thing, in case you see it as blue, is the cyclin M1. And it has some other 3 other variants called M2, M3, M4. We won't talk about it in this lecture. The embryonic stem cells don't have cyclin M1. This is cyclin M1. Okay. The embryonic, the 8 PGCs, primordial germ cells, are negative. Same is true for E9, true for E10, again true for E11. Interestingly, E12 male is negative, even at this point of time, for cyclin M1, but E12 female starts expressing cyclin M1. So this was something interesting. This is not what we were looking for. We thought that we will get a time point where the testis, the primordial testis will show its expression. So up to E12, we did not have any expression of this cyclin M1 gene in the test, in the gonocytes, which are destined to become spermatogonial stem cell. But the ones which are going to be the ovarian whatever cells, gonial stem cells or whatever, they have started expressing cyclin M1. So we wanted to map up between E12 to the neonatal stage, because day 1 neonates were positive for cyclin M1. So okay, in between there was this little thing, let me tell you. So we also did a culture. We from ESCs, starting with mouse ESCs, male ESCs, we tried to convert them into epiblast-like cells in culture. So this epiblast-like culture was converted into PGC-like cells. So these are male ES cells, mouse ES cells. So they also, we did an RNA-seq, and the PGC LCs derived from ESCs were also negative for cyclin M1, but M2, M3, and M4 were there. So cyclin M1 was absolutely absent in PGCs of the male and also in the PGC-like cells. And in the PGCs of the male up to day 12, it was not there. So we went beyond day 12. So we have a little gap because the work is still going on. So going from right to left, going from day 8, postpartum 7, 6, 5, 4, 3, 2, 1, it's all positive. Day 0, it is there. The day 0 is a day it is born. And so my student, Irfan Khan, who is doing PhD with me, has gone all the way on to the left to 18.5. 18.5, it is there. So we have to go between 18.5 and day 13. So we have experiments planned, and that's going to take a couple of other weeks to fill the gap. So I would want you to look at this image. This is a stage day 12.5 to 16.5 where the spermatogonia are formed. That is where the bias starts. So we don't know what happens at this point of time, but this point after 16.5, day 18.5, it is positive. So somewhere here it happens. So that makes us believe that there is a strong association between cyclin M1 expression and the conversion of these cells, the gonocytes, into spermatogonia. So that is something very, very interesting. We also have experiments which showed that cyclin M1, this molecule, has cyclin-like activity in true sense. So we did a pull down with the various CDKs. So with CDC2, so you pull it down with anti-cyclin M1 antibody, then we look for all the kinds of CDKs. So CDC2 showed positivity, and CDK2 showed positivity, CDK6 and all other CDKs were negative. So this did mean that cyclin M1 can bind to CDC2 and CDK2. Then the question is, where this binding, does it induce activity? So cyclin A, because this molecule is very similar to cyclin A, so we had a positive control cyclin A CDC2 system to to phosphorylate retinoblastoma protein, which is one of the substrate proteins for cyclin A. So you can phosphorylate retinoblastoma proteins, a recombinant retinoblastoma protein. And now, similarly, you remove cyclin A, and in place of that, you put cyclin M1 and put CDC2, you still have the same phosphorylation. And the retinoblastoma protein we started off with is a negative control. And then we have with cyclin A and cyclin M1 without the CDCs, negative. And retinoblastoma with CDC2 alone also is negative. And this is a positive control. It's a phosphorylated retinoblastoma protein, absolutely fine. So it did mean that cyclin M1 does have cyclin A-like activity. It can be, obviously, cyclin M1 with CDC2 can, it does have the kinase activity. We overexpressed cyclin M1 in GC1 SPG cells, and we looked at the cell cycle because it's a cyclin-like molecule. Overexpression did not do anything, in fact, So, but the moment you silenced it, we had a decent reduction in the cell cycle. So we looked at the stages. So we realized that if this is a G1, this is a G2, this is mitosis. So the G1 level came down when you silence cyclin M1, and the other two, G2 G2 and mitosis, both of them went down. So somewhere over G1 entry is a place where cyclin M1 works with possibly CDK2 or CDC2 or any other CDK homologue. So we looked at the domains of this protein, and they were very interesting ones. And I was a little interested in this, that this repeat that the testicular haploid express gene, because this molecule has a domain which can push a cell into meiosis. And meiosis may not be a single molecule, single protein affair, but then there is one protein which does have some relevance as far as meiosis is concerned. So we are doing some experiments to see what the tech domain of cyclin M1 can do. So we have this much of the data published in Biology of Reproduction in 2016, and we have activity going on. And one of my students looked at the upstream region, how cyclin M1 expression is regulated. We had data to show that cyclin M1 is negatively regulated by retinoic acid. So we wanted to look at the upstream region. So we had the two putative promoter regions, call it region 1 and region 2. This is the transcription start domain region. So very, very strong prediction for both these things. And region 1 is the one that it will use in case the second start codon is the start codon, true start codon. Region 2 would be the promoter region in case the first methionine is used for the start. So this region 2 might be active in the brain, and the region 1 could be active in the testis. Then the thing is, in case RNA pol 2 enters over here, how does it skip region 2 to get into region 1 in the testis? That's the thing that we don't know. So we looked at the promoter, like we cloned both the promoters. We in fact had multiple promoter constructs, and we looked at all of them. So this is GC1. In GC1 cell, we also have C18-4 cell, which is more like A-type spermatogonium. This is more like B-type spermatogonium. So we have a very huge promoter activity. This minus 265 plus 148, that is the more proximal promoter, has very strong activity in the GC1 cells. The other two places, it did have activity, but not as high as what you saw with the proximal promoter. On the other hand, the distal promoter, the region 1 we saw in the previous slide, was more active in C18-4. This is more immature, spermatogonium. And then we had these two other constructs also with overlapping areas, and all the three were very active in C18-4 cells. Okay, we try to stimulate the cells with GDNF, because GDNF is what keeps the stemness of the germ cells. C18-4, obviously, GDNF enhance the activity of cyclin M1. So having cyclin M1 in the system is possibly very necessary for maintaining stemness. That is very, very, very clear. And the moment you downregulate cyclin M1, it pushes the system into the differentiation pathway. And we looked at the promoter activity in stable. We created stable cell lines in GC1 and C18-4. In C18-4, you see in GC1 it was not showing that high activity with GDNF response, but in C18-4 GDNF showed a response. So it's a GDNF inducible in C18-4 cells, but not in a B-type spermatogonia-like cells, which is GC1. So we had another molecule which we identified in the lab, which also is a regulator of many of the testicular proteins, the germ cell proteins, TDP43. TDP43 also is it's an insulator. So this molecule it's a DNA and RNA binding protein. TDP43 can bind its consensus in the sequences. So, and TDP43 is expressed in the germ cells and also in the somatic cells. If TDP43 engages its consensus in the somatic cells, those genes are not expressed. So but on the other hand, if TDP43 is binding to the promoter region of the same gene in the germ cells, it's an activator. So it's an insulator, in fact. So TDP43 insulates gene expression, unwanted gene expression in the somatic cells. So all the germ cell specific genes are silenced in a way by TDP43 binding in the somatic cells. On the other hand, this will enhance the expression of those target genes in the spermatogonial cells. So we looked at TDP43, what it does. The cyclin M1 expression was downregulated when you overexpress TDP43. This does mean that the TDP43, the moment it expresses, the germ cells express TDP43, again, that's another push for the cell to differentiate. There was reason to believe that there is a little epigenetic regulation, because this molecule can bind H3K9 modified regions. So we did look at the profiles, and we have some little data, but experiments are still going on, so I won't talk much about it. The idea of looking at all these proteins, one thing was to look at differentially displayed proteins, understand its function. So we have our hands on 7 proteins of this kind, and we have a total of 19 proteins identified in our lab as differentially displayed. So the kind of data that I showed about cyclin M1, similar data we have created for many of the proteins that we are working on. So we know what each of the molecules would be doing in the germ cells, in germ cell differentiation, and also beyond that. So the precise role of these proteins in making a successful conception in a way is pretty clear in our mind. So it could be binding to zona pellucida, it could be binding to the ulemma, it could be activating the oocyte, and also it could be the reprogramming of the oocyte into a zygote. So the issue is that doctor doesn't get a chance to look at any of these molecules. So the doctor has to use what is known for deciding on the therapy. But the issue is, if these proteins are absent in the sperm, so sperm-derived protein might be doing things beyond fertilization. And in case they are absent, then there is a very heavy chance that even after an ICSI, development will be impaired. You may have 2-cell, 4-cell, 8-cell, embryos, but they may not become blastocysts, they may not implant, and even if after implantation, normal development may not happen. So the plan is to make a protein chip. This has 20 proteins. So this is a normal spot. So all the 20 proteins, 20 spots are visible, and this is one patient. You see that this protein is absent, where I have this red mark, and another individual, so you have a low expression of several proteins, including this one, and you have this patient, you have almost no expression of this molecule, and these two proteins are different, and some of them also are underexpressed. So there is a little connect between many of the proteins. We are trying to arrange them in a hierarchy, but still, there are molecules in between possibly. So it doesn't make a perfect hierarchical cluster, but that doesn't matter. So though this is all about 19 proteins, I do have more than 19 proteins, which we identified in the lab as absent in a population I think around I would say 3,000 odd number of patients that we screened. So in the population, you may have a little over 70 proteins differentially displayed. So we have an ICMR supported grant. Dr. Rajesh Sharma knows about it. We have an ambitious project of developing a protein chip, and it's an antibody chip. So we'll have an antibody array. So the patient comes in with the male factor. Doctor says he has male factor infertility. We will extract his protein. We will label it. We will put it onto the chip.
Hello.
And we yeah, I'm almost done.
Hello, please conclude, because you had
done. This last slide. So so we will be able to tell that, okay, what would be the implication if this protein is absent, what would happen? So the conclusion is this, that impaired expression of cyclin number is associated with impaired spermatogenesis, and it has something to do with germline stem cell. Promoter has been characterized, and we know its regulation, and we are making a chip. And that's my team. The work started with Sharad Purohit long ago in 1990s, and we were in the Devi University. So then we moved to Rajiv Gandhi Center. Uma carried it over. Then we had a lot of people who associated. So I just put arrows to show that, okay, well, yeah, Indu, Devi, Nomesh, and all these people are there. And as I said, Malini had been my long-standing collaborator, and the collaboration continues both at home and in the lab. We had a beautiful time with Dr. Jin Xiong, because he was a genomics guy. Our job was to teach him proteomics, because genes don't do anything if proteins are not produced. Well, there are some genes which don't produce protein; they're imported. But we convinced Jin Xiong at that time, fooled him in a way that okay, well, proteins are important, and he kind of believed. And Dr. Reddy has an NII, origin, Prabhakar Reddy. Professor Talwar, in case he was there, he would have recognized him. And we do have an active collaboration with Dr. Harry Lights in the London School, where Irfan spent a little time to work on PGCLCs. That was my last slide, and thank you for patient listening, and everybody had funded, so that's it. Thank you.
Hello.
Yeah.
I mean, as we are already, past the time quite a lot, but still, if there is any important issue raised, please bring it up. Any question, any explanation?
Dr. Pradeep.
Yes.
Please stop sharing.
Yeah, I'm trying to stop sharing. Oh, yeah, I saw it. I'm sorry. Yeah, I stopped sharing. Hi, Professor Talwar, you are there.
Yes, I am around, and I'm quite happy that you are getting the gold medal in my name. You've done splendid work, very extensive work.
Thank you.
Along with, of course, your equal half, Malini.
Yeah, so she is my professor's daughter. So along with PhD, I grabbed her also.
Okay, then I hope Professor Loya can give you the gold medal.
Yeah, sure. Thank you.
Where is Professor Loya? Is he around?
Very much here, sir. And we are delighted that maybe a little late you could join. And you would be pleased to know this time that the Oration Awards, they carry the photograph of the person in whose name the oration is being delivered. You can see the plaque being displayed here. And this has already been sent through courier, and it is being acknowledged by Dr. Pradeep. He has received both plaque as well as the gold medal. So he needs your blessings now.
The blessings are there. Please continue.
Oh, yeah. In case this was the real platform, I would have got a hug from you. I will be missing the hug.
Great. That will be another time.
Yeah. Thank you so much.
God bless you. And I guess we have to now go to the next speaker.
Thank you. Bye-bye.
And
sir, we have 10 young scientist awardees of 5 with different names. The first awardee is Miss Ruchita Sandilye from University of Calgary, Canada. She has interest research on the exploration of early differentiation, genes and external causes in 2 intimately connected cell types of blood vessels, leading to vascular tree formation, determining the coordinated ability of these cells to control blood flow. And she has several awards in that, and she will speak for her award entitled A Point of Care Essay for Detection of Cell-Free Circulating MicroRNAs using dual-level aminopyrin, that third carbon nanocomposites for diagnosis of female reproductive tract cancers. Please go ahead, Ruchita.
Okay.
Please share this.
Yeah.
Presentation.
I hope I am audible.
yes,
Okay.
Go ahead.
Okay. Thank you very much, Dr. Ansari, for the warm welcome. I am Ruchita Shandilya, a PhD student from Dr. Child's Lab, University of Calgary. And before proceeding with my session, I would really like to thank the whole ISSRF committee for bestowing me with this prestigious award. I'm truly honored. And the work which I'm going to discuss in this session was done in ICMR NIRE, Bhopal, under the esteemed guidance of Dr. Pradyum Kumar Mishra and Professor Irina U. Goresheva in the Indo-Russian Joint Collaborative Project. So we all know that reproductive tract cancers are the most common cancers in women after breast cancers, accounting for about like 14% of all female cancer cases as per the GloboCan statistics. Specifically, ovarian and cervical cancer are 2 most common reproductive tract cancers. They are mostly, and they are the serious public health issue. They are largely because of the lack of awareness, the variable pathologies which they which we find in different cancer cases, and there are like not many proper screening methodologies available for these tract cancer, these reproductive tract cancers detection. So, and due to this, many of the women, they report at very advanced stages, they significantly hamper the prognosis and clinical outcomes. In order to overcome this, nanoscience in collaboration with sensing technologies have led to development of various miniaturized frameworks, which we call nanobiosensors. There are many nanobiosensors in the market, which are like electrochemical based, they are optical based, or they can be mechanical based. But most commonly are the optical ones, which uses the optical modules such as fluorescence, luminescence, colorimetry-based approaches, absorption-based approaches. They are in too much in demand because of their high sensitivity, selectivity, their portability, their ease of construction, as per the requirement, their improved signal-to-noise ratio. So with increase in the optical nanobiosensors, increase in the liquid biopsy approach has been or we can say with increase in the use of optical nanobiosensors, liquid biopsy approach has been mostly used, majorly used nowadays, which involves detection of biomolecules in the circulation as disease-associated risk factors for precision diagnostics. And particularly, they are largely motivated by the fact that billions of cells are produced in a human body, and the same number of cells, they undergo apoptosis. And owing to this process, they release the genetic materials into the peripheral milieu, which can be detected. However, and they vary in their levels, like ranging from very scantily detectable to few milligrams, but their levels significantly increase in conditions like cancer. Our lab was highly interested in circulating cell-free microRNAs, which are short nucleotide sequences, 18 to 25 nucleotide sequences, due to their unique biological and physicochemical properties, such as short length, hairpin loop structure, low complexity, and they have high stability. They can be detected via various approaches like PCR, Northern blotting, microarray, next generation sequencing, but all of these methods, they have some of their own disadvantages. In addition to that, polyadenylation and reverse transcription prior to amplification has been an obligatory step, which adds on to all the processing and detection time. In order to reduce these processing times as well as to reduce the detection time, many miniaturized nanotechnological based frameworks have come into play in the recent times. One such approach was developed in our lab using aminopyrin tethered carbon nanodots based nanohybrid. They were formed using pi attractive forces, which constitute of strong attractive non-covalent intramolecular forces that occurs between the aromatic structures of the carbon nanodots and the aminopyrin. And they provide a base for stacking of the microRNAs in a given sample using pi stacking forces. So when these microRNAs, they are stacked, they can be detected via propydium iodide, or you can detect it using a specific antimer sequence for a specific microRNA with PI using flow cytometry and fluorometry. And this will be forming a triple or tricolored fluorescence nanocomposite, which can be detected using flow cytometry and fluorometry. So we characterized the aminopyrin tethered carbon nanotubes using gel electrophoretic mobility assay. As you can see, one aminopyrin has restricted mobility, and carbon nanotubes, carbon nanodots, they showed high mobility. But when one aminopyrin was attached to carbon nanodots, that showed restricted mobility, confirming that the nanohybrid has been formed. We also observed an augmentation in the fluorescence of carbon nanodots on attachment with the one aminopyrin. We thought that can we observe that the structure, the hybrid structure that we hypothesized was really as same as we had hypothesized. So we looked into in the fluorescence microscopy. As you can see, there are few green fluorescent clusters just around the blue fluorescent cluster of the carbon nanodot, confirming that yes, this is the nanohybrid structure. We also wanted to see if the microRNAs, they are entrapped or they are captured by these nanohybrids, and they can be detected by PI. So we also looked into fluorescence microscopy, and you can see there are few fluorescent red colored dots around, just around this cluster of blue and green nanohybrid, confirming that yes, the microRNAs, they are aligned in this position, and you can detect via propydium iodide. But these were in the enriched samples, like they were having there were samples which were enriched in a particular microRNA. So we wanted to see, and we want to see if we can see it in flow cytometry. So this, as you can see from this figure, this is the carbon nano dot aminopyrin tethered nanohybrid. This is the antimer, and this dual labeled, the dual positive region cluster that resembles that the microRNAs are entrapped. The microRNAs, they are captured effectively via the CND AP nanohybrid, and they can be detected specifically by the antimer and the propionimide. We also saw the shifting in the fluorescence intensity on attachment of microRNA with PI. So this was like pretty interesting for us. We also wanted to check if the approach is able to detect even the teeny tiny bit of microRNAs that are present in the samples. So we used microRNA 16-5P as our target microRNA, and we developed an antimer sequence, and we wanted to see if we can detect it in fluorometry. As you can see, the sensitivity of the approach was ranging from nanogram to femtogram, or you can easily detect even lower than that, even lower than femtogram levels of microRNA in a given sample, in a given clinical sample. And this was the reproducibility of the approach, showing that the high reliability of the methodology. We wanted to see if the approach is applicable to isolated samples, not the enriched, just the isolated samples. So we kind of compared them. And you can see the comparative analysis in the isolated samples and the enriched samples, showing the similar pattern of detection at different concentrations, conferring the reliability and the feasibility of the methodology in real-time detection, and highlighting the translational significance of the approach for detection and control and experimental settings. Some additional aspects of this method is it took hardly like 15 to 20 minutes for the detection. Just have your isolated sample, add the nanohybrid solution, add the antimer, add the PI, and just go for the flow. It hardly takes 15 to 20 minutes. And it requires about 1 or 2 microliter of your sample, so you can detect many number of microRNAs from a particular given amount of sample and multiple times. So this was very rapid concept approach, and it fulfilled the criteria for a point of care methodology. So I am really happy, and I'm really thankful to Dr. Pradyum Kumar Mishra for giving me the opportunity, guidance, help, support, in whichever form he can give, and to the team for helping me out throughout my tenure in ICMR NIRE. I am feeling blessed to be a part of that great team. Thank you so much. And this is the award, so I'm really thankful to ISSRF for giving me the award. Thank you so much, and I'm open to any questions.
Are there any questions? If not, thank you very much.
I have one question, if I'm allowed to.
Hurry up, please do.
Yes, just I was wondering, it was a very nice presentation, but I was just wondering that what kind of benign conditions and the other diseases of breast and you have checked for the presence of this marker?
Well, ma'am, honestly speaking, we have checked it only it was like a prototype approach. So we have to check it in the clinical samples, specifically the breast cancer samples. And we are moving on to that phase of experimentation. So yes, definitely we're going to do that. Thank you so much for asking the question, by the way.
Okay. Thank you so much. And I hope somebody can give you the medals or whatever the prize is. All the best. Keep doing good work.
Yeah.
Thank you so much, sir.
Congratulations.
It's a great honor.
Maybe ask Dr. Vivek Pandey to come up and to give his presentation. Vivek, please.
Yes, sir. Yes, sir. Yes, sir. I am audible, sir?
Yeah, you are. At least to me, I hope. And as I am at a distance, the others should be hearing too.
The second founder president, Dr. T.C. Kumar Young Scientist Awardee is Mr. Vivek Kumar Pandey from Banaras Hindi University, Varanasi. His research interest includes reproductive physiology, stem cells, and biology, currently focusing on the genetic and molecular mechanism involved in pathophysiology of uterine fibroid and looking for its therapeutic aspects of using phytochemicals. And he has received many awards. And now I invite Mr. Vivek Kumar Pandey for his oration.
Thank you, sir. Thank you, sir. It's my pleasure to perform my research work here. And I am thankful to Lohia, sir, and esteemed chairperson, Talwar, sir.
Please do presentation mode. Please go to presentation mode.
Okay. Thank you.
Yes, it's okay.
I feel honored to nominated as the most prestigious Dr. T.C. Anand Young Scientist Award. So today here I am going to present my research topic, deoxyribonucleic, a novel naturally occurring phytochemical impair growth, induce genome arrest, RAS-related apoptosis, and modulate the expression of various LNC-RNA, which play important role in uterine fibroid pathophysiology. So first I introduce what is uterine fibroid. Uterine fibroid is a benign tumor of the female genital tract, and about 50 to 60% of female suffer during their pre-menopausal age, and 20 to 25% female at their reproductive age. And it is estimated that 20 to 25 million women are suffering with uterine fibroid, according to Ministry of Health and Family Welfare, and it is a major cause of infertility in India. Due to their high incidence and lack of proven treatment, this is cause significant impact on reproductive health. It have common symptoms like non-cyclic pain, pelvic pressure, and other that are closely associated with pregnancy and infertility. So fibroid are classified by their location in the uterus. These are subserous, intramural, submucosal, and pedunculated. It is found that some mucosal fibroid cause implantation defect in the uterus. That is the major cause of infertility. This is the concept, the pathways which are involved in the development of uterine fibroid. It is well known that mesenchymal of the uterus have stem cell-like origin due to genetic aberration in these cells, like somatic mutation in MET12 and HMG. These cells is transformed into fibroid stem cell, which are triggered by various factors like gonadal steroid hormone, growth factors, and many pathways like Wnt pathway and hypoxia, and convert these fibroid stem cells into mature fibroid cells. So till date, no long-term medical treatment are available for treatment of uterine fibroid except surgery and some conventional drug. But these treatment cause several side effects and cause infertility and sometimes recurrence of this disease. Therefore, in order to cure the occurrence of this disease, we need to emphasize a plant-based therapy. At present, a negligible number of phytochemicals has been tested for therapeutic against uterine fibroid. So why I is using phytochemicals? Because phytochemical has tendency to interfere with many signaling pathways which are involved in tumorigenesis, and they also halt the growth of various tumor at different stages of their progression, and these are cost effective and safe as well approach. So at present, only few phytochemicals such as curcumin and genistein has been studied against uterine fibroid. So I have chosen one phytochemical, that is deoxyribonucleic, which are isolated from Elephantus scaber. Is widely distributed all over the world. It's also found in India and African countries. So because because deoxyribonucleic have significant antioxidant, anti-tumor, and anti-proliferative activity. So So I have against many cancer like breast, cervical cancer, and lung cancer. So studies also suggest that these DOE target multiple molecular mechanism which play central role in the development and proliferation of a tumor. So till date, there are no report that examine the effect of DOE against uterine fibroid, while it might have be therapeutic potential to cure the uterine fibroid. So I am going to my slide, what I doing during my research work. Till date, there are no cell line are available for the uterine fibroid. So firstly, I isolate the primary culture uterine fibroid cell from the patient sample. And you can see here the growth of the cell from day 0, day 3, and passage 1 to passage 8. And these fibroid cells are characterized by mesenchymal stem cells marker, which are potently expressed in these cells. So you can see here the expression of CD44 and CD19 in the uterine fibroid cells. So next, I perform the cell viability assay to find out the effect of DOE against uterine fibroid. Can it inhibit the growth of these cells? So for that, I perform MTT assay and find that yes, DOE inhibit the cell viability with time and dose dependent manner. From here, I decide the dose of DOE to conduct to understand the molecular mechanism of DOE against uterine fibroid. And after that, I treated cell with different concentration of DOE and find that uterine fibroid DOE inhibit the growth of the cells, uterine fibroid cells, as you can see here with increased concentration of DOE. And after that, I perform colony formation, long-term colony formation, and find that number of colony decrease with increased concentration of DOE. So whether these cell growth, whether DOE affect the cells growth of cells by affecting which stage of the cell cycle progressions. For that, I perform facts analysis and find that with increased concentration of DOE, cell cycle arrest in G2M phase. As you can see here, the number of cell increase in G2M phase. Further, these growth apoptotic G2M arrested cell goes to apoptosis. For that, I perform AOPI dual staining and find that with increased concentration, number of apoptotic cell increase with you can see here with cellular nuclear uptake of PI stain. This result is also confirmed by our PI facts analysis data. As you can see here, with increased concentration of DOE, number of apoptotic cell increase. So further, I am looking to localize the apoptotic protein marker after DOE treatment and find that the expression of anti-apoptotic BCL2 localization decrease with increased concentration and upregulate the expression of pro-apoptotic caspase 3 with increased concentration of DOE. This result is also supported by Western blot analysis data. As you can see here, the pro-apoptotic BCL, anti-apoptotic BCL2 decrease with increased concentration of DOE and upregulate the BEX and caspase 3 protein expression in increased dose dependent manner. So whether I am looking whether these DOE cause induce apoptosis by intracellular RAS level inductions. For that, I treated cell with different concentration of DOE and found that yes, DOE induce the apoptosis by RAS intracellular RAS generation. As you can see here, with increased concentration, cell were uptake more DCFDA dye, and this result is also confirmed by my facts analysis. As you can see here, the more number of cells are present in maximum concentration of DO. It is also known that various ECM component and endogenetic factor involved in the tumorigenesis and pathogenesis of uterine fibroid. So I checked the mRNA level of these angiogenic and proliferative and ECM component and find that the relative mRNA expression level of these proliferative pCRNA and cyclin D1, angiogenic VEGF, and extracellular component are downregulated with increased concentration of DOE. And some study also reported that several lung encoding RNA which play important role in the many cancer by modulating epigenetically. So some reported also found in earlier report that LNCRNA modulate the expression of play important role in the pathogenesis of uterine fibroids. So here you can see that DOE first time I am looking to that DOE also are an phytochemical inhibit these oncogenic LNCRNA and find that yes, DOE significantly downregulate these LNCRNA in dose dependent manner. So this is my summary, and I conclude that deoxylifentopin degrade the excision component and induce RAS apoptosis, RAS mediated apoptosis by downregulating VAX and caspase BCL2 and upregulating VAX and caspase protein, and arrest cell cycle by to inhibit the cell proliferation, and interestingly find that DOE also downregulate the oncogenic LNCRNA to inhibit the cell proliferation of the uterine fibroid cells. This is my take home message, because this DOE have antifibrotic activity. DOE may be provide a comprehensive assistance for the treatment of uterine fibroid to reduce the infertility and enhance the reproductive success in the female, and emerging as a boom in the modern world for the better of the society. Moreover, new research finding with DOE severely outspread the new insight for research, patients, oncologists, and policymakers. I would like acknowledge. I would like to extend my sincere thanks to ISSRF for giving me this prestigious award, that is the Founder President Dr. T.C. Anand Kumar Young Scientist Award. I am deeply grateful to my mentor Dr. Pon Kumar Ji for their guidance and their constant support through my research journey. I am highly thankful to my parents also for their constant support. Thank you.
Good, good, keeping time.
So can I ask one question, please? Yeah. So can I ask one question, please? Yeah.
Yes, sir. Yes.
Yeah. Thank you. Yeah. Thank you and congratulations, Vivek. I was just wondering, what would be the comparative reference for DOE in terms of phytochemicals? Could you consider, say, curcumin or turmeric or any other phytochemicals, if at all, if you're asked to compare or consider any comparative reference?
Means, sir, actually DOE not used against many cancer, and this is a new drug which are play important role in tumor to inhibit the proliferation and the many cancer like lung and cervical cancer, as I
understand. There should be, I thought, there should be a kind of a comparative reference, or whether or not, any docking complexes was made, taking the fibroid, drug molecules as a kind of a target.
No, sir. No, sir. No.
Thank you. Thank you.
Thank you.
Thank you. Thank you.
Now we would push to the next.
Stop sharing.
And
thank you, sir. I am honored.
Congratulations.
I think these will be made available to you by Professor Loya.
Thanks.
Now we come to Young Scientist Awards, which I have been lucky enough to give. And the first person who's delivering it and getting the award is Dr. Somaya Ranjan Jaina. So would you please come over and let us hear your presentation on comparative proteome profiling of seminal components reveal impaired immune cells, the signaling paternal contributors in recurrent pregnant loss patients. Go ahead, Dr. Pandey.
Good afternoon, everyone. Am I audible?
Yeah, you are audible. Please
Yes, you
have
are audible.
slide presentation. Go
Make it
to
a slide
slide
show.
presentation mode.
Yeah.
Good afternoon, everyone. I am thankful to Professor G.P. Talwar sir and Professor A.N. Ansari sir for chairing the session. I am going to present on comparative proteome profiling of seminal components reveals impaired immunosignaling as paternal contributors in recurrent pregnancy loss patients. First, recurrent pregnancy loss, what is known and what yet to be known. Spontaneous recurrent pregnancy loss defined by 2 or more losses in clinical pregnancy. It includes embryonic and fetal losses. It also affects nearly equal to 2.5% women in worldwide. Up to 50% cases will not have a clearly defined etiology. Previously, RPL is upon investigation from the woman's perspective. Now, seminal oxidative stress and sperm DNA fragmentation is reported to be associated with RPL. Then, what are the possible mechanisms? Only defect spermatozoa are the probable factors. What are the possibilities? Recent evidence implies involvement of male factors in RPL as paternal express gene predominate the placenta. During fertilization, prior to implantation, the immune system purposefully produces early pregnancy factors with potent immunomodulatory properties for adaptation to antigenically dissimilar embryo. Does seminal plasma invoke immunomodulation of the female? If so, how are these factors or molecules signals transferred? For this, does extracellular vesicles found in seminal plasma have a role to play? Then I targeted the extracellular vesicles. The proteome of spermatozoa, despite being transcriptionally and translationally silent, undergoes several modifications at the molecular level during transit through the male and female reproductive tract. Many proteins and RNAs associated with the extracellular vesicles are known to be selectively transferred to or out of the sperm, which modified the sperm function. Then what is extracellular vesicles? Extracellular vesicles are small nano vesicles which the size is in between 30 nanometer to 500 nanometer, and it categorized into 3 parts. One is microvesicles, another one is exosomes, and apoptotic body. The exosomes are 30 to 100 nanometer in size. The microvesicles are 100 to 500 nanometer in size, and 500 nanometer beyond that are called apoptotic bodies. And these extracellular vesicles are secreted by 2 pathways. One is endocytic pathway and another one is secretory pathway. Then seminal extracellular vesicles in reproduction. Seminal plasma contains a heterogeneous population of microvesicles called seminal extracellular vesicles. These SCVs include mainly tetraspanin CD9 positive epididymosomes and prostosomes, which account for 3% of the total protein complement of seminal plasma. Here, the epididymosomes and the prostosomes secrete from the epididymis and prostate gland, which modified the sperm function, and after the ejaculation, first it removes the decapacitated proteins in female reproductive tract and also immune modulate the female reproductive tract fertilization and implantation. Then SCBs also play a major role in sperm maturation in male reproductive tract. Then my hypothesis is paternal immunological factor play a role in RPL or not, or a probable transferring molecules signaled by extracellular vesicles or soluble factors. My objective is to identify and understand the possible paternal factors responsible for early pregnancy loss through differential proteomic analysis of seminal components, that is spermatozoa, seminal extracellular vesicles, and extracellular vesicle free seminal plasma by level free liquid chromatography and mass spectroscopy. This is my experimental design. First, I have collected the semen sample after ethical clearance from Institutional Ethics Committee and Correclining Hospital, Bhubaneswar. Then I collected the semen sample and fractionized into 3 parts. One is spermatozoa, second one is seminal plasma. From seminal plasma, we use ultracentrifugation to segregate the seminal extracellular vesicle and extracellular vesicle seminal plasma. Then I the seminal extracellular vesicle pre-seminal plasma and sperm to go for LC-MS proteomics analysis, because we targeted extracellular vesicle pre-seminal plasma because if there is any soluble factors is there to modulate the immune signaling in female reproductive tract or not. This is my, according to WHO criteria, the semen parameters in RPL group are normal. But what happened to the female part of recurrent pregnancy loss patients? First, I have isolated the seminal extracellular vesicle, then validated this seminal extracellular vesicle by scanning electron microscope in control. Control means those are fertile donors. And in RPL, partners of recurrent pregnancy loss patient. I found that the size of the extracellular vesicle is less than 200 nanometer in control and in also in RPL cases. Then I go for atomic force microscope for surface morphology of the extracellular vesicles. Then I found in the size of the extracellular vesicle is less than 200 nanometer in scanning electron microscope. But average size of the extracellular vesicle is what? Then I go for dynamic light scattering for the average size of the extracellular vesicle. Then I found that in control it is 193 nanometer and in RPL cases it's 187 nanometer. Then according to the International Society for Extracellular Vesicle, we have to validate the surface marker proteins of extracellular vesicles. Then I validated the surface marker proteins of extracellular vesicles by CD9 and CD81 tetrasmanine markers. Then in my proteomics, I have found in SCVs, means seminal extracellular vesicle, I have found 68 proteins. In the 68 proteins, 35 upregulated and 33 are downregulated. In the 35 upregulated and downregulated protein, here we have set up a cutoff value minimum two-fold change. So according to the cutoff value, we have decided the differentially expressed protein to 68. In seminal vesicle pre-seminal plasma, we have found 28 differentially expressed protein with greater than two-fold change is 28. From 28, 7s are upregulated and 21 are downregulated. In spermatozoa, it also found 49, that is 13 upregulated and 16s are downregulated. From heat map, we have here found the abundance of the proteins in control n equal to 3 and in RPL n equal to 3 in numbers. The hierarchical clustering of heat map showing the color coding green and red color denote the low and high expression levels of proteins in RPL cases. Then from my differentially expressed protein, that is found 68, 28, 49. How I have selected this, these are immune signaling proteins or not. Then I go for IPA, ingenuity pathway analysis. In ingenuity pathway analysis, the top function from the disorders category and top function of physiological system development and molecular and cellular category, I found that these 68 in SCB, 28 in EVFSP and 49 in spermatozoa are immune regulated protein in my data set. Then I go for pathway analysis or protein-protein interaction analysis in gene mania, I found that in SCVs, means seminal extracellular vesicle, I found that these proteins are majorly involved in immune response signaling proteins, chromatin packaging and remodeling, protein folding and apoptosis. In EBF-SP, means extracellular vesicle free seminal plasma, I found that these proteins are involved in immune response and signaling proteins. And also in spermatozoa, I found that these are involved in also in immune response and signaling proteins. But we cannot validate these 68, 28 and 49 proteins, differentially expressed protein in spermatozoa, extracellular vesicles and extracellular vesicle free seminal plasma. So I used cytoscape and the hub protein analysis, and the hub protein algorithm said to which are the key proteins are involved in this regulatory network. Then I found that these in seminal extracellular vesicle, the two major proteins are found which are regulate the immune cell signaling, that is innate immune system, adaptive immune system, cytokine signaling in immune system, and second one is toll-like receptor signaling, regulation of complement cascade and interferon gamma signaling. So what I concluded from this, now here I found that the GDF15, the key regulators, because previously known that GDF15 is the master regulator for embryo implantation. And C3 also there for maternal immune tolerance. Then I go for extracellular vesicle seminal plasma. Then in extracellular vesicle seminal plasma, I also found that the TGF beta and TGF beta 1 and TGF beta 3, which are also regulated by GDF15 and pleiotropin proteins. Then I go for spermatozoa for pathway analysis. Then I found that the innate immune response and innate immune response, adaptive immune response, that two key pathways are dysregulated in spermatozoa. Here in whole scenario, I found that in my hub protein algorithm, the GDF15 is the key regulator and C3 is the key regulator of the immune signaling process. Then I go for validate for this C3 and GDF15. I found that C3 is upregulated and GDF15 is downregulated in RPL group with respect to control. Then I summarize that underexpressed GDF15 with overexpressed C3 in SCVs may be involved in altered maternal immune response to paternal antigen, resulting in impaired decidualization. Decidualization means for endometriosis formation. Then GDF15 thus has a potent tolerogenic function and may be involved in the protection of the semi-allogenic fetus from immune-mediated rejection by the host immune system. Dysregulated of TGF beta 1, beta 2 and beta 3 signaling in extracellular vesicle seminal plasma may lead to defective modulation of inflammatory response, induction of immune tolerance to seminal antigen in the female reproductive tract through generation of regulatory T cells. Then retained histones and variants in spermatozoa summarize defective expression of early paternal genes, while underexpression of PTN, pleiotropin proteins, may lead to defective angiogenesis, resulting exclusion of decidua. The result suggests that impaired modulation of immune response and improper placental development due to altered cytokine levels may the contributing paternal factors in RPA. Then I am ineffably indebted to my supervisor, Professor Luna Saman, for encouraging and guiding me throughout my project work, and for Dr. Sujata Kar for giving clinical samples, and Dr. Anshuman Dikshit from Institute of Life Science, Department of Biotechnology, for providing Ingenuity pathway analysis facility, and thank to my lab members Dr. Nilipta, Jasmine, Lisa, and Anwisha. Then my special appreciation to ISSRF 2022 and CSIR for funding me, and then Odisha government and B Proteomics for proteomics facility. Then I am grateful, honored to the organizing committee for the prestigious Professor GP Talwar Young Scientist Award. Thank you.
Please. Sir, please come in. Talwar sir.
The next person is Mamta Sajwan Khatre. I'm very happy that you're receiving the award too. And let us hear what you have to present.
Thank you.
Please. Mamta, please
Yes,
go
sir.
ahead.
Yes, thank you, sir.
Welcome, welcome. University.
Thank you so much, sir. A very good afternoon, one and all present here today. Just a minute. Okay. A very good afternoon, one and all present here today. First and foremost, I would like to thank respected chairpersons, Honorable President of ISSRF, Professor Ankil Lohia, Secretary Dr. Ashish Sharma, dignitaries, Convener Professor Sari sir, Organizing Secretary, and the entire SSRF family for giving me this opportunity to receive this young scientist, prestigious young scientist award, and I'm truly honored for this. So today I'm going to talk about my award lecture on implicating GDN of GFR1 and associated factor tyrosine hydroxylase and sex steroid in brain and gonadal function and also in neurodegeneration. So to briefly introduce glial cell line derived neurotropic factor called GDNF is a signaling molecule and potent survival factor for central and peripheral neuron. It is strongly bind to receptor GFR alpha 1 to signal RET complex to promote differentiation of dopaminergic neuron in brain and gonadal function under the normal condition. However, when receptor is mutant, it constantly provides signal to cells to grow and divide and eventually uncontrolled growth. So based on this study, we wanted to evaluate a significance in dopaminergic neurons and brain function and ultimately reproduction. So to identify the GFR1, initially we started with the molecular cloning where we have found approximately 1400 base operating frame, which encode 467 amino acid residues. As we can see over here, the conserved domain of GFR alpha 1, which shows high homology with other vertebrate counterparts with multiple sequence alignment and phylogenetic analysis. Later, to see the expression profiling using tissue distribution and ontogeny expression differentiation, we have found that the GFR alpha mRNA level was significantly higher in brain of both sexes and ovary, and however, the other organ it got the moderate levels. On the other hand, ontogeny analysis, where we have collected sample from 0-day post-hatch to 250-day post-hatch, and we found this GFR alpha overexpressed during early development, 75-day post-hatch to 100-day post in female brain, which might favor, we can say that GFR alpha might favor the early stage of brain development, which supports gonadal function. Later, we wanted to see the expression in different regions of the brain, which play a crucial role in this development. So we have collected 5 different regions of the brain, that is telencephalon olfactory bulb, pituitary, preoptic area, hypothalamus, thalamus, and medulla oblongata, where a GFR alpha was considerably higher in preoptic area hypothalamus. Later, we wanted to localize the GFR alpha at the level of protein and mRNA. So we have performed immunohistochemistry and to localize GFR alpha protein, and we have seen that this protein was give a prominent signal of this in preoptic area hypothalamus in the central nervous system, as we can see the positive and the negative and pre-observed antibody treatment show the no immunotactic in the same area of the brain. These results supported well correlated with the immunohistochemistry by localizing GFR alpha mRNA in the same region of the brain when sense probe shows a negative control. So by and large, these results support the vital significance of GFR-alpha in the central nervous system, which confirm its role in dopaminergic neuron. So a more important part of this study is the impact of Dangerous silencing to see the regulatory input of the GFR-alpha siRNA in vivo and vitro. So we have performed in vivo study to, by PI-mediated siRNA through brain-targeted injection, as we have found that the delivery of the PI and FGFR-alpha siRNA complex decrease the expression in the central nerve, decrease the expression of the GFR in the brain. How after 7 days of silencing, we have seen the expression of the various brain specific genes. These are crucial factors for the brain cells differentiation: tryptophan hydroxylase, tyrosine hydroxylase, GnRH, HSD3B, aromatase, CYP19A1B, that's aromatase. And these genes are downregulated significantly after the silencing. So silencing of GFR-alpha act is the foremost target to regulate the expression of gene signaling through this neurotrophic factor receptor demonstrated as well. But how the mode of action is not yet clear. Similarly, in vitro analysis, we have used mammalian glial cell line and using the levofectamine, and we have found this in vitro results also support the in vivo that we have found mRNA of GFR-alpha was considerably downregulated after 24 hours after transfection, and more significantly downregulated 48 hours. So this was further validated by the Western blot, where the protein level was diminished after the siRNA silencing. As we can see over here, the control brain shows the prominent band. So our finding on the silencing, which showed the reduced level of the tyrosine hydroxylase, which is a rate-limiting enzyme of catecholamine biosynthesis, and it regulates the dopamine release and dopaminergic neuron from dopaminergic neuron and release of the GnRH axis by modulating hypothalamo-hypophyseal gonadal axis, and also play a main role in central nervous system. So in view of this, we wanted to see the interaction of GFR-alpha and tyrosine hydroxylase with associations of DHT activity. We wanted to study neurodegeneration by inducing MPTP, that is a neurotoxin, in vivo and vitro. So the MPTP is a well-known drug that causes a permanent symptom of Parkinson's disease by specifically destroying dopaminergic neuron in human and many in animals. So what we have done is in vivo study, we have done direct administration of MPTP into the brain for 7 days. 7 days, and we have seen the in vivo study. In vivo study, we have seen that GFR-alpha mRNA level was considerably downregulated as we have increases the doses of MPTP. Later, we have seen the changes in the level of catecholamines, where catecholamines level after the by HPLC analysis, where we have seen all the product of the catecholamines like L-dopa, dopamine, and norepinephrine got downregulated with the concentration, with the increasing concentration. So this further confirmed that the MPTP did have impact on the catecholamine synthesis, and the association of GFR-alpha and catecholamines in particular DA is evident. Later, we wanted to localize tyrosine hydroxylase to see the impact of the MPTP. So before treatment, we have seen a prominent expression of tyrosine hydroxylase in midbrain preoptic area hypothalamus and thalamus. As you can see, this is the DEPI and Mars, and also protein specificity by immunohistochemistry, as you can see. And after MPTP treatment, we have seen the reduced expression of the tyrosine hydroxylase at the 4 days and 7th day. So we saw the impact of MPTP on dopaminergic neuron. Later is MPTP also effect on the ultrastructure of brain, where we have found the disarray of brain structure or abnormal structure changes in the brain cells, as we can see here, so using the TEM analysis. So later, neurodegenerative, if we want to see the neurodegenerative effect on the transcript, which are the GFR-alpha-1, GnRH1, CYP19A1B, and also the gonad CYP19A1B PAX2, which are crucial factor for brain and gonadal functions. So we have seen that after quantitative latent Excel analysis showed the certain brain and gonadal gene got down-regulated after MPTP exposure, which are the crucial factor for sexual development and ultimately the reproduction. So in vivo study also supported the in vivo one, and we have performed MTT assay to see the relative cell viability percentage, and we have found the dose responses reduction dose reduction in the cell viability, and also flow cytometric analysis apoptosis, where we have found the increased apoptotic cells and damaged cells upon the exposure of neurotoxin. We showed that this diergic neuron are susceptible to neurotoxicity of MPTP. Having input of estradiol, as we know that estradiol has a neuroprotective effect for neurodegenerative diseases, we wanted to induce a estradiol. So what we have done, so we have done the controlled release of estradiol through osmotic pump, which alter the GnRH1 and dopaminergic system. So this is the ostomal plant we have implanted through IP administration, loaded with the sex steroid, that is E2 and with estradiol and methyl testosterone. So this osmotic pump is why we use this, because osmotic pump is a small device that employs osmotic pressure as a driving force to deliver specific drug accurately and continuous mode within the required time span. So after this, we have checked all the expression of brain-related gene after the control release of the sex steroid, which got diminished by MPTP. So what we have seen is all gene which is crucial for the brain development is called elevated after this E2 release. So which on the other hand, we can see the MPTP did not show much changes, or it got down-regulated these genes. So we can say that E2 mediated upregulation of the gene lead to elevated of the diergic system. So as we can see, when the DA or TH got elevated, so DA also got elevated here. So this E2 mediated upregulation of TH lead to elevate of DN levels, which might be responsible for the altered brain responses. Later, as we know that the GnRH play a vital role in modulation of the hypothalamus-hypogonadal axis, we wanted to check the expression of the GnRH1, and we have seen we localize this protein, and we have seen different region of the preoptic area, thalamus, pituitary, and all region of the brain with the expression of this GnRH1 got elevated by E2 treatment and diminished by the MPTP. So, but this work is not yet completed because the one is yet to be studied to compare the changes in the brain after sex steroid treatment. So based on this study, we can conclude that the involvement of GTNF-GRFA1 and associated filter TSDA might be critical for brain to regulate gonadal function, and also can be considered to considered a candidate molecule to protect, regenerate the dopaminergic activity. So, and their association with the estrogen axon in the injured brain ultimately lead to more understanding the precise mechanism underlying estradiol-mediated protection. So this is my future perspective, where I wanted to work on the current advances of translation and clinical neurocrinology, TCM researched it, and to see this implication on the reproductive health by using combination therapy, using steroids and neurotrophins, and also testing efficacy of specific biomarkers and associated factor to protect neurodegeneration. So these are the publications in this field. So I would like to acknowledge Department of Science and Technology for funding me, Professor B. Senthil Kumaran for providing me laboratory facilities, and his mentor C, Professor Y. Suresh, who introduced me to this society and encouragement, and entire ISSRF team for his motivation and this Young Scientist Award, which is really going to help for our growing careers. Thank you. Last but not the least, I would like to thank my family and Almighty God for countless love, encouragement, and blessings. Thank you so much.
Welcome, welcome. Well, that's not a bad mark, by the way. Anyway, I hope any question anybody would like to raise? If not, then all the best to you. Continue good work.
Thank you so much, sir.
Yeah. And Professor Loya or somebody should give you the award on our behalf.
Yes, sir. Thank you so much. Thank you, everyone.
Next.
Sir, please, next.
Well, next we are moving to another colleague of mine who is no more. He has departed, and our Luteal Young Scientist Awards. And the first person to get it is Elango from NDRI Bangalore. Elango, please go ahead.
Sir. Yes, sir. Thank you, sir. Thank you so much, sir. I will start sharing. Is my slides visible, sir?
Oh, yes, of course.
Yes.
Lovely bulls.
Yes, there is.
Good-looking bulls.
Yes, sir. Thank you, sir. First of all, thank you so much to ISSRF for bestowing me with this honorable and prestigious award. And then more than that, for giving me the opportunity to present our work in front of the eminent scientists. Thank you, sir. First, let me begin with the presentation. I am here to present my research work on testicular transcriptomics, indigenous prevailed over crossbred cattle. This work was conducted with the guidance of Dr. A. Kumaresan, principal scientist in ISSRF Bangalore. We all know that when it comes to human reproduction, both male and female are equally important for the fertility. But in case of animal reproduction, especially in case of bovine, male infertility is highly important than the female infertility, because the ejaculates from the single bull is used to breed several thousands of females every year with the help of artificial insemination technology. So the male fertility is highly important in case of the bovine reproduction. However, many crossbred bulls, that means the cross between the Bos taurus and Bos indicus, are prone for many reproductive problems. We may know that species hybridization, when we cross between the two different species, the resultant male progeny will be always sterile. Likewise, when we cross between the Bos taurus and Bos indicus also, the resultant male progeny, even though they are not sterile, they are prone for many reproductive problems such as poor sperm function, endocrine disturbances, ejaculate rejection rate, and subfertility. Even though libido and the age at first semen donation is good in case of crossbred bulls, the seminal parameters, cryosurvivability, and the lifetime semen dose are poor in case of crossbred bulls. To understand the reason behind this higher incidence of crossbred bull infertility, so many studies have been conducted at the level of semen production, seminal attributes, histology, endocrinology, genomics, and proteomic profiling of sperm, seminal plasma, and spermatogenic and Sertoli cells. However, the reason was not elucidated completely. So, since the quality of the ejaculate is determined by the testicular environment, the testicular mRNA may hold the key to understand the reason behind the crossbred bull infertility. So, with this background, we devised the following objectives that are transcriptomic profiling of testicular tissue from Tharparkar and current-free cattle, and then the identification of differentially expressed pathways associated with the spermatogenesis and sperm function. For this study, we collected the testicles from the current-frees and Tharparkar males, current-frees which is crossbred, and then Tharparkar which is indigenous bull. The testes were collected by the unilateral castration, or we can call it as architectomy, and then we extracted RNA, and then synthesized cDNA, and then we performed a microarray experiment, and then we did bioinformatics analysis by functional annotation with the help of David software, and then the interaction between the genes that were studied by Plugo. These are the top 10 genes, means abundantly expressed transcripts we found in the testes of bulls, in which cytochrome C oxidase 3 and 2 are among the top 3, which are involved in the electron transport chain. Especially, they are helping in the ATP production in the midpiece of the sperm. And then the tubulin and then thymosin, they are the part of microtubulin of the spermatozoa, and then outer dense fiber of sperm tile, which is the part of axonium of the spermatozoa. And then the ferritin, which is protecting the spermatozoa from the spermatozoa or any other cell from any oxidative damage. And then the protamine, which is a very important gene. It is highly important for the chromatin condensation and then for the maintaining the chromatin integrity. Overall, in the testes, we found 40,409 transcripts, in which 1,038 were upregulated and then 428 were downregulated, whereas the 12,953 were co-expressed. And then these are the top 10 upregulated and the top 10 downregulated transcripts in the crossbred bulls. Here I have highlighted some of the 5 transcripts which are related to the sperm function. IL-12, which is the interleukin 12, which is having the damaging effect on the sperm membrane, and then the MAP6, which is microtubule associated protein, and then PI4KB, which is involved in the phosphatidyl inositol pathway, which is important for capacitation and acrosymbry, and CCDC12, which is involved in the spermatogenesis, and then DPI19L2, which is having the role in the formation of sperm macrosome and maintaining the sperm head shape. And then the functional classification of the upregulated genes revealed that they are involved in the spermatogenesis, spermatid development, sperm motility, acrosome vesicle, and then ubiquitin protein ligase activity. Here we can see that majority of the upregulated proteins were involved in the proteolysis. Nearly 22 genes were involved, and then the ubiquitin protein ligase activity, ubiquitin conjugating enzyme binding. All these are indicating the many genes are many upregulated genes are involved in the protein degradation in the crossbred bulls. And then the pathway analysis revealed that the upregulated pathways are E3K AKT signaling pathway, and then the JAK-STAT signaling pathway, and then GABAergic, endocannabinoid, and steroidogenesis are down-regulated in the crossbred bulls. And then we found that the genes involved in cell proliferation, stem cell differentiation, protein localization to plasma membrane, stem cell population maintenance, male gonad development, WNT signaling, positive regulation of CAMP process, heparin binding, WNT receptor activity, all these genes are down-regulated in the crossbred bulls, even though their function is very important for fertility. And then this is one of the important finding of our study, that one is the genes, nearly 24 genes involved in the steroidogenesis are down-regulated in our study. Steroidogenesis, we know that it is highly essential for maintaining the male fertility, especially by producing progesterone, testosterone, everything. Already in previous studies also, they reported the lower concentration of testosterone in case of crossbred bulls. Here we have reported the molecular interactions behind that. Here we can see that COEP17A1, which is otherwise known as 1720 lyase, which is important for the steroidogenesis, which is also down-regulated in case of crossbred bulls. And then the WNT signaling pathway, this pathway, as I already told, it is important for maintaining the protein integrity and then for the epididymal sperm maturation. However, the genes involved in this pathway are down-regulated mainly. And then the phosphatidylinositol signaling pathway, which is involved in the actin polymerization, which will help in the sperm capacitation and acrosome reaction. However, the genes involved are down-regulated. And then we selected these 10 genes based on their functions related to the sperm function or spermatogenesis for further validation by using qPCR. By using qPCR, we validated the selected 10 genes in 10 indigenous and 10 crossbred bull testes, in which we found that TNP1 and TNP2 are upregulated, whereas the SPATA7 and then sperm1 were highly down-regulated, significantly down-regulated. We can see SPATA7, which means spermatogenesis associated 7, and then the Sperm1, spermatid maturation 1. Their name itself implies that they are related to the spermatogenesis and then spermatid maturation. However, they are down-regulated in the crossbred bull testes. Therefore, we summarize our finding by saying that the down-regulation of WNT pathway, which is important for protein integrity, and then upregulation of ubiquitination, which is opposite, but upregulation and downregulation collectively indicating the protein degradation in the crossbred bull testis, and then the endocannabinoid signaling pathway, which is essential for the sperm oviduct binding, and then the CAMP signaling PI4KB, which are essential for the capacitation, and then GABA receptor present in the sperm surface is essential for the progesterone to induce its response on the sperm. But and then heparin binding, all these things are involved in the capacitation and acrosome reaction are down-regulated, and then the steroidogenesis, SPATA7, cell proliferation related genes are down-regulated, which is indicating of tubed spermatogenesis and crossbred bulls. So we concluded that abundant protein degradation by ubiquitination and then the down-regulation of WNT signaling, cell proliferation, differentiation, and steroidogenesis might be the reason for higher incidence of poor semen quality and infertility in crossbred males as compared to indigenous males. And then the down-regulation of SPATA7 and then the upregulation of transition proteins in crossbred bulls are indicating the impaired spermatogenesis processes, including impaired chromatin compaction in crossbred bulls. This was the publication we got out of this research. And then once again, I thank ISSRF for bestowing me with this honorable award. And then I want to thank the members behind this work. This is our Theriogenology lab of SRS and TRA. Thank you so much, sir.
Thank you.
Sir, can I ask one question, please? Yeah.
Yes, any question?
Yeah. Thank you, sir. Ilango, congratulations. I was just wondering, did you find any non-coding RNAs?
No, sir. It is only coding RNAs, sir, because we used microarray experiments, sir.
That doesn't matter. Microarray, although it captures your non-coding RNAs, you have done your you have taken RNA as a seed and converted to cDNA. In principle, you'll get more sensitive non-coding RNAs in microarray than probably you do in RNA-seq.
No, sir. Only mRNAs we got, sir.
Okay, maybe you have captured only that thing, for your library preparation.
Yes, sir. Yes, sir.
Okay. Yeah, but I would probably suggest performing a capture with non-coding RNAs as well. That's where you would essentially get a lot of microRNAs. So that's where they would probably consider that they would be considered as probable biomarkers. Yeah.
Sir, actually, this was my PG work, sir. Now in PhD, I'm working on non-coding RNAs only, sir. As you suggested.
Thank you. Congratulations.
Yes, sir. Thank you, sir.
Okay, then I hope you got given the award. And then thereafter, may I now request the next awardee, which is Ankita Kaushik, to come up and speak on testicular cancer, infertility, etc., etc. Go ahead, Ankita.
Okay, sir. Am I audible?
Of course.
Yeah.
Quite audible.
Oh, okay, so greeting to everyone. First of all, I would like to thank Professor Lohia for recognizing my work and bestowing me this prestigious Professor N.R. Muthil Young Scientist Award. Are my slide visible to all of you?
Yes.
No.
No. Please share your screen first.
Yeah, share the screen, please.
I have shared. Now it is visible.
Yes, now it is.
Yeah.
Thank you.
Go ahead.
Yeah. So I'll be speaking. Yeah. So today I'll be speaking on testicular cancer, infertility, and reduced sperm count due to endocrine disruption. Are reversed by manipulating testicular resident stem cells and their niche. It's not moving. My slides are not moving.
Can you unshare and reshare, Ankita, please? Yeah.
Yes, sir. I'm trying again. It is not moving.
Use keyboard, please.
Sorry, sir.
From keyboard.
I'm doing it again, sir.
Maybe this time you can only share the window, if not the entire screen. Yeah.
Screen.
Share screen.
Now you can see,
yes.
sir.
Yeah. Please do in presentation mode.
Yes.
Start show.
Shall I start?
Okay now.
Shall I start?
Yeah.
So every organ is expected to have two populations of stem cells, the quiescent population and the relatively actively dividing population. So testis harbor two populations of stem cells, very small embryonic-like stem cell in addition to spermatogonial stem cells. So VSCs are quiescent in nature. There is still ambiguity in their presence. So here you can see we simply demonstrated a robust protocol to delineate the presence of two populations of stem cell in testicular in urine testis. So there is a simple protocol. After enzymatic digestion, the suspension was spun at 1000 RPM, that is 250 G, which constitute pellet A. So pellet A, you can see here the cells of variable sizes with abundant. So pellet A.
Now even speaker is muted. Please unmute her.
Yes. Am I audible to all of you?
Now you are.
Oh, God. So I'll start again. So every organ is expected to have two population of stem cells, the quiescent and the relatively quiescent and actively dividing. However, there is still ambiguity for the presence of quiescent population. So if I talk about testis, so testis harbor two population of stem cells. Here we demonstrate simple and robust protocol to delineate the presence of very small embryonic-like stem cell in addition to spermatogonial stem cell. So after enzymatic digestion, the suspension was spun at 1000 RPM, that is 250 G. So we got pellet A. So pellet A constitutes cell of variable sizes with abundant cytoplasm along with large number of sperm. You can see the variety of cells are present in pellet A. And after separation of pellet A, the supernatant was spun at 3000 RPM, that is 1000 G. So we got pellet B. So pellet B constitute darkly stained spherical cells with a higher nuclear cytoplasm ratio. So these may be putative stem cells, and the pellet B further characterized by immunolocalization study. So you can see the cells of smaller sizes in the pellet B expresses OX4A, which is a pluripotent marker, and slightly bigger cell expresses cytoplasmic OX4. You can see the slightly bigger cells. So they may be, they are spermatogonial stem cells, and SCA, you can see the SCA, both the cell expresses SCA antigen, the smaller and the bigger cells, and these cells co-expresses estrogen receptor. You can see here, OX4 and the ER alpha and beta, both the estrogen receptor they expresses. Now, so it is not, my slides are not moving. Are you all able to see my screen?
Please go ahead now.
Sir, it is not moving. I don't know what is happening.
Keyboard button. Use that.
I'm doing it again.
स्लाइड शो काम नहीं करी तो ऐसे यहाँ
I'm doing like this.
Continue with this.
Are you able to see now?
Yes.
So we cannot think stem cell without its niche. So niche provides the paracrine support. So a stem cell is expected to be quiescent in nature. It self-renew itself and giving rise to a tissue-committed progenitor, which in turn clonally expand and further differentiated. So all adult tissue harbors stem cell for lifelong maintenance and repair. And I would like to mention here, mature cell types have finite lifespan and are regularly replaced throughout life. Tissue-specific stem cells routinely differentiate into mature cell types to maintain lifelong homeostasis. Adult stem progenitor reside in a specific microenvironment called niche that protect and regulate their fate and function. Niche provide trophic support to the growing stem cells, and any dysfunction to the stem cell on their niche can cause the pathology state. So declining reproductive health of man due to environmental insult is reported in literature. Global fertility has dropped more than 50%. So it is reported that fetal and perinatal exposure to endocrine disruptors exert adverse effect on spermatogenesis. There is infertility, subfertility, reduced sperm count, along with testicular cancer are occurring, and these defects can be passed down to subsequent generation. It is reported. So very interestingly, a recent meta-analysis study revealed threefold positive correlation between a history of DES exposure in utero and subsequent occurrence of testicular cancer. So as I showed you, that testicular stem cell expresses estrogen receptor, which make them direct target of endocrine disruption. So we wanted to study the effect of endocrine disruption on testicular stem cell biology. And the question came in our mind that can neonatal exposure to endocrine disruption on tissue-resident VSELs can explain testicular pathology reported in adult life. So this is our mouse model where we have administered two endocrine disruptors. One is very mild, that is 17 beta estradiol, and one is potent, that is diethylstilbestrol to the neonates, and the effects were studied at day 100 in adult mouse. So so I have shown that the spermatogenesis affected in both the treatments group. You can see the tubule in the stage 8 are reduced, and it is markedly reduced after DES treatment. So altered spermatogenesis, reduced sperm count, fertility, and cancer-like changes are observed. So these all symptoms, defects combine and called testicular dysgenesis syndrome. Yeah. So this slide shows the effects of endocrine disruption on spermatogenesis. So number of VSELs were enumerated by flow cytometry. These cells have surface phenotype of Lin negative, CD45 negative, and carbon positive. So you can see their number has been increased in both the treatment group, but the DES has marked increase in the VSEL number. And interestingly, you can see here the differentiation into CK positive spermatogonial cells is compromised. You can see the number of CK positive spermatogonial cell. We wanted to study the effect of neonatal endocrine disruption on testicular cell ploidy. For that, we did differential testicular germ PI staining, which separates cells based on testicular ploidy. So you can see, interestingly, the poor cell, the primary myocytes number has been reduced. And along with, you can see here the elongating and elongated spermatids were reduced, which shows the spermatid retention. And this correlate with the reduced sperm count. You can see the reduction in the foreign population, and elongating and elongated spermatids were increased, which showed the spermatid retention. So you can see in this illustration that regularly VSEL give rise to spermatogonial stem cells, and they finally eventually differentiate into sperm. This is the way spermatogenesis is maintained and normal fertility is maintained. So if the VSELs get affected by endocrine disruption, so their block differentiation lead to reduced sperm count, subfertility or infertility, and their excessive self-renewal culminates into testicular cancer. So we have explained in this in our paper that testicular dysgenesis syndrome possibly have a stem cell basis, and I would like to share that our paper got cited on the journal cover page. And I have presented this work in the ISSRF-2022 and received the Best Poster Award. So we wanted to study what all stem cells, the association of stem cells and cancer, or in what stem cell converted into or transformed into cancer stem cells. For that, we did detailed histology, gross histology, and immunolocalization study, and gene expression study. So you can see here, these are the control testes. These are the control testes, and they are totally different from the diethylstilbestrol. You can see here the control testis remains soft, similar sizing, and epididymis. You can see the distinct epididymis. But in the diethylstilbestrol treated group, the enlarged dark red testis and epididymis, which remain tightly adhered to the each other, was observed. You can see the control testis has, this is the, I'm not able to use the pointer, sir. So you can see the in the control testis histology, you can see the all the spermatogenetic cells were observed healthy. You can see the lumen is filled with sperm, whereas in the DES group, the total tissue architecture was lost. And you can see the empty seminiferous tubule. A lot of inflammation is observed, hyperplasia was observed, and a careful viewing of the section, I could observe the tiny spherical cells, which could be putative VSELs. So DES induced atrophy to tumor-like changes, and 65% of mice showed tumor-like changes, which was studied further in depth. I would like to mention here that testicular atrophy also increase the risk of bilateral testicular neoplasia. So these are the immunolocalization study. You can see this is the DES exposed testicular section. So you can see the OCT4A, which is a sensitive and positive staining of OCT4A, which is a sensitive and specific biomarker for testicular tumor. OCT4B, the cytoplasmic OCT4 was also observed. MVH, CKIT, they are the differentiation marker, the germ cell marker, and SOX9, which is a niche marker, was clearly observed in the control group, and all these markers were clearly absent from the DES treated group. So increased self-renewal of OCT4 positive stem cell in a totally independent manner was observed. And this excessive expansion of OCT4 positive cells and their block differentiation promotes cancer initiation. So these are the again staining. You can see the SSEA1. We could observe the positive staining of SSEA1, which is again a pluripotent marker. The SCA1 stem cell antigen was observed. This is PCNA. You can see this is a control group with beautiful staining of PCNA proliferative expression. And you can see in the DES, it is massively expressed. Along with, you can see the Ki67, it is minimally expressed. It is also a proliferative marker. It is minimally expressed in the control group and massively expressed. Higher proliferation rate was observed after DES treatment. And P10, which is expected to be expressed in the germ cell, it is a tumor suppressor. So the atrophy DES stress test has minimal expression, and the loss expression of P10 was observed in the frank tumor. So loss of P10 marks transition of from intratubular germ cell neoplasia, invasive germ cell tumor. And I would like to mention here the ITGCN cells are precursor cell for testicular tumor. So this is the control staining of 5MC. So hypomethylation was observed, you can see here. And interestingly, we could observe the positive staining of CD166, which is supposed to be a cancer stem cell marker. And it's positive, you can see there's a positive staining of CD166. So am I audible to all of you? Am I audible to all of you?
Please go to me.
Yes, yes. So CD166, it is positive expression related to tumor metastasis and progression. Yes. So I'll briefly explain this. This is study done in bone marrow VSL. You must have heard this this in the study Dr. Redzek's talk. The questions of BACL. So these cells have unique genomic imprinting pattern, which result in quiescent stage. So they at their very crucial imprinting gene, that is H19 and IGF2, they have hypomethylation, the erasure of imprinting, which lead to the minimal expression of IGF2, which is a mitogen, and higher expression of H19, which prevent these cells from unleashed proliferation and helping these cells to be quiescent. So these these are the gene expression study in DES, which was compared with control. So you can see the IGF2, which is a mitogen, and it has expected to increase in various cancer types. So it is increased after DES treatment, and H19 is reduced. DLK1, it is also an imprinted gene and a mitogen also. And MEG3, you can see it is a tumor suppressor, it is down-regulated. So for the proper functioning of the cell, DNA methylation machinery should be functioned properly, and we observe the altered DNA methylation machinery. You can see the de novo methylase DNMT were increased, and you can see a significant increase in the DNMT3A, and the maintenance methylase DNMT1 was down-regulated. DMRT1, so loss of DMRT1 was observed, and it has reported that loss of DMRT1 in mice results in more than 90% of incidence of testicular teratomas. P10, you can see it is unaffected. P57, P2, it is a cell cycle regulator, and it was down-regulated, and its down-regulation was found in many of cancer types. And very interestingly, the ER beta was up-regulated, and its up-regulation was also observed in testicular tumor subtypes. And the FSHR3, you can see the FSHR1 and R3 also expressed, but the R3 was manifold increase after DES treatment. Yeah. So if I tabulate my result here, so this table is very interesting because it helps us to understand what initiate cancer, because we did not observe cancer after estradiol treatment. However, we observed testicular dysgenesis syndrome in both the treatment group. So estradiol has mild TDS, where we could observe the severe TDS in DES treatment. BACL number was increased in both the treatment groups, but manifold increase in the after DES treatment. You can see the yellow highlights. So yellow highlight showed how cancer initiated in our model. Sertoli cells was completely lost after DES treatment, but still observed after estradiol treatment. Global hypomethylation was detected, but the 5-MC was positively expressed in estradiol treatment. Tumor suppression was completely lost in DES treatment, but estradiol treatment was not affected and massively proliferated. So what we think that a permissive chromatin modification along with higher proliferation rate coupled with global hypomethylation initiate testicular cancer in our model. We could identify cancer stem cells, that is CD166 positive cells. The extent of changes induced by DES result in tumor-like changes. So our data support a model in which we think the VSCL get transformed into testicular cancer stem cells, and our data DES treatment induced. So our model is an excellent model to study the type 2 testicular germ cell tumor. And according to literature, there is no model for study type 2, animal model for type 2 germ cell tumor. So to summarize, increased self-renewal of stem cell compartment after DES treatment and their block differentiation post stem cell to initiate testicular cancer-like changes in adult life. We could identify cancer stem cell. Loss of SOX9, tumor suppression gene was lost, and global hypomethylation along with increased proliferative rate and CD166 associated with excessive self-renewal of VSCL are crucial for tumor initials. So we showed for the first time how testicular stem cell get affected by endocrine disruption. So the question came in our mind that can we normalize the stem cell function and reverse this disease phenotype? Yes, so for that we have yes.
You are asking time very much.
Yes, sir. Sir, in 1 or 2 minutes. 1 or 2. Hello, am I audible?
Yeah, please summarize. Yes, quickly.
Yes, sir. In 1 minute or 2. So we have used 2 strategies to reverse employ. 2 strategies was employed to reverse these damaging effect of DES. So we have used ZAR, which is a nano formulation of resveratrol. This molecule has gained attention because it has improved the function of several organs. And the another strategy which was used at the transplantation of mesenchymal cells. So I'll directly come to the result. So you can see after ZAR treatment in the estradiol group, we could observe the improved spermatogenesis, and DES post DES and the DES plus ZAR treated group, the spermatogenesis was improved. You can see the BACL number was reduced and their differentiation into c-KIT positive cells were increased. So the normalization of stem cell compartment and pushed spermatogonial cell to transit from c-KIT negative to c-KIT positive cells. So sperm production was improved after ZAR treatment. So resveratrol restores spermatogenesis in both the treatment group. You can see the ZAR treatment, after DES treatment, we could not observe the c-KIT, MVH, P10 and SOX9, but after ZAR 1 month of ZAR treatment, we could clearly see the differentiation marker c-KIT, the MVH, and the tumor suppression was also again restored, and the niche Sertoli cell was observed. You can see the positive staining of SOX9. And you can see the meiotic marker were increased in the ZAR and E2 ZAR and DES ZAR treated group. So ZAR treatment successfully reversed adverse effect of neonatal exposure to endocrine disruption after estradiol and partially after DES treatment. The ZAR successfully reversed epigenetic status of testicular stem cells. Loss of P10 resulting in inhibition of its nuclear tumor suppressor functions such as cell cycle arrest.
Ankita, try to summarize. Go to the last slide now. Everybody is asking you.
Okay.
Leave the results. Leave this part of the study.
Okay, so to conclude, being immortal, BACL have the potential to carry fetal perinatal insults to adult life. Other cells are also affected, but they have limited lifespan. Dysfunction to BACL lead to various pathologies, including testicular cancer, and that so we say that testicular dysgenesis syndrome has a stem cell basis, and resveratrol treatment and MST transplantation can successfully reverse these damaging effects. So resveratrol and MST transplantation simultaneously can be a promising therapy for treating infertility, improving sperm count, and for testicular cancer prevention and their treatment. Thank you, all of you. I would like to thank once again ISSRF and Professor Lohia for encouraging me and recognizing my work and giving me this prestigious award. Thank you. Thank you, everyone.
Now stop sharing.
Good worker and a good present. It's a good work, by the way, but you haven't kept to the time.
Stop
That's
sharing.
the only request. And in future, you also look at that.
Yes,
Go
sir.
ahead. Is there any very important question?
Stop sharing now.
If not, thank you so much, Ankita.
Thank you, sir.
And you will receive your award.
Stop sharing your screen, Ankita.
Yes. Thank you so much.
Go ahead.
Next.
Okay, next is Pushpa Singh. Who's is she here? Yeah, she's here. So go ahead, Pushpa, to present your work, please. Pushpa, where is she? What's happening? Why is Pushpa not coming on the screen?
Hey?
Ankita has not closed.
Ankita hasn't closed. That's bad. Ankita, please close your thing and give the chance to Pushpa now to present her work.
Pushpa, you are muted.
Bolo bhai,
Please unmute.
What's happening?
Pushpa, please unmute yourself first. Then share the screen. Yes, share the screen.
Unmute.
Please unmute first.
Pushpa, you're
Please
muted.
unmute first.
Unmute yourself. You are still not.
Now share the screen.
Unmute अभी भी नहीं कर.
Focus. Share the screen first.
Yeah.
Click the share screen. Share.
Just.
पुष्पा जी क्या हो गया?
Just a second, sir. There is some problem.
We are already running late. So
Just a second, sir.
Share the screen.
Yes. Yeah. Okay.
Yes. Good.
Yeah. Now it's
Yeah.
visible, sir. Okay. Good evening to one
Yeah,
and all.
sure.
Yeah.
It is in the slide
first
mode.
of all, thank you.
Presentation mode. It's not in the presentation mode.
Okay. It is now.
No, go at the bottom and bottom right side, and then
It is
click
not in
on this
presentation mode.
presentation mode. Go further down. Yeah.
Oh, go ahead.
Probably
Go ahead.
It is not.
it's okay to go ahead and.
It is now.
Oh, just screen का size increase कर दो.
Yeah, from 63 to increase the size, it will be okay. What happened? Why?
Yeah, this is good.
It's okay now.
Okay.
Okay. So first of all, thank you ISSRF Society for selecting me for this prestigious award. So today the title of my talk is VSCS and ENSCs partake in endometrial regeneration and their dysregulation initiates various uteropathies in mice. So since I'm working on the uterus, so in brief, uterus is one of the most plastic adult organs with tremendous regenerative capacity. It is comprised of the three layers. The inner one is endometrium, then myometrium, and the outer perimetrium. So all women in their reproductive lifespan undergoes menstrual cycle. The phases include proliferation and growth during follicular phase, then differentiation and secretory or receptive phase comes for implantation to occur. And if implantation does not occur, it is followed by degeneration and breakdown leading to menses. And this menstrual cycle then repeats again every month. Similarly, the mouse endometrium also undergoes cyclic changes, including growth, differentiation, regression, and adsorption phenomena. Although menstrual phase does not occur as in humans, the mouse astral cycle comprised of these four stages, the proestrus and estrus, which is similar to the proliferatory stage, and the metaestrus and diestrus, which is similar to the secretory stage as in humans. So all these cyclic changes in both human and mouse endometrium are thought to be mediated by stem progenitor cells, which play an important role to bring about regeneration and remodeling in the endometrium. But still, there is no consensus on specific markers for stem cells involved in endometrial regeneration, although stem cells were first discovered in 2004. So as listed here, various research groups have reported different types of stem cells in the uterus using different approaches, including epithelial stem progenitors, side populations, mesenchymal stromal cells, etc. However, our group is extensively working on these two of four positive stem cell populations, VSCs, that is very small embryonic-like stem cells, and the tissue-committed ENSCs or endometrial stem progenitor cells. So we are the first group to report these stem cells in the uterus, and till now we have published these 4 articles on uterine VSCs. So in the recent article, Singh et Bhatia 2021, we have discussed the protocol to enrich uterine stem cells, and like this flow cytometry data and qPCR results, we found these VSCs and NSCs varies across estral cycles. These stem cells were maximum at the estrus and metaestrus stage. Also, the pluripotent transcripts, the expression of these transcripts were maximum at the estrus and metaestrus stage, because this is at these stages maximum endometrial remodeling takes place. Then this immunofluorescence data shows that uterine stem cells also expresses the hormonal receptors like ER alpha, ER beta, and PR, which makes them that's why they are sensitive to hormonal triggers or any endocrine insults. Then further study was undertaken to further elucidate that VSCs are the indeed illicit uterine stem cells. So to achieve this, we have designed 3 sets of experiments. I will go through one by one. So coming to my first experiment, to study the regenerative ability of uterine VSCs. So first we have sorted the SSC1 positive stem cells from a BPGFP mice, which has a ubiquitous GFP expression by immunomagnetic isolation protocol. And then approximately 1 million of these sorted stem cells were transplanted in the uterine horns of 6-week-old Swiss mice during the diastase stage, which is maximally regress state. We have also transplanted the GFP positive somatic cell, mature differentiated somatic cells at the same stage in different groups. Then this uterine tissue was collected during the estrus stage for the same cycle, and these transplanted cells were tracked for the GFP expression by immunofluorescence study. So coming to results. So first of all, we have checked the sorted cells for the expression of total OCT4 and OCT4A, and we found these sorted stem cells which expresses pretty good expression of total OCT4 and OCT4A. Thus, we will be able to track VSCLs. And by immunofluorescence study, very interestingly, we found the engraftment of GFP positive cells in the luminal epithelium. As you can see, these are the different fields, and you can see the chimeric pattern of the engraftment shown by the pink arrow. These stem cells were also scattered in the stromal compartment, and some were differentiated into these epithelial cells, as you can see in these figures. So this result shows that the uterine VSCLs are differentiated into these epithelial cells as well. Then further, we also found the engraftment of these GFP positive cells in the glandular epithelium as well. While at places we found a completely newly formed green glands, as you can see here, this completely newly formed green glands, while the endogenous glands were negative for the GFP expression. However, the groups where we have transplanted the mature differentiated somatic cells, we found those cells, those epithelial, those cells were scattered in the stromal and the myometrial compartment, but they didn't participate in endometrial degenerations. So from this experiment, we conclude
There's no voice.
Yeah.
उसी को problem है.
Something is wrong with the internet.
Something's wrong. There's no voice.
Pushpa, what happened? You are mute.
Yeah. This is with the speaker.
but nobody has reported these OCT4 positive stem progenitor cells role in maintaining endocrine.
Start sharing your screen.
You have please share again.
Sorry.
Yeah, you have to.
Please share the
Just
कर दिया नीचे आया था इसके Please share button.
Recorded.
sorry, sir, for the.
Go ahead, please.
Is it visible now, sir?
Yes, go ahead.
Yeah.
Yes, go ahead.
So, yeah.
Now your voice is gone. Something is not right. Are you muted, Pushpa? Can't hear you now.
I think some connectivity problem is there.
Yeah.
Yeah, looks like that. Some system
problem is there because our video is also not running, I think.
Sir, can you go next? Hello?
Should we assume that you have presented? But we could listen to all because of some problems on the presentation side.
What is wrong, Pushpa?
Yeah, please stop sharing.
चलो भाई आगे चलो फिर. Let's go to the next and give Pushpa the award, please.
Please stop sharing. Yeah. Next. This is the award.
Started.
अच्छा
ये वाला यार परेशान हो गए 3 बार तो ये कर दीजिए
नेक्स्ट सर
Sorry,
नेक्स्ट
sir.
awardee सर
All this.
नेक्स्ट awardee
Okay, now Dr. Shilpa Prasad. Is she-
Yes, sir. I'm audible, sir. Good evening, sir.
Oh, very good. Thank God you are not facing the same problem. Go
No,
ahead.
sir.
Start your presentation.
Thank you. Yes, sir. So, first of all, not taking so much of time, I would like to thank the ISSRF Society and the organizing committee for considering my research for this prestigious Dr. Mridura Kamboj Young Scientist Award. I would also like to thank all the dignitaries that are present over here for this awardee talk. I'm glad to share such a novel, my work, which I have started during my PhDs in year 2013 under supervision of respected Professor Chaube sir. We have carried out lots of researches at that time, but here in this within this stipulated time, I would like to present some very important findings that we have done. So not taking so much of time, let's begin the presentation. So in this presentation, I would like to share the important findings that are related to the involvement of cytostatic factor and maturation promoting factor during post-ovulatory aging-induced spontaneous exit in radics. So the title is itself so much big. So coming to the next, that what is this all about, that on which I have started working during 2013. Why this issue took my consent so that I would work over here. So as we all know that for IVF or for the reproduction, egg factor plays a very important role. And in that, to decide the fertilization rate and early embryonic stage, in spite of having so much of work done related to egg quality, still there are various factors that require to be elucidated and to be targeted so that we could maintain the eggs at the good quality during their in vitro processing and to increase their quality, to maintain their quality. So in the egg biology, as it is a germ cell, so of course it is associated with it carries out the meiotic cell cycle. And in the meiotic cell cycle, generally we have two phases, meiosis 1, meiosis 2. So not going to that. Mainly the story of the egg starts with the diplotin stage, because during the fetal life, the eggs are arrested at this stage of meiosis. The diplotin arrested oocytes are there, which are characterized by the presence of germinal vesicle. Okay, and then later, as the time processes, as the puberty occurs, all the systems start. So the eggs resumes from this stage to move to the metaphase 2 arrested stage, and that is the stage at which all the ovulated eggs are present, and they are arrested at metaphase 2 stage. And this is actually the best stage for fertilization. This is the stage when the fertilization should occur. But fertilization has its window period. So if the fertilization doesn't occur within that stipulated window period time, then the eggs will undergo time-related deterioration, and that's what happens in post-ovulatory aging case. The egg resumes the metaphase 2 arrested stage of its own, and that is the spontaneous exit from metaphase 2 stage. So in 2015, we have proposed this, that what are the different cellular and molecular changes that are responsible for the egg to resume from this metaphase 2 stage without getting fertilized and just move towards this spontaneous exit from metaphase 2. Then some studies also suggest that after this stage, eggs get again arrested at metaphase 3 stage. But at that stage, it is none of its importance for the fertilization or for any other IVF purpose. So in this review paper, we have proposed involvement of different signal articles, the signal molecules in this case, starting with the upstream factors like cyclic AMP involvement, ROS, oxidative stress, calcium, reactive oxygen species, how they play a role in modulating different cellular factors, those cellular changes that causes the molecular changes, and then morphologically the change or the resumption is observed as the initiation of extrusion of second polar body like this. So my work was confined to the role of maturation promoting factor and cytostatic factors. The cytostatic factors in this case mainly involves the about APCC, EMI2, MAD2, and B1. And the maturation promoting factors are mainly the subunits of maturation promoting factor, that is cyclin B1 and cyclin dependent kinase 1 or CDK1. How due to the changes in the levels of these factors leads to the MPF destabilization, and this destabilized MPF further leads to deterioration of egg quality, resumption of egg from metaphase to stage, and then also causes the initiation of egg apoptosis process. So coming directly to my work, so this is the process which we utilize to collect the eggs from the immature female rats. We took the immature female rats of Charles Foster strain that were of 22 to 25 days old. They were subjected to superovulation protocol with the injections of PMSG and SCG, and then after the requisite time, actually in my case I took different time intervals to collect the egg, like after 14 hours of SCG injection, then after 17, then after 19 hours, then after 21 hours. So the egg along with the fallopian tubes were collected, and the fallopian tubes were actually responsible for carrying the ovulated eggs. Okay, so this was how the ovulated cumulus oocyte complexes were obtained after the series of dissections and processes that were carrying out under the microscope. So the eggs were collected, then they were denuded by use of hyaluronidase, and then these eggs were then further observed under microscope for morphological changes to study that what are the numbers. Suppose if we have got 25 eggs, then among them after 17, after 19, after 24 hours, 21 hours, what are the status of the eggs? How many eggs have undergone superovulation, or your spontaneous exit from metaphase to arrest? All those percentages were carried on. Similar case work was done like with in vitro studies. Eggs collection process was just same, but the after collection, but here in this case all eggs were collected after 14 hours. Then they were subjected to in vitro aging process, keeping them under requisite media in a requisite CO2 incubator at the respective 37 degrees C for respective time intervals like 1 hour, 2 hour, 3 hour, 5 hour, and 7 hour. And after that, all the eggs were checked about their resumption status, how many percentage have undergone the spontaneous exit, like that. So mainly two protocols were followed, like immunocytochemistry, like the eggs were first they were fixed, and this process was utilized to study the levels of different proteins, and the CDK1 activity was also carried out by using ELISA protocol. So directly coming to the results, this is the status that was observed in the case when the eggs were subjected to in vivo as well as in vitro aging case. So in the similar pattern, this was how the morphological status was shown. This is the absolutely metaphase 2 arrested eggs, the fine eggs. These eggs which have started undergoing spontaneous exit from metaphase 2 arrest, and these are the eggs that where the second polar body, first polar body is deteriorated, and second polar body has also resumed perfectly. But now these are the metaphase 3 arrested eggs, so they are also not fit for any IVF purpose or to support any reproduction. This is showing the DNA status of the eggs in the 3 different stages. So with the time-dependent study in vivo as well as in vitro, there was significant increase in the number of eggs that underwent a spontaneous exit was observed. So as the spontaneous exit also supports that it will initiate the apoptotic purpose. So I checked about the telomerase reverse transcriptase, its function, that its level. What about its level in during the aging purpose? Is during the aging the reverse transcriptase, the telomerase work is getting increased, or it is trying to protect the eggs from apoptosis, or is it initiating the things? As it has been also studied that involvement of this reverse transcriptase, it could be a good marker to study about the oocyte quality. If its level is increasing, then it must be leading to the deterioration of oocyte quality. So in that case also, as well as in vivo and in vitro, the level of TERT was also seen to be increased. In vivo, it increased significantly in different levels, like after 3, 5, and 7 hours. But in vitro, it increased suddenly and be maintained at the same level for the time interval. The tunnel assay was also carried out to observe about the DNA fragmentation. There also it showed that this result also showed that post-ovulatory aging mediates spontaneous exit from metaphase 2 arrest, as well as in vivo case, it has not much induced the DNA fragmentation much. But as in case of in vitro, it was reported that it has induced somehow the DNA fragmentation, or it could further lead to or induce the apoptosis. Then the analysis for the different cytostatic factors like EMI2, APCC, MAT2, V1 were also carried out. EMI2 is actually responsible to protect or to inhibit the APCC involvement, and because APCC is responsible to degrade the cyclin B1, the MPF factor. So if EMI2 level is high, then it is going to inhibit APCC. That means it is going to maintain the metaphase 2 arrest. But during in vitro condition, the EMI2 level was pretty good at 14 hours, where the eggs were arrested at metaphase 2 state. But as the eggs were progressing the cycle and they were getting towards the spontaneous exit, the EMI2 level was decreased. Just opposite, the APCC level was also observed to increase. That means it is going to initiate the further resumption of the cell cycle and leading to the spontaneous exit from metaphase 2 arrest. MAT2 level was observed to be increased first, and then again it level gets decreased after the 5 and 7 hours of in vitro culture. The V1 is responsible to phosphorylate the CDK1, the MPF factor subunit, and it causes the phosphorylation of tyrosine 15, that is responsible for degradation of maturation promoting factor, thus spontaneous exit from metaphase 2 arrest. So if the level of V1 is observed to be increased after a certain time interval of in vitro culture, then it means that it is going to initiate the further degradation of maturation promoting factor, leading to spontaneous exit from metaphase 2 arrest. This was about the cyclin B1, that is a factor for maturation promoting factor subunit, and its level was good when the eggs were arrested at metaphase 2 state. But as the resumption increases, then the level of cyclin B1 was observed to be decreased. Then the similar tests were carried out in the eggs that were aged under in vivo condition for 14, 17, 19, and 21 hours. And the pattern was observed like the EMI2 level here, first it got decreased, but at 21 stage, when the eggs were again arrested, I think at metaphase 3 stage, then the level was observed to increase again. In this case, when the same study was carried out like for APCC, there also there was the changes in the levels of the APCC, the MAT2, cyclin B1 were observed in the similar manner, as the level first increased and then decreased during the post-SCG search. This was about the V1. Here also in V1 case, the level was low, promoting the stabilization of maturation promoting factor. But as the in vivo aging was done till 19 hours, the level of V1 was increased, leading to just supporting the thought that it will again trigger the destabilization of maturation promoting factor, thus causing the degradation of cyclin B1, leading to exit from metaphase 2 arrest. Then study the levels of CDK1, like the different phosphorylation states. Threonine 161 phosphorylation supports for the stabilization of maturation promoting factor, but threonine 14 or tyrosine 15 phosphorylation is responsible to destabilize maturation promoting factor, leading to exit from metaphase 2 arrest. So eggs that were aged under in vitro, there the significant increase in the level of tyrosine 14, tyrosine 15 was observed after 3 hours of in vitro culture, leading just suggesting that it will lead to the destabilization of maturation promoting factor. And the threonine 161 that supports for the stabilization of maturation promoting factor, thus maintenance of metaphase 2 arrest, its level was high when the eggs were arrested in metaphase 2 state after 14 hours of SEG search, but later the significant decrease in the level of threonine 161 phosphorylation was observed, leading to that could result into spontaneous exit from metaphase 2 stage. Then the total threonine CDK1 phosphorylation was also carried out, and there was no significant change in the total phosphorylation was observed. The CDK1 activity was done by using ELISA, and the data suggests that the activity of CDK, that means cyclin-dependent kinase 1, increases in the time-dependent manner, leading to highest at the after 5 hours of in vitro culture. That suggests that the eggs are going to, or they have already moved to the exit from metaphase 2 stage. The same phosphorylation status was also observed in the eggs that were aged under in vivo, and a significant increase in the tyrosine 15 phosphorylation was observed after 19 hours of SEG search. And similarly, in the case of in vitro, the threonine 161 phosphorylation was high after 14 hours SEG search, and then it decreased significantly. Total phosphorylation status was not observed for any change in this condition also, and the CDK1 activity was also increased significantly till 21 hours of SEG search. So with these studies, I would like to conclude that post-ovulatory aging leads to spontaneous exit from metaphase 2 arrest that causes the initiation of extrusion of second polar body. The spontaneous exit from metaphase 2 arrest occurs in a time-dependent manner in vivo as well as under in vitro conditions. Increased TERT expression was observed, but the other like DNA fragmentation was not induced too much during the course of study. The decrease in the level of EMI2 and increase in the level of APCC associates with a spontaneous exit from metaphase 2 arrest during post-ovulatory egg aging. High level of MAT2 expression and decrease in level of V1 associates with maintenance of metaphase 2 arrest during post-ovulatory egg aging. High level of threonine 161 phosphorylated CDK1 as well as cyclin B1 level are required to maintain the metaphase 2 arrest, as both of them are the subunits of maturation promoting factor, and if they are joined together, then factor is stabilized, and thus it is going to enhance the maintenance of metaphase 2 arrest. But as early that if the factors gets destabilized and the subunits get separated, then APCC leads to degradation of cyclin B1, thus initiating the spontaneous exit from metaphase 2 arrest. And in that way, the CDK1 activity is also found to be associated with the spontaneous exit from metaphase 2 arrest. These are some of my research articles that I have published from this piece of work. And finally, I would like to thank my mentor and supervisor, without whose idea this piece of work was not possible. I would not be able to present it over here. I'm thankful to DBT for all the financial grants and fundings. I would also extend my thanks to my lab mates, my dear lab mates, my lab attendants, my dear family members for their continuous support and encouragement. And finally, I would also like to thank Amity University, Jharkhand, to encourage and support me to continue my research work. And thank you so much, ISSRF, for considering this piece of work for the award. Thank you so much, sir.
Welcome, welcome. I think you have taken much more time than was allotted, but you have done a good job. And I would suggest that the award be presented to you. And thank you for. Let's go to the next now. We are already behind time. Go ahead.
Stop sharing.
Next.
Shilpa.
Next is
Please stop sharing.
is Pramod Kumar now. Shilpa is just presented. So now it is Pramod Kumar Jadhav.
Stop sharing.
शिल्पा प्रसाद को दे दो भाई. Good, good. Go ahead. Jadhav ji, Dr. Jadhav, please start. Start the presentation, please. We are behind time.
Am I audible?
You are.
Yeah.
Very much. Go ahead.
Let me take this opportunity to thank ISSRF committee members for recognizing my research work for Professor S.S. Guraya Young Scientist Award 2022. As you all know that the autophagy plays an important role in deciding a cell whether to survive or to die. As you know that the autophagy is beneficial for cell survival, but emerging the evidences are now on the table for the scientists for belief that the excessive autophagy induced by oxidative stress causes cell death. The emerging evidences also supporting the notion that the autophagy is playing an important role in germ cell depletion from mammalian ovary. Although our laboratory have already conducted an extensive research in order to determine the role of apoptosis in germ cell depletion, as well as deteriorating the oocyte quality. This indicated to me find out the role of excessive autophagy in germ cell and oocyte quality within the follicle of mammalian ovary. This interesting research idea we published in highly reputed international journals in 2018, which is almost 9 impact factor. I began my research career with this novel idea, and we reported a series of our papers in various reputed journals. With the given limited time period, today I would like to share my sum of research data for my awardee talk. The follicular atresia mainly occurs via apoptosis. However, growing body of evidence suggests the involvement of autophagy in germ cell depletion via follicular atresia. Follicular cells show simultaneous presence of both autophagic and apoptotic markers in same cell at the same time during all phases of stress cycle in rat. Autophagy acts as a double-edged sword and plays a significant role in both physiological and pathophysiological processes. Autophagy eliminates damaged follicles and remains of the corpus luteum to provide the required space for primordial follicle growth. These primordial follicles from the growing follicle pool to achieve a sustainable level of ovulation. The autophagy marker genes have been reported in granulosa, theca, and oocytes during follicular development in the ovary. Ovarian knockout of Beclin-1, a core component of PI3K complex, supports autophagosome nucleation, results in a substantial loss of oocytes at postnatal day 1. A rapamycin treatment increased the expression of LC3B and Beclin-1 and promote primordial follicle assembly as well as oocyte survival in urine ovary. The basal level of autophagy is beneficial for development of germ cells and pro-survival adaptive response to heat shock to boy and cumulus oocyte complexes. The excessive autophagy cell death under unfavorable conditions such as hypoxia or oxidative stress results in the loss of bidirectional talk between granulosa cell and oocyte, which may affect the oocyte quality and may cause the substantial POI and PCOS in later life. These studies highlight the importance of autophagy in the maintenance of oocyte quality, providing a basis for further investigation of dysfunctional autophagy in the deterioration of oocyte quality and development of therapeutic strategies to aid in the treatment and prevent of age-related infertility. In 2018, I have published an article, Germ Cell Depletion from Mammalian Ovary, Possible Involvement of Apoptosis and Autophagy in Journal of Biomedical Sciences. In this article, I have proposed a molecular pathway which may involve in the oocyte autophagy. To investigate the aging induces autophagy rat follicular oocytes, my research areas working on the two steps: expression of autophagic marker genes in experimental age group of rats by immunohistochemistry as well as by Western blot analysis, and second one is expression of ROS, BAX, BCL2, P53 and cytochrome C level in experimental age group of rats by immunocytochemistry. Chemicals and preparation of culture medium. All chemicals were purchased from Sigma Chemicals, and experimental animals and oocyte quality.
Show your results. You have 15
Yeah, sir.
minutes.
This is the our sir. This is the our protocol which I have followed in my research. Results. In these slides, upper panel shows the our experimental mother rats. This is the young one as 1 month old rat, and this is the adult treated as a adult. It is 6 month old, and this one is 24 months old rat treated as a aged one, and their respective ovary. So expression of LAMP1. So in this slide, upper panel shows the light microscope image of follicle, and in lower panel you see the LAMP1 expression in the follicle of young adult and aged one. Expression of LC3. In these slides, upper panel figure showing the expression of LC3 in different age group of rats. A1, B1, and C1 shows the light microscope of image, and there A2, B2, and C2 shows the expression of LC3 in our experimental age group of rats. And expression of LAMP1 LC3 by Western blot analysis. This is the Western blot profiling, and you see the LAMP1 expression in young one is very low, and LAMP1 expression in 24 months is very high. LAMP1 LC3 is down regulated in young rat and up regulated in the adult one. This is the ROS expression. You see the upper panel. This is upper panel figure showing the expression of ROS in different age group of rats. In lower panel, CTCF analysis confirms the gradual increase of ROS level from young to adult and then to the aged. And in these slides, upper panel figure shows the expression of BAX in different age group of rats, and the lower panel shows the CTCF analysis confirms the gradual increase of BAX level from young to adult and then to aged one. And in these slides, upper panel figure expression shows the BCL2 expression in our experimental group of rats, and lower panel shows the CTCF analysis confirms the significant decrease of BCL2 level from young to adult and from then to adult to the aged one. In these slides, upper panel figure shows the expression of P53 in our experimental group, like 1 month, 6 month, or 24 months old rat, and lower panel shows the significant decrease of P53 levels. In 1 month older, they higher P53 level, and then 6 month low, and 24 month is a higher level of P53 expression. And in this slide, upper panel shows the cytochrome C expression in our experimental age group of rats, and lower panel shows the CTCF analysis confirm the significant decrease of cytochrome C level from young to adult and then to the aged one. And conclusion, the increased expression of LAMP1 and LC3 with increase in age suggests the oocyte undergo autophagic cell death process as age increases. Total ROS level is increased with increase in age. 1 month old rat has lowest ROS level, whereas 24 months old rat has highest ROS level. Oocyte apoptosis is increased with increase in age as BAX level is increased with increase in age of the rat. BCL2 level is decreased with increase in age. Cytochrome C level is decreased with increase in age. 1 month old rat oocyte shows highest level, whereas 24 months old shows lowest cytochrome C level. P53 level is highest in 1 month old rat and lowest in 6 month old rat. And summary of my research work is the expected outcome of this study will be useful to understand the age-related decline in female fertility and the etiology of oxidative stress within the ovarian environment and the oocyte itself. Data generated through this study will raise the prospect of harnessing autophagy modulating and autophagy activators as therapeutic interventions for mitigating oxidative damage within the oocyte. This study will be useful to improve our understanding of how autophagy pathways integrate into normal oocyte physiology as well as their response to pathological levels of oxidative stress in order to maintain the good number and quality of oocytes that otherwise directly affects fertility potential and leads to ovarian diseases. This is the reference. Acknowledgement. I am extremely and highly obliged to my mentor, Professor Sahil Kumar Chaube sir. Without his efforts, it was not possible for me to be here. I am really thankful to my lab colleagues Anumegha, Alka, and Anil for their consistent moral and scientific support. I am grateful to the CSIR New Delhi for JRF and SRF. I am also very much thankful to my parents and family members who have kept all patience and allowed me to work in Corona pandemic. It is very difficult to me to ignore our lab assistant for consistent support, and of course our experimental rats who were sacrificed for generating such a novel data presented before you. Thanks a lot for your patience hearing us. Thank you.
Again, I don't know. Is there any burning question? If not, thank you so much. And may you be awarded the deserved award, so to say, prize. Maybe now go to the next, please. The next.
Please stop sharing.
Huh? Sorry?
Please stop sharing. Yes.
Gurayas.
Yes, sir.
Okay.
Last one.
The last is take Gangwar. Sorry? Huh? What is it? Maybe now invite take
A very good evening to Chairman Sir, Co-Chairman Sir, and all the dignitaries present here. I am very much thankful to team ISSRF and the jury who selected me for the award, Professor S.S. Goraya Young Scientist Award. Further, I want to congratulate Professor M.L. Madan Sir for receiving the prestigious Padam Shri Award, and he is the source of continuous inspiration for all of us. Thank you very much. The award topic is isolation, identification, and characterization of Staphylococcus species isolates from bug semen. And these are my team members. Next.
What is happening to these slides? They are not moving.
Yes, they are not moving.
Awful.
Sir, I'm trying.
Put it on the slideshow.
Yes, sir. Regarding the introduction, as we all know, that is Staphylococcus aureus is responsible for the mastitis in animals and causes the great financial losses to dairy animals, as it takes long time and money to cure it. And it is also responsible for...
Now your slides are not moving, please. Can you please unshare and reshare, please? I'm sorry for this.
Slides are moving,
No,
moving.
Slides are not moving.
Okay, okay, sir.
So on the first slide.
Okay, sir.
Instead of full screen, maybe you can share only the slides and yeah.
They're moving or not moving? So slides are moving or not?
Not yet. It is only first slides.
Okay, sir.
Please use keyboard key.
Yes, sir. I'm using keyboard, but still.
You might want to unshare and then share again. Probably that may resolve sometimes.
Okay, sir.
Yeah, it is moving now.
Now it is moving.
It's in the
Now
presentation.
moving, sir?
Yes.
Yes,
Yeah.
sir.
Put it in
As we
the
all-
presentation mode.
It is on slideshow mode or
No, not yet.
not yet?
Put it in, come down.
Okay,
Yes,
okay.
yeah.
Sir,
Click
now
it.
it is moving or not?
Click it.
Put it in the
I'm clicking.
presentation mode.
I'm clicking, sir. It is moving or not?
It's on second slide. That
This
is
is second
introduction.
slide.
Yeah.
Now this is third
It's not
slide.
moving.
No, third slide.
no.
Here. No.
Materials and
No. We are not able to see the third slide.
okay, sir. Again, I'm trying.
Some problem is there.
Exit and rejoin.
You might want to use your keyboard actually to advance slides rather than mouse. That works sometimes.
I'm using keyboard only. So now it is moving.
This is the second slide only.
Introduction
No.
slide.
Put the next
Click
slide.
this one. Click this one.
Yes.
Yeah.
Yes. It's moving now.
Yeah.
Go back.
Okay,
Yeah.
sir.
Yeah. Now you start, I think.
Okay, okay. As we all know, Staphylococcus is responsible for mastitis in animal, and it causes great financial losses to the dairy industry. And to cure the mastitis, it took long time and money to cure it. So we can say that Staphylococcus is how much dangerous to the animals as well as humans. And pathogens in one way or other may infect inseminated females or contributed to a rapid deterioration of the sperm quality. And regarding to this introduction, we started a study with the materials method. We used total 48 semen ejaculates. Out of them, 16 were from Jamnapari and 16 were from Jakrana and 16 from Barbary bugs. For this, we did the microbiological evaluation. Fresh semen samples were inoculated into the nutrient broth and incubated at 37 degrees centigrade overnight. The broth culture was inoculated into the nutrient agar and mannitol salt agar. For identification, we did the gram staining. We did the catalase test and coagulase test for further identification of the species. As Dr. Elango has already told that the male part or semen is most important or crucial for the success of the artificial insemination in animal. So we should take care of these microorganisms contaminating the semen. Regarding the isolation and identification of Staphylococcus, we did the gram staining. These are the violet color bunches seen during the gram staining, and this is the yellow color colonies surrounded by the yellow zones suggestive of mannitol fermentation by the Staphylococcus organism. This is the catalase test, which is performed for identification of Staphylococcus. For this, we mixed a colony in 3% hydrogen peroxide, showing the effervescence, which is the positive reaction, and no effervescence is the negative reaction. Further, we did the coagulase test for differentiating the Staphylococcus aureus from other Staphylococcus like Staphylococcus chromogens and Staphylococcus epidermidis or Staphylococcus saprophyticus. For this, we use rabbit plasma and we mixed the culture colony in this, and large visible clumps are seen. This is the positive coagulase test shown by the Staphylococcus aureus. Next, we did the molecular characterization of Staphylococcus species isolated from bug semen. For this, we use the following genes for identification of these species. We isolated the S. aureus, Staphylococcus aureus in 44% of the samples, and S. chromogens in 4% of the samples, and S. hemolyticus, curei, simulans, epidermidis were identified in the different ratio out of the 25 semen samples. Next, this is the pictorial depiction of the Staphylococcus speciation through the conventional multiplex PCR. Through this PCR, we identified the different species in the bug semen. Regarding the results, we found 52.08% samples were positive for the Staphylococcus. Out of 48 ejaculates, 25 ejaculates are positive for Staphylococcus, and out of 25 semen ejaculates, the species identified were Staphylococcus aureus, S. chromogens, S. hemolyticus, S. curei, S. simulans, and S. epidermidis. Next, regarding the discussion, we already said that Staphylococcus is not a simple organism. It is having a antimicrobial resistance too. Latestly, we have published a paper in which we found that the staph is resistant to methicillin as well as vancomycin, the latest antimicrobials which we are using for the which we are using in the diluters for preventing the microbial growth. Conclusion, this species identification could help in decipher important information about the selection of the antibiotics in semen diluter, and in turn could help in assess the public health risk due to antimicrobial resistant isolates and their influence on personnel assisting the semen collection and processing for AI. This is our latest publication in which we found a great antimicrobial resistance Staphylococcus species isolated from bug semen. The paper was published in Archives of Microbiology. These are few other publications related to the microbes in bug semen. And thank you regarding the acknowledgement. I am very much thankful to Professor S.S. Goraya for bestowing me this award. Dr. M.S. Chauhan, our previous director, who always encouraged us to do hard work. Our team members at ICRCIRG, staff of Male Reproduction Laboratory at my office, my family members who spare me on this Sunday. And thank you for the patience hearing. And again, thank you for the team ISSRF, Professor N.K. Lohia sir, Professor Dr. R.A. Sharma sir, Ansari sir, Barkha ma'am. Thank you so much for selecting me for this award. Thank you.
Thank you.
Please stop sharing.
Dr. Kangawar.
Thank you so much. Congratulations.
Hope the award is given to you, allotted to you, and thank you very much for presentation. Well, that comes to the end of this session, and the valedictory function now will start. I leave the ball now to Professor Professor Lohia would be the one who would be in charge of this session. अभी मेरे वो स्लाइड शो कैसे चलाओ?
Thank you, everyone. Thank you, everyone. It has been a great day. Now, I thank all the keynote speakers, all the oral presenters, invited speakers, all the participants, all the young awardees to make this day a very successful one. Now we have reached to the end part of our session. Now it is valedictory function, for which we have two eminent personalities with us. Our chief guest, Professor G.P. Talwar, who has been with us for the past session. And he has been chairing this session wonderfully. We welcome you, sir. And now we have our guest of honor, Professor Sudhir Bhandari, who is Vice Chancellor, RUHS, and Principal and Controller, SMS Medical College Hospital, Jaipur. We welcome you, sir. We are really grateful for your presence. And now I would ask President ISSRF, Professor Lohia, sir, to do the presidential address. Over to you, sir. Thank you.
Dr. Talwar, namaskar. Namaskar ji.
बहुत अच्छा. Oh, nice.
Very good afternoon to all. And how happy we are to have very distinguished, very esteemed, very honored chief guest of the function, Professor G.P. Talwar. Professor Talwar,
I'm right here and I'm honored.
Let me express the feelings on behalf of all of us. And Professor Talwar celebrated 95th birthday recently on 2nd October 2021. And we feel that a great source of inspiration, great source of motivation to all of us. And we feel that the ISSRF ISSRF is honored.
Camera se
Sure.
Sure, sir.
Honored to announce that this ISSRF 2022 is dedicated to Professor Talwar.
How nice. How nice.
In honor of him. And had this been the physical, Professor Bhandari wants to say something?
No.
No. Okay, we are coming to that as well. So we would say that it's a great conference for last 3 days, starting from 10 o'clock till 7 p.m. all around all hours, with very packed scientific program, which details Dr. Ansari will provide. But I am just very much contented to see that a great participation of great scientists, young scientists, and representing almost all premier universities, institutions, veterinary, clinical, basic scientists from all over the country and abroad. I have special feelings for our colleagues who joined from abroad, and you all will appreciate that because of the time difference, some of the presentations were made early morning at 5 o'clock for them, or late in the night after 11 p.m. or so. They cooperated to the extent that sometimes when we requested them to give us the recorded presentation so that they may not be put to a lot of inconvenience, they gladly said, no, it is an opportunity for us so that we would give it a live presentation. So I would take this opportunity to say that a big thank you to one and all for making this 2022 event of the ISSRF a grand success. We have another very distinguished scientists, clinicians amongst us in the name of Professor Dr. Sudhir Bhandari. Professor Sudhir Bhandari has given a new heights to the medical support to the state of Rajasthan. And particularly, every one of us who is residing in any part of the state of Rajasthan feels with a great gratitude to Professor Bhandari, specifically during the period of COVID-19 pandemic, be it a phase 1, be it a phase 2, and now we are passing through phase 3, or we may call it omics pandemic. And his management, his looking after every aspect of the pandemic has been greatly appreciated, not only by the state of Rajasthan, not only by the government of Rajasthan, but government of India as a whole. And many of initiatives taken by Professor Sudhir Bhandari and team in SMS Medical College, this has been made as exemplary to follow the other states of the country. And I have great pleasure in welcoming Professor Bhandari to this event. And we feel proud, Professor Bhandari, to have you with us and to greatly compliment you for your commendable services and contribution in the area of health to the state of Rajasthan. With this, I would say that when the presence of a large number of senior scientists we can see, and presence of them all through the 3 days, it has been a source of great motivation to all of us. We know that there have been some occasions where some technical problems were there, which were unavoidable. But otherwise, I would say that all of you will agree with me that the quality of science, quality of presentations, quality of participation, everything has been commendable. We kept to schedule. We today also you could see that we were just 15 minutes behind the schedule. So started dot at 10 o'clock, 10 a.m. and completing as per schedule. All our scientific program has been worked out very well. And since our very distinguished guests have joined, I would like to say a few words about what has been done in the past 3 days. Every aspect of reproductive health care has been covered. Talk about the different themes, different aspects of reproductive health care has been covered. And we had very special lectures in the form of orations, in the form of keynote speakers, in the form of invited talks, oral presentations, and young scientist awards. And all together made a memorable 3 days event of the society. And in addition, I would like to share with Professor Talwar, maybe we could see him second day, probably he could log in, and Professor Bhandari would like to share with him also the ISSRF society with which Professor Bhandari has been associated in the past for quite some time. And whenever he comes, we feel that it is a blessing on his part to the all participants. And we would like to share that whatever in the reproductive health research, our society is very actively involved. Ensure that there would be in the form of newsletter, 2 newsletters in a year. They are very regularly published, one released in September, one released in February, without any fail, for last many years. And that is the credibility of the society, that with this, we pass on, disseminate information relating to different important aspects of reproductive health. And I would send you details where you would appreciate that as and when we feel, society feels that what is the current reproductive health priorities of the country. Based on that, we decide the theme of the newsletter. And I would like to compliment all the editors who very richly contributed in the success, and all the contributors who made contributions to different newsletters. I would also like to share with all of you, and particularly with Professor Bhandari, because I know that Professor Talwar has been part of this, that the midterm activities of the society also a very big contribution to the society in terms of the awareness about reproductive health issues. And we hold these awareness programs in the form of midterm activities in different parts of the country. And they have been very well taken up. And we see that young minds we participate. At times they are hesitant sharing some information with their parents, with their teachers, and they become so open sharing information during the course of presentations made by senior scientists in the form of basic understanding. They can talk very high-fi, but they talk such things which can go to the minds of the young people in the form of awareness. And just one example I would like to give, that when the presentations were going on in Pilani, the Birla Institute, the Birla Balika Vidyapeeth, you would be very pleased to know that a student stood up and said that when Dr. Suri was giving a presentation on cancer awareness, she said that I have some question, and that question was related to her own cancer problem. And we were very surprised to say, she said, I could not share this information of my health either to my parents, to my teacher, and did not visit to a doctor, but I could have the courage to come out in the atmosphere where people were so friendly, and she shared this information. That made us to realize that how the awareness programs are helping to young minds to get themselves aware about different reproductive health issues. So with this brief, I have a great pleasure to say that we are very much contented with these 3 days program. And I would now request Professor Ansari to give a brief about the report of the proceedings And then thereafter, in continuation, we will have because many of our young scholars might be waiting for the outcome of the posters they have given and the results of the poster awards. We will do it subsequently. I'll request Professor Ansari to give a brief report of the proceedings of the conference. Thank you so much.
Thank you, sir. Honorable Professor Talwar, sir, Professor Bhandari, guest of honor, Professor Doia, Dr. R.S. Sharma, Secretary of the ISSRF, and distinguished delegates, participants, awardees, orators, etc. An international conference on reproductive healthcare and 32nd annual meeting of the Indian Society for the Study of Reproduction and Fertility has been organized by the ISSRF at the Center for Advanced Studies, Department of Zoology, University of Rajasthan, Jaipur during Feb 11 to 13, 2022, covering many aspects. First, the female reproductive health, PCOS, endocrinology, reproductive tract cancers, male reproduction, omics in reproductive health, fetal reproductive health therapeutics, fertility preservation and ART, and translational technologies from the animal species for reproductive health. The conference was inaugurated by Dr. V.M. Katoj, former Secretary, Department of Health Research, Minister of Health and Family Welfare, and Director General Indian Council of Medical Research, New Delhi. And Dr. V.P. Kamboj presided over the function. Padam Shri Professor M.L. Madan, guest of honor of the conference. Professor N.K. Lohiya, President ISSRF and Chairperson ISSRF-2022, delivered welcome address, and myself, convener of the conference, proposed vote of thanks. A total of, in the conference, 365 delegates were participated from different, more than 55 organizations from our country, and more than 10 delegates from abroad actively participated in the conference. In all, during 3 days deliberations, there were 6 orations, 3 keynote speakers, 29 invited talks, 10 young scientist awardees, 18 oral presentations, and 19 poster presentations were there. But for some presentations were not presented during the conference. For the day 1, on the 11th Feb, there were total 4 sessions were held, and 3 oration awardees were there. First was Founder President Dr. T. Anand Kumar Memorial Oration. It was delivered by Professor J.V. Sharma on role of female genital tuberculosis in female infertility, Indian perspective. The second oration was delivered by Dr. Taruna Madan Gupta from the NIRHC at Mumbai of the Dr. Mridula Kamboj Memorial Oration. The third oration was Professor L.S. Ramaswamy Memorial Oration. It was delivered by Professor Arun Chogle from SMS Medical College and Hospital. On the day 2nd, on 12th of Feb, there were total 4 sessions in which keynote speakers and different invited talks and oral presentations were there, and 1 oration award, namely Professor N.R. Mudgal Memorial Oration. It was delivered by Dawul Gajbiye of the NIRRCH, Mumbai. On day 13, today, there were total 2 sessions containing keynote speakers, invited talks, and oral presentations, and there were 2 oration awards. First was Professor S.S. Guraya Memorial Award, delivered by Professor M.S. Chauhan, Director NDRI Karnal, and second was Professor G.P. Talwar Gold Medal Oration Award, delivered by Professor Pradeep Kumar G from RGCB Anandpur. And there were 10 young scientists awardees of different names, and also the best poster award. Just we are announcing it. Thanks so much.
Thank you, Professor Ansari. And this is the time for us to announce the best poster presentation awards. and it is on behalf of the chief guest, Professor Talwar, and the guest of honor, Professor Bhandari. I'm announcing the best poster presentation awardees. Just a brief before this is done, that in all 91 posters were presented, and the posters were then sent out to various 3 teams, and in each team 2 to 3 experts were there, and this care was taken that those experts were the mostly the participation was not there from their institution, and they were given the option to award out of 50 based on the importance of the work, translational value of the work, and the overall results and the overall presentation of the poster. So different parameters were taken into consideration, and when they submitted the award list, it was all compiled, and care was taken to ensure that from one institution, though there were several such institutions where more than 1, 2, 3, 4, 5 posters were there, and it was very difficult that how to decide which poster is the best, and also a challenge that not so many poster awards should go to one institution. So with this, I am announcing, and there is no sequence or no what you say, first, second, third type of thing. It is the practice of the society that to try to identify as many possible based on their quality of work, try to see that maximum institutions and universities and hospitals and are covered, so that young scientists are encouraged. With that, I am just announcing first candidate, a scholar who got the best poster presentation award is poster number 11. And I'll request Dr. Barkar to simultaneously present the poster. So this is the poster number 11, and you can see the details of the group, but it is being presented by Arya D, and it is from NIRRCH, National Institute for Research in Child Health, Mumbai. So congratulations to Arya D for getting this best poster presentation award. Next is poster number 14, and this goes to Priyanka Sanghvi, and she is from Gujarat University, Ahmedabad. And you can see the other colleague joined with this. And I'm not going to read out the title because to save the time, but you can see title as well as the details on poster. And we will be providing the complete PDF of the what you call abstract book, which has all the posters and all the abstracts and everything for in due course of time. Then next comes the poster number 15, and this is Sirsa Mondal, and Sirsa Mondal is Vishwa Bharati Central University from Santiniketan. And you would see that the title, if you go through, you will find that they have all worked on different aspects of reproductive health research. Then the next is P18. P18 poster is Sriparna Pal, is from Banaras Hindu University, Varanasi. So congratulations to Sriparna Pal. The next is poster 21. This is the Seni Pallavi, and she is from Central Drug Research Institution, Lucknow. So congratulations, Pallavi, for being awarded Best Poster award. Then next is poster 24. And this is Jaya from National Research Center on Pig, Guwahati, Assam. Congratulations, Jaya, for this honor. Next is P26. P26 is Krutika Patil, and she is again from NIRRCH, Mumbai. And again, congratulations to Krutika Patil for this honor. Then next is P44. Poster 44 is Naresh Patnaik. And is Patnaik? Naresh Patnaik is from BITS Pilani, Hyderabad campus, Hyderabad. And congratulations to Patnaik for this honor. Next is poster 52 is Jitendra Kumar Bhardwaj, and is from Kurukshetra University, Kurukshetra. So congratulations, Jitendra, for this honor. Next is poster 56 is Mr. Sonu from University of Rajasthan, Jaipur. Congratulations, Sonu, for this honor. Next is poster 63 is Prachi Chauhan, is NIREH, National Institute for Research in Environmental Health, Bhopal. Prachi Chauhan, congratulations for this honor. Next is Rosni Kumari, and she is again from NIREH, Bhopal. Congratulations, Rosni, for this honor. Next is poster 75 and is Devri RK and NDRI Karnal. So Devri, again, big congratulations for this honor. And next is poster 82 and is Jamil Aisa, and is from University of Hyderabad, Hyderabad. So Jamil, congratulations for this honor. And last is poster 90, Anjali Priyadarshini from University of Delhi, New Delhi. So congratulations, Anjali, for this honor. So in all, we have 15 awardees who have been recognized for Best Poster Presentation Awards, and the society will ensure that the award certificates, which will be prepared in due course and at the earliest possible, will be mailed to all the awardees with compliments, congratulations for this big honor. We hope that this will help them in their future career and will serve as the source of motivation to continue doing good work. I would add that those who could not be included in the list of awards, it is no reflection that they are not doing good work. The posters were of very good quality, but it was difficult for the even evaluators, experts, but they did convey that we are finding it difficult to make out of the who is better, who is less better. But anyway, this assessment has to be done. So we compliment and congratulate all the awardees, and also wish all the best for remaining people who could not make it to continue making best effort and see that they compete next time. Thank you so much. Now you can move, right?
Okay, so
Thank you. Thank you, Lohia sir, for giving the awards to the poster presenters. Now I would request our guest of honor, Dr. Sudhir Bhandari, to say a few words. Welcome, sir.
Good evening, most honorable Professor Talwar, Dr. N.K. Lohia, the convener, Dr. A.S. Ansari, Dr. Barka Khildani. At the onset, I extend my heartfelt gratitude to Professor N.K. Lohia for inviting me, and I feel humbled and honored to be part of such an illustrious conference. Dr. N.K. Lohia deserves all the compliments and praises for his dedication, and probably I have a feeling that he is going to be another Dr. Talwar, and my all compliments to Dr. Lohia. And it has been a wonderful to see the menu of your conference was so enlightening. The content was so rich that it is a great effort put in by you, which is very visible. Over the last several years, thanks to the improvement in the progress of cancer patients, increasing attention has been given to the survivors' fertility issue. International guidelines on this topic have been recently updated and published. The fertility and reproductive health, which is the theme of your conference, experts have found that problems related to ovaries are the leading cause of infertility among women. Ovary-related factors were responsible for 40% of the women patients. While the growing population is a cause of concern, increasing level of fertility is the affecting paternity and maternity outcomes. Psychological stress, as well as the industrial and environmental pollution, is taking a toll on male fertility. One of the most fragile systems in the human body is the reproductive system. A safe, controlled, and nurtured approach toward it will make care of overall health for a longer time. Female infertility impacts the quality of the life, well-being of the affected individuals and the couples. Female reproductive diseases such as primary ovarian insufficiency, polycystic ovarian syndrome, endometriosis, fallopian tube obstruction, and Asherman syndrome can induce infertility and many more. In recent years, translational medicine has developed rapidly, and clinical researchers are focusing on the treatment of female infertility using novel approaches. Owing to the advantage of convenient samples, abundant sources, and avoidable ethical issues, mesenchymal stem cell can be applied widely in the clinical practice to take care of these issues. Recent advances using 4 types of mesenchymal stem cells, the bone marrow stromal cells, adipose-derived stem cells, menstrual stem cells, and the umbilical cord mesenchymal stem cells, each of these have been used for the treatment of ovarian and uterine diseases and provide new approaches for the treatment of female infertility. As a part of education and informed consent before cancer therapy, health care providers, including medical personnels, oncologists, radiation expert, the gynecologists, surgeons, urologists, hematologists, pediatric oncologists should address the possibility of infertility with the patient treated during their reproductive years. It is very important to apprise the patients of the outcome of the chemotherapy when they treat such patients or the parents of small children, and to be prepared to discuss fertility preservation options and to refer all potential patients to appropriate reproductive spaces. I think it is an integral part of responsibility of all the treating doctors to address beforehand the infertility issue which can arise as a part of chemo or radiotherapeutic interventions. Although the patients may be focused initially on their cancer diagnosis, the update panel encourages providers to advise patients regarding potential threat to fertility as well as the possible in the treatment process so as to allow for widest array of options for fertility preservation. The discussion should be documented. Sperm and embryo cryopreservation as well as oocyte cryopreservations are considered standard practice and are widely available, and probably they should go hand in hand with chemotherapeutic and cancer treatment protocols. Other fertility preservation methods should be considered. Investigational and other investigations performed by providers with necessary expertise. Current evidence suggests that discussions about the fertility and fertility preservation are of great importance to the patient with cancer pre and during treatment management. It will be difficult for physicians to know how important fertility preservation is to their patient unless they ask, because many bring up the topic. Many patients are shy, many patients are vocal. Some these days with the internet knowledge ask pre-hand with the doctors. The failure of patient to mention infertility concern or interest in fertility preservation can result from a variety of factors. They may be overwhelmed by and focused exclusively on cancer diagnosis. They may be unaware that potential fertility loss may occur, or they may be concerned that pursuing fertility preservation will delay their treatment, leading to increased morbidity and mortality. That fear could also inhibit them from being frank with the treating oncologist or radiotherapist. 29% of women with the breast cancer reported that infertility concern influenced their treatment decision. It means 30% women in the data did not want to talk about their fertility issue because they wanted the best and the early treatment. Healthcare providers can use the following points for a discussion of infertility and fertility preservation with a patient or their guardians. Some cancer treatment can cause infertility or early menopause. What are the options left with us? There are many available fertility preservation and parenthood after cancer options which we may consider. For men, the most common and successful option is the sperm banking. Other experimental options exist if sperm banking is not a viable option for patients. For women, the most established options are embryo and egg freezing. Other experimental options exist, and if these are not available, we may have other few methods available with us. Time is of the essence in fertility preservation. Treatments need to be completed before they start chemotherapy or irradiation. In many cases, cancer surgery or treatment can be more likely than the cancer itself to interfere with some parts of the reproductive process. And one need to be very careful about sensitizing patient all about the outcome associated with their infertility. Different types of surgeries and treatment can have different effects. The risk of infertility varies depending upon patient's age and the stage of development. For the example, before and after puberty, the type and extent of surgery and the type treatment given, like radiation or chemotherapy, hormone therapy, targeted therapy, immunotherapy, stem cell transplant, etc. And also the doses of the chemotherapy which is given to the patient. There are things that cause a female to have a higher risk for infertility and others that might not affect the fertility at all. And there are many examples. Younger you are, more eggs you have usually, and probably you may retain the fertility. This gives you a higher chance to keep more fertility in spite of damage from treatment. Puberty and menopause makes it different. Having a bone marrow or a stem cell transplant usually involve receiving high dose of chemo and sometimes radiation to whole body before procedure. And hence, majority of the children, adolescent, and all age group people need to be sensitized, need to be made aware of it, and the treating doctor need to be very careful about this fertility aspect. Timely and complete information on the impact of cancer treatment on fertility and fertility preservation option should be presented to all the patients when a cancer treatment is planned, which is a very important aspect of it. Now, many surveys of cancer survival have found that these patients are at increased risk of emotional distress if they become infertile. So this is a psychosocial impact of the various chemotherapeutic modalities as a result of their treatment. And all the doctors need to be very sensitive about it, and they need to make people apprise of the outcome. The possibility of using fertility preservation methods should be presented to all the patients, even if they are ambivalent at the time. Many reports are there that fertility preservation may be offered in a safe context without any risk of delaying initiation of cancer treatment. This is another important aspect. It is an algebraic sum that we need to be careful about gains and the losses. In this context, prompt referral may increase the cancer patient's chances of receiving appropriate counseling and improved success of fertility preservation, which is very important. Another important aspect is that interdisciplinary collaboration between oncologists and endocrinologists, physicians, gynecologists is very important to bring about the best results. And we must follow the practices for reproductive health, counseling and education to children on sexuality and sexual health at the right age. Adolescent and youth health is also very important as a part of this endeavor. Treatment of infertility and other functions following environmental factors, iatrogenic following chemo and radiotherapy, we need to be very careful about it. So overall, this is one of the most burning topic. I think all the speakers did a great job. The topics were very interesting, and probably we require a comprehensive approach with the involvement of endocrinologists, the reproductive specialists, the chemotherapeutics, the radiation expert to address the issues of infertility, also find out more chances of the stem cell involvement, how we can do, and we need to address all these issues to prevent even the psychosocial trauma which can happen without patient's knowledge. I hope this conference has been a very interactive. The topics itself are fully updatation of latest what is happening in the field of reproductive health. And I compliment Dr. Lohia for making such a wonderful program. And I extend my heartfelt gratitude and thanks that I have been invited. And I really feel more enlightened listening to few of the speakers in between whenever I got time. Thank you very much, sir. And I'm humbled and honored once again to be a part of your conference.
We really thank our guest of honor, Professor Sudhir Bhandari, for giving an insight on the reproductive healthcare. We really thank you, sir, for your gracious presence and for your time. Now, I would like to invite our chief guest, Professor G.P. Talwar, to say a few words. Please, sir, over to you.
Well, is my voice reaching you? Is my voice reaching?
Yes.
No, your voice is fine.
Okay.
Fine, Daksa.
First of all, let me say and sort of in a way reiterate what Professor Bhandari has just now said. To me, even the session that I chaired, it had only 11 speakers. It was a very, very impressive and scholarly combination. So the meeting, as it happens, I think should be a matter of pride for the level of science that is prevailing now in the country. I think I'm very impressed, and I want to pay a compliment to the organizers and also to the president of the society, which is Professor Lohia. You know, another thing that I discovered very recently is a journal which he is editing. And here is the picture of this journal, the Journal of Reproductive Healthcare and Medicine. I think it's a very impressive journal, although a recent, it's only the volume 2 that I'm showing you, but it is something on which again, Professor Lohia deserves congratulations. And shabash, aisa kaam karte raho. till you can, or till any one of us can do. And if I am going beyond 95, I think he has to complete the century also, if possible. Now, let me say that my own interest in reproduction started when I was sort of member of the Executive Council of Banaras Hindu University in the 70s. I was a member of that council for 6 years, and every odd month we had to be there. And you know what I noticed was that in Banaras, where the people have very good features, otherwise looking healthy, but they are very thin. And their family members are even, very, very malnourished, so to say. And then, I asked them, what's the problem? Why is it Ganga Bharaya? It's the heart of the country. Why can't they feed themselves better? And it came out that what most of the people had in big families, and whatever they earned was too small to properly nourish all family members. So they were just, so to say, abridged under, really sort of condensed in a way, so to say. So I said, well, so many contraceptives were available and the government is giving free of charge. Why don't you use the contraceptive? And then they told me that, no contraceptive is really, which is available at that time, is worthwhile. They cause bleeding, they cause this, they cause that, and there are a lot of complaints about the side effects that the available contraceptives at that time were causing. So that made me think of developing a contraceptive which should be free of all these problems. And so, oh, sorry. So, oh, sorry. So you see, I thought of making a vaccine. Why a vaccine? Because it would not then need day-to-day taking. You take once and it will be for its efficacy will be there if it is effective for many months. And therefore it doesn't have the problem of daily use. Now, what sort of vaccine should we make? A vaccine has to be safe. It will be, that is an important demand for it. So therefore I had to choose a molecule against which an immune response should not lead to any problem in the body. So, I thought of using the human chorionic gonadotropin, or HCG, which the woman makes only when she conceives. And the reason why our pregnancy tests are based on the sort of analysis for HCG is because it's not there in the normal non-pregnant female. So therefore, that by itself was a reason why it should be chosen. Then it is no organ of the body obviously makes it, other than and it starts when the woman becomes pregnant. And then it is important for the implantation of the embryo, which means it is the start of the pregnancy for which HCG has a role. And then, of course, it sustains pregnancy in various other ways. So therefore, that is the reason why we selected this molecule. This structure is now known completely, and it's made up of two subunits, alpha and beta. This is what they are, alpha and beta, and this is the whole molecule when they are joined to each other, when they become effective. Now the subunit itself, the alpha is common to say 3 other or 4 other hormones. So therefore the choice for the vaccine was to take only the beta. And then, to make it as its self molecule, the body will not make antibodies against it. So in order to render it immunogenic, one had to tag it to a carrier. And I decided at that time to tag it to tetanus toxoid. Why? Because, it's a vaccine at that time. It was not compulsory, but it's a vaccine which gives protection against tetanus, and that by itself would be useful. It will be giving it an additional benefit. Now, then it was necessary to check whether my concept of linking beta HCG to tetanus toxoid renders it immunogenic in women, in humans. This is one of the experiments that we did at that time. And this woman, KW, made antibodies. Now we had to determine whether the antibodies are specific enough against HCG. So when you inject 5,000 IU of HCG, the antibody titers, the antibodies bind with it, and they come back to the normal after the thing is done. So there is regeneration of the additional antibody. So therefore, it's extremely, specific, and it is effective in neutralizing the HCG. And unless there is HCG, there can't be an implantation. And you see, the tetanus, it does nothing, so to say, and the carrier is carrier. Next slide will show you that you see the safety and the reversibility of the HCV-based vaccine was established not only in India, but in Finland, Sweden, Brazil, Chile, under the International Committee of Contraception Research of Population Council, and in India, obviously under ISSRF. And you see what it was evident is that it is completely safe, and it is all these publications report the safety, complete safety of the vaccine for the woman, no side effect of any kind. And then, it was taken to, of course, to a phase 2 efficacy study too. And what is amazing is that it is highly specific. These are the, these trials were held at the All India Institute of Medical Sciences, at the PGI Chandigarh, and then the Safdarjung Hospital, in these 3 centers. And you see, we had about 100 women who were, quite a few women were enrolled. This slide is showing the phenomena in 4 women. And as on the top, these dots are showing the menstrual cycles. And in every woman, no derangement of the menstrual cycles occurred. It was a complete regularity of menstrual cycles that was maintained. These were the sexually active young women of 30, 22, and they were all fertile. They had 2 pregnancies, so that was a proof that they can conceive. And many times, one of them had also an abortion done. The 2 of them had abortion done. So they are now keen to come to need or to ask for a contraceptive, and they very readily agreed, all of them. And when we had to conclude this trial, some of them said, Ajit, we will pay for it. Give us the booster if necessary. We want to remain vaccinated. But of course, this was not permissible. But this whole thing is published in one of the major journals, the Proceeding National Academy of Science in the USA. So it was a landmark as far as I'm concerned. Now, usually 8 women completed 30 cycles without getting pregnant. Otherwise, they are all fertile, no known fertility. 9 women completed 24, 12 women completed these many cycles. So for so many cycles, they remained unprotected from becoming pregnant at and above titers of 50 nanograms of antibodies per ml of this serum. Then you see the antibodies were not impairing ovulation. The progesterone levels in all of them indicated the ovulation taking place normally. There was no derangement of the menstrual regularity, nor of the bleeding profiles. It was absolutely normal. So none of the so-called abnormalities, that side effects that the other contraceptives caused, this particular vaccine was completely free of them. And in 1224 cycles, only 1 pregnancy occurred at 50 nanograms. So it was fairly fertile. And then, you know, if a woman wants another child, it is totally possible to have it. That was also tested. 4 women wanted another child, so we didn't give them a booster. And at the time that the titers came below 50 nanograms per ml, you know, she became pregnant and she became HCG positive. And then she had, all these 4 women had normal progeny, absolutely normal. And you see Professor Mehrbaan Singh, the professor of pediatrics at the All India Institute of Medical Sciences, in fact, interviewed all these women, and many of them she examined in various ways, not only the women, but the progeny, the children that they produced, these 4 women, and all the offspring was completely normal, was similar to the one which they had before they joined the trial. So it's a normalcy of progeny bonds. In other words, it's totally reversible if one wants more children. Then, you know, so many years I retired from National Institute of Immunology, as the rules are, and they gave me 3-4 years extra, but still, you know, one has to retire. And for many years, nothing happened. Then American Academy, as well as the Canadians, they asked me to revive the vaccine. And at that time, with the results in 2006 or so, I thought, why now make the old type of vaccine, which was with chemically purified ingredients? Why not go in for a recombinant vaccine? Because that is the era now. We are in the genetically engineered era that we are in. So therefore, this is the vaccine that we planned and made by the genetic engineering route. And this went through safety trials, extensive safety trials, because we had to obtain the approval of the RCGM. The RCGM is the committee which approves recombinant products. So it did obtain the complete approval of the RCGM, but it took 5 years of extensive and a variety of toxicology studies. What is interesting is that this vaccine was also quite immunogenic in mice. This is the bulb C mice. And you see 50 nanograms is the titers that we need to make the woman. Above that, she's protected. So all the mice made antibodies several times higher than the 50 nanograms. You see, we went up to several thousand, 6,600 nanograms per ml. So many times the titers necessary to protect. So therefore, it was all right. And in course of time, we, thought that we should restart the trial. I'm happy to inform you that ICMR has given a special grant to have a combined protocol phase 1, phase 2 trial on it. And the current status of the trials is that, having made it by genetic engineering route, we gave it to a company. Masters Bharat Biotech accepted to make it and supply to us for the trial free of charge. Now there are 9 women who are enrolled at AIIMS and Sargangaram hospitals. 5 of them have developed nodules after 3rd or 4th injection of this vaccine. And four of the women didn't develop. Why the 4 didn't develop and why these 5 developed, we still do not know. But this is the type of nodules that they have. And they heal, but in course of time, but they are inconvenient to see. So therefore, we have this in my laboratory, one of my scholar, Priyanka Paul, and Kirti Nan, this have started studies in mice. And of course, in mice too, if you give the vaccine intradermally, there are nodules which are produced. And but if you give the vaccine intramuscularly, none of the mice had any nodules. Otherwise, they also form nodules because I think we have used MIP, Mycobacterium indicus prani, as an adjuvant in the vaccine. This was the vaccine that we made for leprosy, against leprosy. It is already approved by the Drug Controller of India as well as by the US FDA. And it is the only vaccine for leprosy in the world which has the approval of many drug regulatory agencies in every country. What is it? Another very interesting property of this vaccine is that it's a very big invigorator of immune response. It also protects against tuberculosis, and it has an even immunotherapeutic action on category 2, difficult to treat tuberculosis patients. And then Professor Somesh Gupta et al. In Nature of Medical Sciences gives it to treat the genital warts, very ugly genital warts. They are healed completely by giving MIP, the adjuvant that we use in our vaccine. Whether we should use all the 4 doses, I think is open to issue. We are examining currently in experimental animals whether limiting the adjuvant to the first DNA version of the vaccine or the first and first protein version of the vaccine would suffice as an adjuvant. Of course, we don't have yet the final results on it, but maybe if we do, then even the inclusion of MIP in every injection could be avoided. So another very interesting and important, as I was hearing, there was cancers also. Even Professor Bandari spoke about it. And what is very interesting is that at a advanced stage, many cancers start expressing HCG. So HCG is not only made during after a woman becomes pregnant or after she conceives, but you see the advanced stage, difficult to treat cancers also express HCG. So and what we have already tested before the vaccine was made, we tested that if we have a monoclonal antibody against HCG, and if we link it to haldi, curcumin, all such cancer cells are completely cleared off. You see, this is the lymphoblastic leukemia, and if you put in the antibody, which is the PIPP, of a monoclonal antibody, and link it up with curcumin, every cancer cell. So therefore, another advantage and another utility of this vaccine would be in such cancers. And I think as they are so difficult to treat, I think it will be another very good thing too. So therefore, the vaccine has the potential of not only of immunotherapy of such cancers, in addition to protection against leprosy and tuberculosis because of MIP as adjuvant. And if we are able to make enough antibodies, it will be very protective against pregnancy without any side effect at all that we usually observe with the contraceptives. And I think this is a summary of what I'm currently involved with. And it is my hope that before I quit this world, this vaccine will also be there for everyone to use, not only for providing as a contraceptive, very good contraceptive, but also against cancers. Thank you very much.
No words to express our feelings, Professor Talwar, and we salute you for your determination, and all of us wish that you come out with your dreams come true in very near future. The studies which you are conducting, which are completing phase 1 along with phase 2 clinical trials, with the support of the ICMR and drug regulatory agencies, you restart with your effort, and we look forward that at the earliest possible you complete phase 3 clinical trials and this comes as a product in the market. So with this brief, I would now request our dignitaries to join the ISSRF, which has generally been a tradition, and Dr. Sarma, Secretary, generally joins the President, but from the screen itself, I would request him that he is a part of it. And we would like to acknowledge the contributions being made by the team. And to start with, I would first say that there is one Dr. Prasant. Can I have a screen for this? Sir, Dr. Prasant, and he is currently in Amrita School of Biotechnology, Amrita University, and you would be very pleased to learn that he was supposed to come to Jaipur to facilitate our efforts of organizing the event, but the whole family, his wife, children, got trapped into the omics. What is that? Omicron pandemic infection, and because of that he couldn't make it. But from here, on behalf of the ISSRF, we express our great appreciation, Dr. Prasant, for your valuable contribution to the success of this event. Thank you so much.
Thank you so much, sir. No, it's always a great honor working with you.
Recovery to his family.
You have
His
been,
speedy recovery to his family.
Yeah. And he has been instrumental in sending all the documents and responding to all queries and ensuring that if there is any pitfalls here and there, he was taking care. Then we have another contribution from Nidhi. And Nidhi, you must have seen that the all proceedings for 3 days, she comes here at 8:30 a.m. and stays till late after completion of the proceedings. So Nidhi's contribution, she is currently working at Birla Institute of Scientific Research in the Department of Biotechnology, is a woman scientist, and we greatly appreciate her contribution. And the society, on behalf of the society and on behalf of all of us, we compliment her and we convey our appreciation for her contribution to the success of the event. Then you must have seen Dr. Barka, and this is the time I must convey that the starting from compilation of all the submissions in the form of abstracts, preparation of what you say, what you say, the no, that what you call scientific program compilation, and designing of the website, and everything related to what you see today is being contributed by Dr. Barka. And I have no words to appreciate her inputs in making the today's event successful. And I would like all of you to say a big thank you to Barka for her contribution to the success of the event.
Thank you so much, sir.
And finally, I would like to compliment Professor Ansari, and as a convener तो नाम का है, ऑर्गेनाइजिंग सेक्रेटरी भी हमने नाम दिया है, पर उनका कंट्रीब्यूशन तो इतना इमेंस है कि वो कभी उन्होंने समय का नहीं देखा. And from every point of view, looking into every aspect of the event, and they immensely contributed to see that everything goes very smooth. And this all appreciation is on behalf of all dignitaries, all participants, all guests, and on behalf of the ISSRF. And we hope that their contributions will go a long way, and we will remember that the success of ISSR 2022 is mainly and basically because of this teamwork, which resulted into today, the day when we all hope, we all go contented about the oral scientific deliberations of the event. With this, I would now finally request Dr. Barka to propose a vote of thanks.
A very good evening to all. At the outset, I thank our honorable chief guest, respected Professor G.P. Talwar sir, who at such young age of 95 is source of inspiration for each one of us. It has always been a pleasure, sir, to listening to you and attending with you conferences of ISSRF. Thank you, sir, from deepest of my heart for your kind presence and blessings. And now I extend my gratitude to our guest of honor, respected Dr. Sudhir Bhandari, sir. Sir, it has been a great pleasure of us that you can take out time from a busy schedule, and you have always been active participation in taking care of health services at the state of Rajasthan. Thank you, sir, for gracing the occasion with your motivational words. Now I take this opportunity to extend heartfelt gratitude to my mentor and mentor to many mentors, respected Professor Loya, sir, for entrusting me and providing me with the privilege of organizing this international conference. Under his stalwart leadership, it has been possible for me to arrange everything. Thank you so much, sir. I extend special thanks to Professor Ansari, sir, for his guidance and valuable inputs. from editing the newsletter, abstract book, to overall organization of this conference. Thank you so much, sir. I'm truly indebted to Dr. Prashant for his constant support towards the perfect logistics throughout the conference. I must also acknowledge efforts of Ms. Nidhi for conducting the proceedings so nicely. I also acknowledge the support and work done by scholars of our lab, Ms. Demanshi, Sonu, and Rajiv. And in the last 3 days, we had very exciting and scientific deliberations. On behalf of the organizing team, I convey my sincere gratitude to all the distinguished speakers and delegates for enriching us with the knowledge of the remarkable research work. There has been a galaxy of scientists conferring on various awards during these 3 days of the conference. Their presence and kind contributions are deeply acknowledged. At the last but not the least, I thank my family, especially my son, without whose support it would not have been possible for me to complete this Herculean task. Thank you one and all. I hope you'll keep blessing me and we'll have more zeal and zest to make this conference and other activities of ISSRF a great success. Thank you so much from all.
I think with this we come to an end of 3 days ISSRF 2022 event. And I would say very goodbye to everyone. And we will be in contact with each other, and we will convey you and communicate you and send you the subsequent details about the proceedings and other documents of on behalf of the society to every member of the society. And again, a big thank you to everyone.
Before we leave, 3
Sir.
cheers for Professor Bhaiya.
Yes. So nice of you, sir. And it's all blessings from every one of you and a valuable contribution made the event a success.
I would request all. I would request everyone to switch on the camera so that I can click a last picture, please.
You can appear on the so that there could be a photograph, and which we would like to put it in the next newsletter of the society. Oh, I could see Professor Surendra Sharma as well. So great. Leo, कैसे लेंगे? Screenshot लेते हैं? Prashant will do. Prashant, are you taking the screenshot?
Yeah, मैं ले रहा हूँ sir. Yeah.
Professor Loya had muted my audio and video.
Once you also appear.
Yes,
Sunita Mittal Madam, Seema Rai, please switch on your camera. Sono, A.K. Mohan, Anju Jain. So nice. Please switch on your camera. So a beautiful picture will come. Barkha is not seen. हो गया?
I think everybody should turn on their
Sunita
camera.
Mittal Madam, Professor Sunita Mittal, please switch on your camera.
Yeah.
Great.
Sir, your team is behind the screen,
So
sir.
you can expose now. You can click or what?
Yes, sir, your team, Barkha is missing.
A screenshot.
I'm taking in 2 windows, please.
When it is done, please let us know. We cannot keep on smiling for long.
Sir, Barkha is missing, sir.
I would say 3, 2, 1.
Barkha is missing, sir.
1.
You could see Timansi also here. She is a scholar and she also contributed in number of ways towards organization of the event. So we acknowledge everybody's contribution.
Thank you so much, sir. Thank you so much.
Sir, congrats to the ISSRF team, sir, to was a good conference.
Congratulations, Dr. Loya, and my salute to you.
Dr.
Loya, and my salute to you.
Pleasure having all of you and having your valuable contributions.
Congratulations to the entire team.
Yes, certainly we receive your compliments with pleasure. Source of encouragement.
Sir, it is you, sir. You are a source of inspiration. It is you, sir. You are a source of inspiration.
It's a pleasure, but एक चीज मुझे बहुत अच्छी लगी, वो पता नहीं कितनी पॉसिबल हो पाएगी, पर भंडारी साहब ने कहा था कि तलवार साहब आने वाले टाइम में यू विल टर्न इनटू तलवार साहब. Reason being, in terms of the commitment of science, I would take it in that spirit. That तलवार साहब का जो कमिटमेंट है साइंस के प्रति, वो देखने लायक होता है कि जब भी अपॉर्चुनिटी उनको कहीं मिलती है तो हमें सबसे पहले ये सोच रखा था हमने कि when he will be chief guest, we will say please give say few words. Few words means he will start sharing his slides and he will share his and Dr. Sharma is there and he did not say, he could have said, Radhe, don't delay. Before I say goodbye, let me complete it.
I was hoping the same, but I thought thanks to him.
And he makes so much emotional.
Yeah.
He said the journal he was showing, I must share with you, the Journal of Reproductive Healthcare and Medicine. He contributed one recent article about the ongoing trials as well as his experience of dealing with the mice model about the nodules formation and how it can be addressed. So when he was saying, भाई निर्मल जी जितना जल्दी हो इस मैन्युस्क्रिप्ट को पब्लिश करना है, तो मैंने कहा साहब जो प्रोसीजर है we will send it across to the experts and we try to get the comments as early possible and we receive the comments, send it across for revision, and when we received the revised manuscript, he was following it up and when it appeared, he said it has come up very well. I would all request that if you can log in the Journal of Reproductive Healthcare and Medicine, you would see that manuscript has come very well. And I would again repeat my request, all of you, please make it at least one article contribution to the journal. This is society official publication and your contribution will strengthen the journal. And specifically all those who are awardees, we expect one contribution from them, all of them. And again, repeat, society is all of us. And when you encourage your scholar to become a part of it, then it will, we talk about how to encourage young scientist participation. You must appreciate that this year, definitely there has been a greater participation of the young scholar, and Professor Kamboj has always been advocating for it, that try to do something where young scholars are more and more given the opportunity, and this is being done. And we hope that as being given suggestion, we'll try to make provisions for larger participation, further larger participation of young scholars in times to come. So, अभी इच्छा नहीं होती है कि अभी अपन गुड बाय करें, पर
Thank you, Professor.
I think
Thank you very much. Thank you very much.
Thank you very much.
it is time to say goodbye. I see.
And Professor Loya, you should take your team for a party. Loya, you should take your team for a party.
Yeah, certainly. I agree with this. आपने वो चीज कह दी जो मैं सोच रहा था.
मैं सोच रही थी किसी तरह स्विगी कर दूं.
आज बिरले टू मालदी हैं? लोया बिरले टू मालदी.
Yes, no problem.
What is that?
Tell it to me. Yes, no problem.
See, always willing. ठीक है?
Congratulations.
So look forward our continued association and all the best to everyone.
Thank you, sir.
Thank you.
Bye.
Thank you very much.
Bye. Bye.
Bye now.
Bye.
So blessed.